procedure. So till now, we have done about 45 PCIs using this route with direct guiding catheter approach, which consisted of 29 males and 16 females. The guide size that we used was 7 French in 6 of them. And in 3 of these patients, we did a left main bifurcation with kissing balloons. And for our Indian colleagues, I mean, we all know that we many times have to use used balloons, and we can't really do kissing balloon and all from a 6 French catheter unless there are smaller size and newer balloons. So this allows a bifurcation procedure to be done with a 6 French size puncture. So what 6 French size you would have used otherwise, using the same size of puncture, you can do a left main bifurcation. We did not have any problem with radial artery occlusion. There was a considerable procedural difficulty in 2 patients because of spasm, because we know that it can occur even when you're putting a diagnostic catheter of 5 French, it can happen. And there was not a single procedure needed a switch over to femoral because of inability at any stage. Now, I'll lastly mention about the other way if you don't have a railway system.
Until I think we have finished the time. We'll have discussion during the live case also, if you don't mind.
I'll just show one slide maybe.
Okay.
So the principle remains the same, and this is the crux of the matter. What happens in the glide slender sheath is that the sheath thickness is reduced from 0.20 to 0.1.
Next talk is on this same thing, sheets. The Dr. Shaukat will show these sheets and the other things. If you have to show one slide, sorry, you can go ahead. Otherwise, next talk.
I just thought I would just. So I think rest of this thing is just data. So I think I will skip that. And this is just the last slide showing that you can have a much smaller outer diameter of slender sheath to perform the radial procedures. And if the next probably talk would explain that. So sometimes small could be safer and satisfied. Thank you.
Thank you.
Okay, thank you so much. I think just because we are practically now late, we have to go ahead, and Dr. Shaukat will just make a next presentation according what is GCC and how GCC can help us in daily routine. Welcome.
Okay, thank you. Good afternoon, everyone. Thanks for, can you see my screen?
Yes.
Yes.
Oh, thanks for the organizers to give me the opportunity to talk on radial access chip PCI by the use of glide sheath slender. My previous colleague nicely demonstrated how a difference between the sheath and the catheter sizes, the outer diameter of the catheter size is equivalent to the inner diameter of the sheath. And when you talk about a 7 French sheath, it's essentially... No?
Mute all other mics, please.
Yeah.
Please go ahead.
Yeah, so when we talk about the sheath size, we normally mention the sheath size, 7 French sheath is equivalent to the inner diameter of the sheath, whereas the outer diameter may be around 1.5 French to 2 French, higher than the mentioned size, depending on which company you use. So obviously, when you're using a 7 French, it's around 8.5 French outer diameter. So just briefly to show how the radial access has improved over the years, this is the slide, just a simple British Cardiac Intervention Society slide back in 2012, telling that the access site has moved from 10% of radial to 65% in 2012. I'm sure this is going and going and going. So in the same 2012, we published our data about transradial rotablation in a patient with dextrocardia and acute ST elevation myocardial infarction. So this is this is the time when the chip was not even coined back in 2012. There's a gentleman, 80-year-old guy with a heavily calcified right coronary artery in a dextrocardia, coming with an ST elevation MI, which is thrombolized in the local hospital. But those days we didn't have intravascular lithotripsy, and even though it's a large artery, we went with a 2 mm burr and rotablated it, and this is what the results we got. So why do we have to use radial access in chip? Of course, we all know people are moving towards, but when it comes to chip PCI, people are still not keen to move on to radial. But I think there are certain reasons why we should be thinking about radial access. First is if you use your radial access in a complex cases, you have a good femoral access on your both sides to use your Impella or ECMO or intra-aortic balloon pump. In cases like CTO, where you want to keep your ACT above 300, 350, when you go femorally, there is risk of bleeding is extremely high. And that has been told by my previous colleague as well. So why actually we should not be using radial access? I think we should probably think radial as the first choice in most of these CHIP PCI. So you remember, when we talk about CHIP, we talk about either the complex coronary anatomy or the other patient's factors. If you think the complex coronary anatomy is the issue, then you can consider femoral. But I think most of the time we can get away with radial. But if you have other issues like LV dysfunction and so on and so forth, you should actually go for radial straight away, even if it's a CHIP PCI. So, I mean, I don't want to dwell on this. We have enough data so far starting from RIVAL back in 2011, and then RIFLE ACS showing that the access site bleeding is significantly reduced, around 47% reduction in access site 30-day bleeding rate with radial compared to femoral in ACS patient. And coming to CTOs, this is a registry from the European registry, the Recharge registry, including around 1,200 patients from different centers, looking at their CTO, totally radial, biradial versus femoral. What they showed is if your JCTO score is anything between 0, 1, and 2, there is no significant difference in the success rate of your CTO. Even in 3, there is no significant difference, even though numerically it's slightly lower. But if your JCTO score is higher, the femoral access is better. So that's what this shows. This is another data from the North American registry about the same CTO. So they suggest that they either fully transradial or femoral with radial or fully transfemoral. They showed that the success rate of the outcome is the same, whereas the bleeding rate is extremely high. We use the femoral access, whereas in the radial access is extremely low. So I think we have enough data to show that radial is kind of equivalent to femoral access in most of the patients we deal with on a day-to-day practice. See, as my previous colleague just briefly mentioned about the glide sheath slender, essentially the advantage of this sheath is actually the 7 French sheath has got an outer diameter which is equivalent to a 6 French normal sheath. That's the basic point you need to understand. When you talk about 7 French glide sheath slender, the outer diameter of the 7 French glide sheath slender is equivalent to a 6 French normal sheath. So if you're doing your PCI with a 6 French normal sheath, you can always use a 7 French slender sheath to do that. So by doing that, what is happening is it improving your inner diameter opening nicely for your 7 French guiding catheter to go very smoothly inside your coronary arteries. As we know that most of the complex PCI, we prefer 7 French, particularly in radial, because it gives us more support to deliver devices in positions. So, but there are certain things with this slide that we need to be aware of about, because it's so slender, the thickness of the cover diameter is slow. It also has a slightly higher chance of kinking, but you do have to have some tricks to avoid that happening. So let me show some of my cases, which is what the main theme of this, to how my glide sheath slender has helped me. So this is one of these early cases of transradial rotablation with OCT guidance in a 7 French slender sheath and a 7 French guiding catheter. You can see the calcium in the LAD. The OCT nicely showed that calcification, and I straight away went with a 1.5 millimeter burr, around 175 rotations per minute. You can see the burr going in, and then deploy the stent. So it's kind of a reasonably simple form of CHIP PCI, if you want to call it as. So where the rotablation, the rotaburr went very smoothly from that. So this is another gentleman, 72-year-old guy who had a single kind of coronary artery, but actually the left system is coming from the right sinus, but the roof of the coronary arteries are the same. It's rising from the same roof. There is a tight lesion at this circumflex after the tortuosity, and on the pigtail catheter done in the hospital, there's not any left-sided system coming at all. So one of the things, advantage of this is because it's the right coronary, this is all is nearly a single coronary artery. You don't want to damage the ostium of the coronary artery. So this is the Amplatz guiding catheter I used. I put a wire to support on the right coronary artery and then went the other wire to the circumflex artery. And just to avoid this, I cut a guidezilla in and get the guidezilla all the way in deeply and then deploy the stent, thereby avoiding any damage to the ostium of the right coronary artery, which is because the right coronary artery is a major artery for the supply of the coronary artery. So another case, this is a IVUS guided DK crush left main PCI through the right radial axis. So you can see it's a Medina 111 classification, the obtuse marginal and the circumflex involved. The LAD has got a very tight lesion up to the mid segment. You can see this in this particular slide, you can see the S-shaped part of the catheter from the right radial artery, 7 French. So what I'm trying to say, even though it's an S-shape, the IVUS catheter went very smoothly. There's no issues. And I deployed the first circumflex stent and pulled back and ballooned it. And then you can see when you have a 7 French, it's always better to have a 7 French when you go for kissing because the balloons move very smoothly. And this is what I had. And they put the LAD stent and the double second kissing, and this is the final result of that. So you can imagine, even in very complex left main bifurcation PCI, you can use a 7 French guiding catheter very nicely and get your results, better results as such. And this is a very complex rotablation where when I try to do the right radially, the rotabur, whenever I want to bring my rotabur in, it just pushing the guiding back. So one of the tricks you can do is you can pass another wire into the circumflex and try to get the rotabur on the rotor wire to give us more support. When I tried that, it still didn't help. Then I have to use a guidezilla to just feed it on the rotor wire, kept the guidezilla in position, and then got the rotor through the rotabur through the guidezilla. And this is the rotablation done through the guidezilla, right radial axis in the 7 French sheath. So this is a 1.25 millimeter burr. It's a heavily calcified vessel at this segment. And I nearly got caught with entrapment, but then I have to pull it just gently with a higher rotating speed as such. So this is on the highly complex rotablation. They still managed to get through the right radial axis, and this is the last result of that. And in coming to CTO PCI, this is a biradial retrograde CTO, which I did in the lady CTO. Right coronary artery was nicely supplying the distal vessels. And so I used cyan through the antegrade approach, and then this went through the retrograde with the Corsair and managed to go with the SO3 wire and entered into the antegrade lumen. This is both biradial access, both sides. The patient was around 45-year-old guy, very cooperative, and I managed to get through that. You can see this nice 2 catheters coming, and then I got the RG3 wire and then ballooned on the RG3 wire and then went antegradally and finished off the case. So I think these are the important cases to show, even with the access of right radial with the slender sheaths, we can manage. This is the last case of my transradial primary, which is a very recent one. A 73-year-old gentleman, anterior wall ST elevation MI, LAD occluded, as you can see here, heavily calcified vessel. There's no flow, and when the wire passed through, and I could manage to balloon the proximal segment, but what I was there happening is the distally I could not get any balloon. There's a very tight lesion there, and I could not get anything beyond that segment despite my effort. So I have to use a rotablation. So the occlusion of the proximal segment, but this segment was not giving away with any balloon, even the 1 millimeter balloon. I didn't have a 0.85 on the stock at that time. Yeah, so I think that's the last case, and then I put a stent there. Just to quickly last a couple of slides to show that, yeah. So one of the things when we talk about slender sheaths is when you put your guide lead center, the first thing you'll notice is the slender sheath will look above and in an around 60-degree angle above it. So when you're trying to push something, be careful because there will be a high chance of kinking, but it's because so flexible at this segment. So one tip I would say is normally put a tegaderm band just to fix the sheath in position, because normally we don't normally put sheaths on the transradial. I don't put for my normal sheaths, but in this sled sheath slender, definitely you have to put a thing because it's so slippery and you can come out when you exchange the catheters as well. So, and also I would say that you have to use a radial arm board, because when you're going by radial, or if you want to switch over to a IABP on the left femoral, it's better to have a radial arm board than your long things. So I think in conclusion, radial chip is feasible in many patients, but not for all patients. You all agree with that. There are certain cases you have to go femorally. Know your kit and keep it ready in the cath lab. Plan your strategy ahead, including the support devices and bailing techniques, and feel free to switch over. The most important thing that you don't want to keep going on and on. You have to feel free to switch over to femoral if needed. Thank you for listening.
Thank you, Shaukat, for telling that last point also. Sometimes youngsters keep on chasing, and it's as if it is a crime to go to the femoral. I don't think it is the right approach. What is required for the patient and keeping the patient safety in point of view, we should do our best. I think that point is highlighted. Regarding the advantages and disadvantages of each of that catheter versus the sheath usage, we'll discuss at the end. I think we can invite the next speaker, Dr. Farang.
Yeah, thank you. Maybe just one question to the to Dr. Rafal.
Yeah.
What is your usual heparin dose if you go by radial approach?
Yeah, so normally I go with 100 units per kilogram for the patient's weight, and then do ACT every half an hour and just upgrade it accordingly.
So we usually in our center in Europe, we give 5,000 units heparin, and if we for angio for diagnostics, and if we go for PCI, then we adjust the heparin dose after ACT. Okay, so we go ahead with the next presentation. This is Dr. Dougal.
Dr. Nagendra Chauhan is doing it, sir. Vascular access site management and ideal patient site for a smooth muscle for a site vascular closure devices. So, Dr. Nagendra is joined.
Hello.
Yeah, Dr. Kumar, how are you?
Yeah. Please go ahead.
Okay, so I will share my slides first. And thank you, Dr. Shikumar and Dr. Farang, for inviting me for this nice meeting. So I have no disclosures for this presentation. So my presentation is mainly on vascular access site management and suture-mediated vascular closure devices. So as preventions for coronary arc can be done through radial access. So vascular access closure was initially not that important once radial came, but after structural intervention gaining speed, now it is very important, equally important for, I think, for coronary also and for structural also. So most important to recognize is that once you are going for femoral vascular access especially, then because of the newer technologies, now we are worried about tower and mitral valve and all those kind of things. And the basic thing is puncture, and generally it is underrepresented, and it is the major cause of complication. So most important thing is to assess the vessel size, and then you should know that what kind of intervention you are planning and for which what kind of sheath you have to use for devices to be inserted, and what is the size of that sheath. So that's very important to assess that complications because of vascular access are the most common complications, like in tower. Partner B trial data was shown in even 2010. The maximum complications were happening because of vascular access, because we are going with the large bore devices. Initially, they were 22 French, 24 French. Now, with the advent of newer technology, now they have came down to 14 to 16 French, but still they are quite big for many small size patients, and that causes complications. So you have done the major procedure, but there was a major complication of femoral access, and that can be dangerous sometimes even for life. The small hematoma gradually developing overnight may cause sleeping hypotension, and patient can die because of that also. Definitely, intraperitoneal hematoma is a major complication, and generally we can prevent that. But even small hematomas because of minor bleed are dangerous, so we should prevent these complications. And to prevent this, the most important thing is that we have to select the right patient. So for patient selection, it's very simple. That generally female patient, old age patients, patients with peripheral vascular disease and calcification are the patient in which complications are more common. If we are using a bigger size devices, then complications are more common. And definitely you need experience to use these devices and closure access sheaths for closing the vascular access. So the simple rule is that your stiffness artery to the sheath ratio should not be more than 1.05. If it is more than that, chances of complications are much higher. Although in younger patients with smooth arteries like this one, you can go up to 1.1 ratio, but with patients with heavily calcified artery, you have to you should not underestimate the complications, and the ratio should not be more than 0.9 or 0.95. The other important thing is you have to decide what kind of sheet you are using for the procedure. Like for tower, we are using a 14 French sheet commonly, which is expandable. 14 French sheets, internal diameter is 4.7, but generally external diameter is almost 5.3. So you should know that you need a 5.5 size vessel for that. So any vessel which is less than 5 is not a good idea for these things. And any vessel which is between 5 to 6 is borderline. You have to assess calcium and then decide. And more than 6, definitely you can go ahead and do it without any problem. So this is very important to understand that what kind of procedure you are planning and what kind of sheet is required for that. So most important is femoral access. So for all kind of advanced procedures where just simple imaging, so always go for a CT first, and on the basis of CT decide what is the size required. Like in this patient, the femorals are reasonably good, but aorta, the level of aorta size is very small, just 3 millimeters. So this can be a good case for any kind of large access devices like tower or any other procedure. Another example, similar situation, heavily calcified arteries with small size, so they are not good. So it's very important that you should select the ideal access for successful closure of the vessel. So what is important is to puncture at the right place. That is the first important thing. So for puncture also, now what we are doing is we are going by CT scan. We are assessing the calcification at the level of puncture and above. We are assessing for the plaque at that level, high bifurcation if it is there, and location of branches. So it's very important to assess all these things, and not just by the anatomical landmarks which were previously used, like the inguinal crease or inguinal ligaments, because sometimes the bifurcation can be very high or very low. So although this is good for coronary access and coronary intervention, but for large bore accesses, this is not a good idea, because in multiple trials it was shown that generally the bifurcation is below the ligament, but it can be high or low. So most important thing is to assess that where we have to puncture. So most important understanding is to assess where the inferior epigastric artery is going. So this is inferior epigastric artery which is going around the inguinal ligament. So this is our upper margin, and the bifurcation is lower margin. But definitely we don't want to go below the head of femur. So ideal area for puncture should be in the middle of the head of femur. And how this can be done? What we do routinely, if there is no kidney issue, then generally we puncture contralaterally with a small 5 French sheet, go crossover, and then take a shoot. And on this femoral axis, we puncture in the middle of the artery. So the artery puncture is done with access, so we can clearly see it in a zoom mode, and puncture is done in the middle part of the artery, so that will not have any problem, because we are going for large bore accesses. So this puncture is very important. Other important technique is, like, if you don't want to go contralaterally, then micropuncture is a very good idea. So this is just an example of micropuncture. You can see that puncture was quite low. This is just a 4 French or even less. So even if the puncture is not at right place, you can remove it, just press for a few seconds, and then you can take another puncture, and this is another puncture taken. And now you can see the puncture is at the middle of the head of femur. So this is also a possible option. And micropuncture is always better because the size is very small. And if you go by size, although it is almost 2/3, but if you go by the blood loss is much, much less. You can see if the larger size normal puncture lead is taken, blood loss is more than 6 times. The other option is ultrasound guided puncture, which is also a very good option if you are comfortable with it, and then you can reduce complications by significant amount. So either microvascular puncture or ultrasound guided puncture or flow guided puncture. So it has to be a guided puncture. If you're using a guided puncture, then problem is not there. In terms of suture mediated vascular closure, there are 2 devices available. One is ProStar, another is ProGlide. ProStar is mainly for punctures which are more than 10 French, and ProGlide is used even for punctures from 6 French to even 21 French. Only thing is that you have to use it as pre-closed device, and you have to use multiple ProGlide. ProStar is not very common. We have used in 2-3 patients, but it's slightly more complex and takes a longer learning curve. I think ProGlide is most suitable and most commonly used all over the world when it's used as pre-closer. Although there are so many new devices available now, I will not go into details. I will go just on the most commonly used things. So most common thing is you have to be sticking to the common femoral artery, not into the branches. So it's very important. Best is to go by ultrasound guidance or micropuncture. Then use a pre-closed suture-based device. If it is more than 8 to 10 French, you can use 2 devices. Up to 14 French, 2 devices are sufficient. If you're going more than 14, 16 or 18, maybe 3 devices are required. So everything depends on how much size you are using. What we are doing is routinely for 14 French, we are using 2 devices. And if it is not fully closed, a 3rd device can be used. The most important thing is once we are removing it, wire should be kept inside before we are 100% sure that closure is successful, and then it can be removed. And a last DSA check is always a must to confirm that there is no problem. So pre-close, how to use the ProGlide device as a pre-close is very simple. You go conventionally with the simple puncher first, and once you are coming out, at that point of time, it's very important that through the wire access point, wire should be pushed again, and over that wire you can use a second ProGlide. Generally we use around 40-degree angle or 35-degree angle for between these two nowadays. Previously we were using 90-degree angle. So two devices are to be placed in different angles, so that once you close, the sutures are in different alignment, so that will close it properly. So most important thing is, once you have done it, you have to check with an angiogram also if there's any kinking or any dissection or any obstruction that has to be relieved. Like in this case, there is some obstruction at the point of puncture site, which was fixed with just a balloon dilatation, and patient was fine with balloon dilatation. So these kind of complications like dissection, like spasm, like obstruction can happen. Once you check it, you know that there is no issue. You can fix it. There can be small bleed, which can be stopped with just pressing, or there can be larger bleed, which may require surgical access. So most important thing is, if we are deploying with two devices and we have deployed the two devices after doing the procedure and still there is a bleed, what to do? There are multiple ways you can use another ProGlide if the bleed is not too torsional. And what other way you can do is, you can put a small 6 French or 8 French sheet. If 6 French sheet is closing the leak, then a vascular closure with an angio seal can easily be done. If it is more than 6 French, 8 French, you can try a third ProGlide device that can also close it. If it is more than that, then definitely surgical access, such closure is required, and you should call the surgeon. The one small thing is about, in a large vessel access closure, how to use a ProGlide as post-closure, not as pre-closure. So if the access site is large, what you can do is, you can put two wires with the help of a bigger size sheet, and then use these two wires as access sites for two pre-closed devices, and they can possibly close this large access even if you have not used a pre-closure device. So this is how this can be done. This is just to understand that you have to put two wires will be at the two different places, and they will give it two sutures to two different parts, and they will stretch the hole so it will not be that big to cause any problem in suture holding. So just to summarize, what to do to decrease complications, access using fluoroscopy or ultrasound. Needle entry should be in the central line and on the femoral head. Femoral angiogram, regardless of
So I have impression we lost our speaker.
Any problem? Anyway, most of his talk is done, sir. He came to the end of the lecture. One thing interested, what he was telling was without pre-closing, post-closure with two wires. Did you try any time like that, Farang?
Yes, sporadically we do this, but we usually, I personally,
I think I was
in TAVR procedure, I use Manta system, which is very nicely working, but you have to pre-select the patients very nicely. I think if you go with ProGlide, you have the benefit of ProGlide is you have still the wire in position, and if there is still some bleeding, you can go even with additionally with a new ProGlide system, or you can use 8 French angio-seal system to stop the bleeding. So this is a benefit of ProGlide.
And Nagendra, you came back. Huh? You want to say anything in the close?
Yeah. I think there's just one slide left, so it's okay.
Yeah, just you can conclude saying it. Otherwise, stop sharing. And
I will just do it. Okay, I will just do it. So, as Dr. Farang was saying, that we can use all these other options for closure, like we can use an extra ProGlide or angio-seal if there's a bleed. And there's no hesitation in calling a surgeon if there's a major bleed, because this is a major complication. If it happens, it is a major problem, and we should not hesitate in calling our surgeon friends if you feel that there is a bleeding issue. So I will just come to my conclusion slides.
This is important point. We are really very happy in our heart center Freiburg Bad Krozingen. In our center in Bad Krozingen, we have a very, very potent, very good angiology department. So we usually ask angiology guys to stand, cover stand, whatever, and then surgery, vascular surgery is practically in background, but usually we use angiological way to.
Angiologists. We call our vascular surgeons mainly for any problem, and they generally fix it very well. Sometimes they use covered stand, otherwise they fix it surgically. So with this, I want to conclude that vascular closure is a very good option. You can embolize patient very early. Patient satisfaction is much better. There is no scar, so you don't have to worry about scars. So all kind of advanced procedures, we should use this more often. And once you are used to it, you can use it for all these with all the confidence. So I think we should use it more often, even in our angioplasties, so that you will be confident in using these devices, and then you can use it for large access closure also. Thank you.
I think we are seeing in between live cases coming. Before that, we have one last lecture by Dr. Samir Dani, how suture-mediated vessel closure devices change my clinical practice, experience in large hole cases. Dr. Samir, we can restrict for 10 minutes so that we can go on time to live cases. As he's joining, yesterday, other advantage of Manta, what they have shown in the live case, sir, is a single device itself. You can close holes as up to high, as bigger as 20 French. That was other advantage which is quoted with Manta. Only single device, you can close up the larger French holes also.
It is, that's correct. It is like Angiozyl-like device, but not really the same. But we use it practically in TAVR procedures or after impeller use in CHUT patients. Okay, so I think we should go ahead and start next presentation.
Yeah, is Dr. Samir ready? I see him logged in already.
Dr.
AV
Samir?
team, can you connect to Dr. Samir Dani? They are about to go to live cases, I think. We'll just finish that lecture and the session will end. We'll go to live case.
Okay.
Oh, they're already connected live cases.
Sir, Dr. Samir, I think he has left out of the meeting.
You went to the other hall?
No.
Okay, then. We can discuss on this closure devices. If any of the other panel members, I see Raghu, Jabir and others joined. If any comments, otherwise we'll continue the same panel for the live cases too. Raghu, do you want to say anything? Jabir?
I just want a very small question. So Dr. Farang, if we are using these newer devices like Mammoth, then is it possible to repuncture the same site, or you have to, if there is some emergency required, then you have to go to other site, or you can repuncture it like we can do in suture-mediated devices?
If we go for TAVR or if we go for protected PCI, we usually try to get in upfront angio-CT to understand really how is anatomy in the pelvic region, how is abdominal aorta, how it looks, and then we usually on regarding to this information and to the diameter and how is the plaque distribution, we decide which device we finally take. What I personally do in all TAVR and all femoral accesses, I always use ultrasound puncture. So all my femoral punctures are ultrasound guided, and so that it means practically your complications rate is extremely low. So if you go with ultrasound, this is very beneficial. And then according to the anatomy, then you decide where to perfectly make a puncture, in which angle, and then you can also decide after ultrasound check, you can decide either you take Manta system or you take ProGlide. And what we have practically always contralateral injection, as Dr. Nagendra perfectly showed, then to check in DSA technique how the puncture site looks. So the patient should leave cath lab with really safe, 100% safe growing puncture site. This is very important to avoid later on very dangerous complications.
There are no further comments in this.
Just one small question. Yeah. Okay.
Yeah. Go ahead.
So one small question is regarding. So if you use this glue-based devices like Mementa or AngioSeal, can you repuncture the same site? How much time is required before you can repuncture the same vessel if required?
Yeah, normally you have to wait, normally you have to wait around 10 weeks between to go in next procedure to use this puncture site. What you can do if there is emergency case next day, you can again go with ultrasound puncture, go 1 centimeter, 10 millimeters up or down, and then you can, from my perspective, also make a safe puncture if there is no option to use another growing.
That's right.
Okay, thank you.
Thank you, sir. Thank you.
I think we have that demonstration of radial access through the railway catheter by Rahul Gupta from Mumbai. Then we'll briefly see that and then go to MS Hiramat sir is ready to demonstrate a case. Can you connect Mumbai first, Dr. Rahul Gupta? Ujjwal?
1, 2.
Yeah. We are able to see Rahul. You can go ahead. Dr. Rahul, can you hear us?
Gauss spaces though.
Dr. Rahul, we are able to see and hear you. You are live?
This is fine.
Usual, they are not able to hear us.
Right? Oh, just still.
Railway system दो इधर और guiding भी इधर ले लो. We'll demonstrate from here.
Okay.
Rahul, we have Dr.
Live view जाना पड़ेगा ना सर? निवास को अंदर बुला लो.
Live view?
Please inform them that they are live.
Yeah. ठीक है. ये इसको फोकस करना है. उसको नहीं करना है. इसको कुछ नहीं करना है.
Dr. Rahul, you are live.
They are not hearing us. It looks. Ujjwal, can you inform them?
उसको ठीक से फोल्ड करके रख दो.
Remove the slide. Let them. Let the video be shown. Yeah, that's better.
ACT के लिए ले लिया?
Who can make a comment to this video?
AV team, can you check why they were not able to hear them? We are able to hear them, but they are not hearing us.
Checking on that, sir.
If there's a problem here, then we'll go to Pune first, see sometime, then come back here. But we can see them. I think only the mic issue can be corrected.
बलून जो भी मैं मांगूंगा साइज का तो गिव मी अपना स्प्रिंटर का बलून, मेट्रॉनिक का बलून
2 millimeter.
Hello?
Yeah, hi.
Yeah, good afternoon. We are able to see you well since last 2-3 minutes, but probably you are not able to hear us. We can see you and hear you well now. Please proceed.
Thank you very much. Thank you. Good afternoon. So, very warm welcome to everybody to our cath lab. Dr. M.G. Pillai sir is over here. Dr. Charan Reddy, my colleague cardiologist. Right. So what we'll do is we just present a brief history of the patient, and then I will go directly on the radial system demonstration, that how to access the radial easily through a 7 French if you want to use for complex intervention 7 French. So how to do it. So let's go to the clinical presentation. Dr. Charan will present it, and then we'll go ahead.
Good afternoon, everyone. I will present the short history of the patient.
Can you put the PPT?
Yeah. This is a 59-year-old male, a known case of diabetes and hypertension in the past 15 years, presented to us with a history of resistance chest pains in the last 3 days.
2000 heparin.
The ECG was done was suggestive of evolved and evolved MI. Today, echo showed hyperkinesia of the anterior wall with an EF of 35%. So we did the CAG, which showed critical triple vessel disease, and so we'll show you the angiography also. Next one, please.
So we'll discuss the angio. I think we can show the angio right now.
Yeah.
So can you please show the angio images? So these are the angio images, and if you look at the angiography, there is a CTO which we can see left, the OM CTO, and which is filling retrogradely via collaterals. Please keep running.
Please keep running. Please.
And yeah, so just stop this. So there's a LED which is, we'll show you in the LED diagonal view. If you can look at that diagonal which is coming out, please go a little back. Yeah, so there's a tight diagonal lesion at the, is a bifurcation lesion. Go to the next view, PA cranial view. PA cranial view, please. Okay. Yeah. So there is a recent, it looks like a recent total occlusion. There is some filling retrogradely of this LED. But the diagonal appears significant only in the spider view, where it looks very tight. And show the RCA. So this is the RCA, which is again very tight. So it's a critical TVD, and with the recent evolved anti-evolved MI presented as more of as an angina, and he came on in the OPD where we admitted him and did his angiography. So I think we can we can discuss the issues if we want. Otherwise, we can. Our idea is to access this LED through the left system to the 7 French system, because there's a bifurcation and there is a CTO. So we'll see how we have to address all these issues. But let us first focus on the railway system, which makes things quite easier whenever we are doing a 7 French access, because we all know that the radial artery diameter may not be in 50% of the patients, Indian patient. The radial artery is not actually sufficient to take the even the 6 French diameter catheter. And when we try to insert the sheath, they can go into radial artery spasm and a lot of issues. And when we talk about the 7 French access, it definitely difficult to the radial access. So I think we will just show you this railway system demonstration. We can go side by side PPT also if it is possible. So this is the railway system, and there are 2 dilators which come along with it. There is a O21 wire related hole which we can see through the, if you want to do a ad hoc, we want to do directly angioplasty, we can directly access the system through this. And then we have the O35 compatible the dilator, which is done when we are doing an ad hoc angioplasty. So there are 3 places where we can use this railway system. One is when we want to use a small bore access directly. We want to do the angioplasty directly where we know the patient. Otherwise, we want to increase our size of the guiding catheter, so we can actually do an angio with a 5 French catheter and then change it to the 7 French. So and the third part is to facilitate tracing. So sometimes if it is a tortuous artery, this railway system is really helpful. I found it quite useful while tracing into a tortuous artery anatomy also, and we can easily access with the thing. So let us go with the procedure. So we will be intervening. I think we can discuss the issue, and then we can also discuss. You can take the this thing. You can
small comment: if you are using a 6 French guiding, you need not give a nick on the skin. With the puncture needle or the 6 French or 5 French catheter delivery system itself, can go through that.
So,
Rahul,
yes.
The package has both of the things, but actually what we were suggesting to decrease to make it separate so that cost could come down significantly in our country, because cost is a challenge.
Yes.
Now,
yes.
one is an exchange device if you have to change and do ad hoc. Other is which you can do directly.
Yes.
So probably if it can be separated, also cost could decrease significantly.
I think I agree with your viewpoint. I totally agree with your viewpoint. So now what just for the sake of convenience, what we have done is not to waste the time in the radial puncture during the live case. We have already taken a 5 French access of our patient, and we will demonstrate that how to insert this catheter.
I think slides can be removed. You can make your thing bigger, because slide is not necessary. Yeah, please.
So this is that 035 access catheter. So we will first flush it fast, and then once we flush it and activate the hydrophilic coating, then we can we always
please show their hands, not the coronary angiofluoro bigger. They show their hands.
Can you please bigger? Focus the camera on the yeah. Can you show it fully?
Yeah. Okay.
Okay. So we are just we have access. Just give me this thing. So we have. Activated the hydrophilic coating, just did the flushing of the catheter, and what we are going to do is we have to always load it from the back side. So the hydrophilic coating is in the front. We are doing it, and this is the reason for doing this is that we don't want to disturb this hydrophilic coating, as well as we don't want to damage the tip. So this is how we go back. So
the taper is always on the front, and the blunt is always behind.
So we are going behind. There are 2 markers, one for the 90 centimeter guide, and so we can see the 2 markers which are there. And so we will go with these markers. So I'm just loading this system from behind.
There's no need to put a wire before you do that in the guide.
Yeah, so I don't have to put the wire. I have to, because I'm going to put the wire now into my 5 French system which I have taken. Can you focus on the radial artery? So this is the 5 French radial I've already taken, and once I have removed the 5 French sheath, I'm going to insert this. So let's do that. So we are pulling it till the time we get this black marker here. This is a 100 centimeter guide. So this is the first marker which is seen. So we have taken this out, and our system is ready to be inserted now. Dr. Pillai sir is now cannulating the, just wiring the radial through the 5 French. We have to take a double length wire whenever we are exchanging like this. So this is a double length wire, and we'll remove the sheath and insert this system, and then we are ready to go.
And because he's exchanging, now they're using the double length wire. But if you do directly, probably you can do puncture and put that special wire which comes with this, so that you can directly, what is previous lecture they have shown it. The wire can be put in, and you can directly take this catheter on that wire.
So there are 2 systems which are there. Now this is for the ad hoc one where we already have the 5 French sheath.
Yes.
Otherwise, if, as you are rightly saying, that we have this system, and it is very, very user friendly, very easy to use. Once we see this, I think it is it's quite easy. You can do it at the first go. There's nothing technically very difficult. So there is a rapid exchange port where we can do that. Can you push a little bit?
What we find, Rahul, is as Pillai sir was mentioning, when you are doing it directly, not this ad hoc way, it is better to give a good nick there at the site, because sometimes that over the wire to get the bigger catheter in, it could trouble and catheter could get damaged. Probably good nick after the puncture is important.
Can you just push this? No, not push this. Push the this thing. It has to be in the front. Yeah, and just hold the wire. Don't pin the catheter. So this is how we have gone. Just 1 minute. Okay. So this is only I think radial. If we are able to see, we are now entering. So let us go ahead. Yeah. Okay.
Yeah, Dr. Rahul. Good afternoon here from Germany. So what I see, you are twice. You are double guys at the table, or three doctors. And so it's a long wire, and so can you do this if you are alone, or do you need somebody who will help you?
No, only a staff nurse is sufficient. This is just for the live case purpose. We have 3 of us over here, but otherwise I've been routinely doing it alone with my staff nurse who's there to assist me. it is not that difficult. So it is quite.
But you definitely need somebody else.
Yeah, we need somebody. We need somebody to have these wire. Now we are just going above. So I am with the dilator as well as the guiding. I am going both.
You can show the fluoro screen now, because
can you show the fluoro, please? So could I show the wire a little bit back? Yeah. So I am till the subclavian. I am going with the dilator as well as, because dilator is also helping me to track the guiding. You don't need it, but it can help you in tracking. And then you can remove just the dilator. So now I am removing the dilator because my guiding has reached till the subclavian. So Dr. Pillai will remove it, and then I can just move ahead with the. Okay.
Dr. Rahul, just for me to understand, so with this very long sheet, or dilatator system, you make a smoother transfer for your guiding catheter, or do you avoid spasms? What is
so the most important thing is the outer diameter of a 5 French sheet is the diameter of this guiding, 7 French guiding. And the most important reason which has been found for the radial artery spasm and difficulty is when we use a higher size the sheet, which causes the artery to get into spasm, and then it becomes very difficult for it to be cannulated. So this is the advantage which we get when we are.
Would you
if they show the radial site, you know, sir, there's no sheath there. It's directly only the guide now.
No, it's a sheathless. Yeah. It's a sheathless thing. If we can
just let them focus on the radial site once. If the camera can focus, then people will understand what is the difference.
Actually, this dilator, when you use, it reduces the razor effect of the guide. It smoothens the transition between the guide and the dilator.
Yes.
So you don't have the razor effect of the guide, which would injure the radial artery. That's the advantage of using this dilator inside the guide.
No, otherwise, as you said, injury will happen. Dilator is mandatory. That is what is the railway catheter actually.
Yeah, that is why. So Dr. Ferenek wanted to understand the benefit of using this dilator inside. So I think that's the transition between the guide catheter and the dilator. That bevel becomes reduced. So that reduces the razor effect.
So
when you are doing the direct puncture, that means not exchanging it, then you can't take the dilator beyond a certain length, because the exit port of the wire is within few centimeters. So there you would insert the guide and then put a normal guide wire. In this situation, you have the option of taking the dilator right up to subclavian, or you can remove it earlier and put your normal guide.
So when we are doing the direct direct puncture, so what we do is, now I'll just describe that direct puncture technique as well. So we go directly as we are taking the radial sheet. There is a wire which is available, the O21 wire, over which then we feed the same way the dilator has been fed, and then there is the rapid exchange port, and we go through go into the radial artery, and we remove the wire O5, O3, O21 wire, and we just pin the dilator, we slide the guiding, and then we can give our heparin and in the cocktail to prevent spasm, and then we can just go with the normal wire and normal length wire, and we can directly access the. So I think
you also don't necessarily need to use the 2-1 wire in the kit. You can use the same wire that you have been using for your normal radial punctures. You can use the same one.
It is the one which is available with it, so I'm just describing.
Atul sir, what we have noticed, if you are using the regular wire, sometimes the support is a problem. This wire which is there in the set is more supportive, more stiffer. And wire enters, the guide enters easily into the radial artery compared to regular wire, what we thought.
Yeah, because when you're using a
first wire, to enter the radial artery after the needle puncture, it is much easier with the routine smaller wire, with the thinner wire that we use. So from that point of view, it is better to use the wire that we have been used to. In some situations where you think it's difficult to push it, then you can choose a 2-1 wire. But most of the times to enter the radial artery, it's much easier to use the wire that we are used to in so many cases.
Yeah, entry is easy, but only thing is sometimes when you are trying to introduce the railway catheter over that wire, there is a difficulty in entering probably better nick should be given so as to it.
Yeah, I agree. I agree with Dr. Srinivas. I think if you have to use your own wire, you can actually use the puncture wire that you normally use, then push the cannula forward and change it to the wire that comes in this railway system. So that has a steel portion, where it is entering the skin. So you can give a better nick. That's important to give a nick because you're directly going to take the guide in after that with the dilator.
So
I think somehow the camera probably was not able to focus on the hand. On the radial portion of the hand, there is only now the guide. There is no sheath.
There is only the guide, and it's quite all right, and the patient is quite comfortable. So I think if we are done, if there is no more doubt about the railway system, if anybody else can we, if any thoughts about the angiogram and the approach which anybody wants to suggest?
The regular thing is now what we wanted to demonstrate is doing a bifurcation through this system. That will be 7 French in the radial. Right. The plan is probably you can do bifurcation because that is the culprit vessel. Right. If it is okay with you, then shall we go to Pune and come back to you?
Yeah, that will be fine. Meanwhile, we'll work on the left system.
Yeah.
And then
any questions, Raghu or anybody on this? We are trying to do a study with this railway catheter system through foundation involving many of the young radial operators too. Where we can avoid going to femoral, even using the 7 French system. And we are in the process of finalizing that with Cardis and Cardinal. Hope it will come through. We have done some left mains, we have done some bifurcations with the system through. But what they claim, Rahul, is generally they say it is 2 French better, but definitely 1 French lesser, we can say 6 instead of 6, 7 can go. But to put a 8 with this, I think slightly may be challenging, but we need to have more experience. Yes. I think with this, if no further comments or questions on this particular
I actually
system,
have 2 comments here. One is that Dr.
Sanjay
Atul mentioned about the radial artery size.
Dr. Ferenc is one of the oldest operators. Now he has described some distal radial technique also. Please go ahead, Sanjay.
Yeah, so the 2 comments I had was, one is that the radial artery size, Dr. Atul actually quoted for Indians as being 2.3, but in our data of thousands of patients, the average radial size in the Indian population that we've studied and published is 1.7 in females and 1.8 in males. And the upper limit is usually around 2. So I think this kind of a system is actually useful if we have to use 7 French or even 6 French. And the other point is that we've actually found a higher number of radial artery occlusions using this railway system. So I think once we have a larger study, if we have a randomized study, then we might be able to have a clearer idea of that, because most of these radial occlusion data based on experience is probably not based on ultrasonic assessment of occlusions, because we looked at ultrasound assessment of occlusions just immediately after and 30 days later, and we found a higher incidence, a pretty high incidence radial occlusion, almost like 18%. So I think just because you're able to use a bigger size does not guarantee that you would have a patent radial artery at the end. So I think we need a larger study before we comment on that. But personal experience has been that the incidence is higher because probably we are stretching the smaller arteries a lot more when we use a sheetless system and use a 7 French or even a 6 French in many of the arteries, because the average artery is pretty small, 1.7 to 1.8 in the Indian population.
Dr. Sanjay, are you using the same amount of heparin, or are you upscaling the heparin dosage in these when you are using these sheetless systems?
Same.
Is the same dose? I mean, you would use the same dose as you would do for angioplasty.
I think Sanjay sir, as you understand, when you are putting a bigger size the catheter, obviously there we need to be more careful and there could be more chance of occlusion. As you said, we need to have larger data. And now, can you, Ujjwal, can you switch us to Hiramat to Pune? We'll come back later here again.
Yeah.
And mute the Apollo Mumbai and make Hiramat Pune site active. Yeah, good afternoon, sir. I'm Dr. Srinivas Kumar here. We are joined by Dr. Ferenc and Dr. Sanjay, Dr. Raghu, Jabir Ali, Abdullah Kuti, and many others, sir. Over to you, sir. We can see you and probably present your case.
All right. So, good afternoon, everybody. It's always a pleasure presenting to this august audience. So we are in Ruby Hall, Pune, and our first, rather today's case is a 53-year-old gentleman, non-diabetic. He's hypertensive, and he has COVID and MI both together. I mean, he had MI, was tested for COVID and was positive. He was in some peripheral town, and we suggested we wait because he had no pain and ECG had settled very well. So LV function is good, ejection fraction is 55%, minor inferior hypokinesia. So we will show you the right coronary angio, run number 1, and we are with simultaneous Judkins catheter in the left ostium. With me is Dr. Makhre and Dr. Salil and the entire Ruby Hall team. So this is a simultaneous injection together, and you can see the distality of the right artery. Next view. Next view. So, you know, the filling of the right coronary is all the way up. So looked like a focal lesion in the right coronary artery. Probably would need something like a 33 length stent. Okay, you want to add anything here?
Yeah, this is what we have done, the contralateral injection as the rule suggests, that first you inject the contralateral vessel. So by the time you follow it here on the ipsilateral side, your ipsilateral injection comes through, so that you know the correct assessment of the CTO segment.
So we are with AR1, and next slide. Next run, we are come with a Gaia wire. This is Gaia 2, and there is no real support from behind except for a decent position of the right guide. So Gaia is making progress on its own. It is guided by the left injection.
Dr. Hira, did you use a microcatheter?
We did not.
No, microcatheter is there, but it is not brought in as yet, but it is in the guide catheter.
Okay.
Okay, next.
Sir, which are the situations in which you try the first, because the faint antegrade trickle, then only you will take a Fielder XT type of wire. Otherwise, if it is definite CTO, you directly go for stiffer wires. I think you thought this is an older version occlusion, that's why you straight took Gaia.
This is from March to today, about 4 months.
Okay.
And definitely, in fact, on the ECG also. Next.
Okay.
So the left is sort of guiding the progress of the wire. We thought we are in good position now. Time to bring in a balloon. So you can actually see the balloon come in. This is a 1.5, 15 balloon, but giant.
No, it's Abbott
balloon, mini track. And we had little difficulty in pushing it, but ultimately it went well. So the whole length is now dilated with 1.5 only. So decent flow, and we probably see the length also.
Yeah. Sir, for sake of everybody with such tough lesions, what is your first balloon of choice for difficult entry purposes? Like here you have taken mini track.
We started with 1.5. It would, if it would not cross, then possibly we would have taken the big nano 0.85.
Dr. Ferenc, what do you use there?
What we use in Germany in our center is usually Ikatsuki balloon from Japan, or Rurai from Terumo, and Sapphire for Orbis niche. This is our first choice. If nothing is running through, so usually we start with Ikatsuki. It's 1.06 millimeter long, and if Ikatsuki doesn't work, so then there was no option for crossing. That's my personal opinion.
We generally take Ryrel balloon of Taramo, sir. It's quite a very good trackability and process.
Colleagues are doing here very nice progress. And you can see now how big this artery is finally. So it's make definitely sense to open this artery. My first choice of wire will be probably to try Field XDR and then Gaia second or something like this. But Dr. Hermat is very skilled operator. He's great guy.
So, over Gaia 2, we have placed a microcatheter through which we are now putting this is a hydrophilic wire, which is placed well distally.
Yeah, perfect.
This is after some more dilatation. Run this again and freeze it.
So now we have impression there is also very distally, probably, I don't know, maybe spasm, but it looks like a significant distal stenosis. So you have to probably use 2 long stents.
Yes,
Exactly.
I think this is what we also discussed, and we are now ready for 2 stents.
Next.
We of course needed to dilate the distal part well.
Yes.
So we are dilating with a 2515 NC balloon on high pressure. And
Dr. Huramat, you do very nice job, definitely perfect. What is maybe important for younger colleagues, for younger interventional cardiologists? So how to estimate the vessel diameter for this distal segment? So it's 3.0, 2.75, or maybe 3.5. So would you suggest to go here with imaging, or would you go now direct with a stent? And there is some kind of tortuosity. Would you consider to use also here guiding extension like Godzilla or whatever?
So we were in what you are also thinking, a 2-stent strategy.
Yeah.
So the distal part of the lesion is now dilated, and this is a 48 length Zion stent. You know, the guide stent was not tracking very easily distally. Despite guide catheter adjustment, it was quite difficult to get it further.
Yeah, so what is now your next step? Would you take another access support wire, so body wire, or would you go now with more intensive prodilatation, or would you take guiding extension, guideline or Godzilla or telescope, whatever you have?
We got a guide into guide, a telescope
catheter extension, telescope.
This is a Medtronic introduction just a couple of weeks back.
System, yeah.
So on its own, the telescope you can see coming up to the mid portion.
Yeah, perfect.
Then
what I do usually, I usually take balloon and 3.5 or 3.0 and go over the balloon step by step, and more distally, to avoid huge dissections, whatever.
Yeah. Actually, this is what we did for earlier guideliners, Guidezilla or Guideliner.
Yeah.
But up to the telescope, people were telling us that it can go a long way inside without.
No, that's correct. That's really.
So we just tried that. It didn't work to a great extent, but once we gave a support, it moved in very easily.
Yeah, perfect.
So as the balloon is deflating, we are sort of rolling the telescope on that, and this is the 48 length Zion's expedition.
Now it's perfectly demonstrated, Dr. Huramat, how easy PCI or stenting positioning of the stenting can be if you have perfect guideliner or telescope position. So now it's easy and safe.
Dr. Huramat, is there, do you feel a real difference between a Godzilla and a telescope?
Well, this is our first use of telescope.
But I find it very promising because at its own it could go up to the mid RCA where our previous stent was getting stuck.
It's considered to be more flexible.
Afterwards, we needed to do the balloon anchor technique, and with the balloon anchor technique, we could pass it as distal, you can see.
Definitely, it is more trackable, and kinking chance is less, and it tracks like a regular balloon going over the wire. That way, it is a significant improvement over GuideZilla. I am not too sure when compared to Guideline and how it works, but definitely we felt it is slightly better trackable and less kink risk. More of less kinking is less.
Right.
So I think
it has got extra support with a platform.
Yeah.
So this was after the distal stent was deployed. It is 348 and the balloon was taken to about 14. And this is the
Next.
position.
Next.
This is a 3528.
Giants expedition again.
Again, Giants expedition. So whenever we are taking long and extra long stents, we need to size it properly.
Next.
So after putting the second stent 3528, the whole length is post dilated with a 3 and 3.5 NC, 3 in the distal stent and 3.5 in the proximal stent. So these are some of our final pictures of the right, and this is the without wire. So you can see a lot of blush at the distality. So hopefully the LV, which is well preserved at this stage, continues to be good in future too. Any comments? I mean, this is a 4-month-old inferior wall infarct and a totally occluded right coronary artery.
So from my perspective, very good decision to open this artery, and I'm quite sure there was option for recovery of LV function. And I think Dr. Hiramat, you pointed is very much the point how important is to perform post-dilatation with NC balloons, you know. So it looks sometimes after stenting by angiographic view very nice, but we know from OCT data and from IVUS data in around 40% of cases, there is still malapposition. So from my perspective, post-dilatation is a must, and I do this in 100% of cases. So at least in all my patients with stented segments, they got finally post-dilatation with non-compliant balloons. I think this is really very, very important point.
Dr. Farhan, would you prefer doing an OCT in this case? It's 2 long stents and it's essential to optimize the
Not really. I think the stents choice was perfect. Post-dilatation was done by angiographic view. It looks perfect. From my point of view, in this right coronary artery, I would leave it like this.
I think when the places where imaging is not available, as Ferenc said and Dr. Hiramat are shown, post-dilatation with a quarter-size bigger balloon with going to high pressure is mandatory, especially whenever the stent lengths become bigger, more than 28. Generally, it is always better to, again, post-dilate with a bigger balloon, especially in the center. Otherwise, sometimes you could have hourglass effect and the stents less expanding at that site of lesion. So that is very well demonstrated, and the final result, that's how is quite good. I think we are going to left, sir, now.
Yes, so we are with EBU 7, and you can see the circumflex as it is running in the AV sulcus. It is critically narrowed in the mid and distal portion and moderately narrowed in the proximal portion. So the plan is to go for circumflex first. The next vessel that you see is actually a diagonal, and this is the LAD. So LAD proximal to the diagonal 2 is showing a moderate disease. So idea is to have an FFR on the LAD. Next view, and in spider view, you can see the diagonal showing a disease right from the osseum.
And this diagonal is coursing like a OM in the distal part.
Yeah. You mean to say the Ramnas-like vessel, the first diagonal.
Clearly arising from the LAD.
Yeah.
So we will go for the circumflex. first contrast study. Small. So this is that same run-through hypercode. Small.
Yeah.
I can't see it. Okay. Come to this view.
Srinivas, we will continue with the circumflex and do the FFR. In the meanwhile, if you want to go to the other center and come back to us.
Okay. AV team, can you switch to Mumbai? Can you keep sir in the mute and then...
If they are not ready, we are ready to continue here, okay?
Okay. Just check with them. If they want to come, us to come back, we'll go there and come back to you.
Small.
Mumbai? Rahul?
Dr. Rahul, you are on mute.
Okay. Yes.
Make a bigger screen, Rahul's.
Yeah, can you hear us?
Yeah, we can see and hear you. Go ahead.
Yeah, so we went ahead, wired the LED, not with difficulty, but just a balloon support. The diagonal was a little bit difficult, but we were able to negotiate it. I've just taken the OCT mild dilatation with 2.20 balloon. I think it's a recent total occlusion, so nothing, this thing. We were trying to, we have taken the OCT image. If we can just focus on the OCT, we still not interpreted yet.
We did not see the wiring. Can you just show those fluoro pictures once before we go to OCT?
Can you go a few scenes behind?
Okay, otherwise, you're already there. It's okay. Go ahead.
Yeah, we are already there with the wires. If you can show this. And this is before this. So these are all pre-dilatation. So the LED wire went with little next. Yeah, with balloon support only. Then it went easily. Then next. Yeah, so the LED, this the picture of the wiring of diagonal is not there, but it was slightly difficult, but we managed it. And this is a pre-dilatation with a 2O balloon. Show the picture, next picture.
Did you feel anything different with this railway system which we use without sheath compared to the previous?
I think it is quite comfortable in doing it. That sometimes if the skin nick is not good, and you can feel resistance in manipulating the guide. So that's what we have to take care. But otherwise, it's fine. That's what my experience is. So here we are, and can you show the OCT image if everybody can see the OCT? Can you switch to the OCT? So this wire tends to go into the diagonal. We are trying to negotiate, but just for the want of time, we have kept it. Anyways, we are not going to come over there. It's gone into one of the diagonals. Every time we have to change the shape. We have not done that because of the time. This is the OCT image. I think. Can you see the OCT image?
Yes.
So these are the OCT images. We'll just take the diameters and all, but I think the plan looks simple as of now. Can you go to that diagonal area where we can, if we can see the the ostium of the diagonal?
Actually, we didn't see the angio picture before if you get people will have better orientation once. At least when OCT you have taken a picture with angio, that to save the contrast, if you have not taken a picture while taking OCT.
Yeah, we have the picture of the angio which are there.
Once and then show this.
Okay. So can you show the? You want to show the angio? See the angio pictures? We can just show you.
Once the final before OCT also while doing it, you get an angio picture. So the plan is to see where to start the stent and where to end. That's what you are.
So can you show to the angio pictures? Go to the angio.
And Dr. Rahul, do we have an angio co-registration?
No, angio co-registration is there, but because this is connected to the live same thing. We can't, just the angio correlation doesn't happen when we have the live case because the output has been taken for that.
Okay. Dr. Sengoto, if you look at the angiogram, it is a tapering LED from soon after its origin. So I think we have to keep the diameter of the proximal LED in your mind. And if you look at the angiogram during the OCT, the mid LED is quite good sized, there is probably much more disease in the origin of diagonal and thereafter. So we will appropriately select a stent in a few seconds after looking at the diameter on the OCT.
Okay.
Yeah. देखो ना, measurement करो ना. Distal diameter.
Go to the distal side and then we cover.
Just check, Charan, just take the diameters. Meanwhile, if this goes into...
Go down.
Yeah, go down. Yeah. This is the return lens segment.
Yeah.
Yeah, show the OCT picture again.
Can you show the OCT picture on the shift to the OCT thing? Oh, so this is the can you go in the just run it and go to the proximal area, take the...
I think you may have to negotiate it a little down.
No, we have gone down now into the LED.
It could be recanalized LED.
Okay, so
another important thing is probably we should treat it with nitroglycerin before each picture, especially when there's occluded vessel which is opened up. It could be spasm.
No, we've given a nitroglyceride as well as NTG just now.
Yeah.
Yeah, just take the proximal thing. There's a...
It's diseased.
It's all deceased all throughout. Go proximally.
Go proximally. Go proximally further. Come further. Come further. Come back. For all diseased segment. Come back. That is circumflex.
Yeah. So basically, a diffusely diseased LED, there is no, those three layers can be seen completely, any of the side, but we'll choose the side which is of the, the least plaque burden.
Come back.
So,
come back. Back. Proximally.
But I think this diagonal probably will not trouble. Although, can you go to the one of the spider views where we had a very tight-looking diagonal?
What's the diameter of the 3.1?
3.1.
3.1.
Yeah, this one. Yeah. Stop it. Yeah, stop it.
Can you go to the fluoro? You just show. I think we'll take a picture right now in this view. Can we go to the spider? We'll take a picture because in the spider view, the diagonal looked pretty tight. But we'll just, now after opening the LED, we'll just see that picture and decide whether we need to do something about the...
Off the spine, please.
LO2 and...
As they are taking those, Jabir, would you comment on what is your policy of selection of diameter with OCT? Unlike IVUS, we take intima to intima. Here, what do you go from media to media?
Yeah, the problem is we are not seeing the EEL correctly, and can we make it a little bigger screen? It's a little difficult to see it, but if we cannot
make the screen bigger.
To avoid this only, Jabir, we made it projected on the bigger screens on the PVR cinemas. People are enjoying there. Only we, in the Zoom platform, we are suffering.
Right.
But the live stream viewers are seeing it on a very big screens.
Very big. Right. It's a bit difficult for us to see it well.
Yeah.
Since we could measure a 3.1 at 3 millimeter stent, I think I'll go for a 3 millimeter stent. If it is the measurement, that is the auto lumen measurement, we can go a 0.25 millimeter higher size.
I think we'll delete the
EL to EL, the maximum size of the stent can be that EL to EL. So we go for a quarter size or a 0.5 millimeter, the next size down.
And what are your comments on distal vessel being smaller compared to the proximal vessel, which is bigger? So probably if you take the bigger compared to the proximal segment, if you take, there is a chance of dissecting the distal vessel.
It's all based on the distal vessel diameter. It's
that's important. That also we need to mention. Yeah, that's what I was highlighting. That also we need to mention, because if you see only the proximal vessel, sometimes you could end up, though these later generation stents are very good and compliant, they adjust according to the diameters, but if you stretch it too much, probably edge dissections could happen. So that's where I think the proximal and distal vessels are different, then probably you could select somewhere in between and then dilate proximally with a bigger size balloon. That is a normal routine approach.
So we have taken the aleocaudal view. If you can see this aleocaudal view, the diagonal ostium is very tight. So what do you think? The diagonal is not very big.
Thank you. We have master in bifurcation, Ferenc, who is a principal investigator for BBC other trials. What is your approach, Ferenc? What we do normally is, if a diagonal or a branch has a tight stenosis, we tend to predilate to protect it. If there is no tight stenosis, we avoid doing predilatation. Do you agree with it, or what is your recommendation?
Yeah, definitely. I would try to go here with provisional
very low
approach.
atmosphere. 2, 3, 4, 4 only.
From my perspective, it's definitely necessary
That's it.
to make a gentle predilatation of the diagonal branch with 2.0 balloon, maybe 10 atmospheres,
Keep it for some time.
12 atmospheres pressure, and then try to get it open and concentrate then to the main branch. So in this case, I would definitely go provisional.
So we have done exactly the same. Negative PV, please. So what we have done is the diagonal was quite tight, 90%. So we've just at low 4 atmosphere, it has opened up well. We'll see how it looks like in a picture. And then if it is fine, I would just not do anything for the diagonal because the diameter wise, the diagonal is not very big. Go with the main vessel stenting and then see how the diagonal behaves, and maybe a provisional strategy just to open up these struts and all in case it gets pinched significantly. So this is the picture is better than before. The diagonal appears to have opened slightly better. Now we'll go with the stenting of the LED, and then we'll see how the diagonal behaves, and then accordingly act on it.
Dr. Ferenc, after your BBC trial data showing that in the overlapped portion, sometimes if you're doing a provisional stent or following a mini tap, there's more events happening in the branch that showed that probably culotte is better. Did you any approach changed in two-stent technique doing bifurcation, or do you still follow the same?
एकदम नीचे जाओ, distal जाओ, एकदम distal जाओ.
Follow the same. So what we know, we still have data to go with provisional. So this is
come from there.
The provisional is fine, but two stents technique, you are edging more towards culotte type compared to tap or mini tap, or still?
We have done a randomized study comparing tap and culotte, but the data was definitely better for culotte stenting, because with culotte stenting we have
fibrotic plaque.
always sufficient coverage of
distally.
You have impression you are perfect, but finally up you see there is some gap and again problem in ostium of the side branch. So you have usually then.
So this is about let's take 2.75 38.
So in our center we prefer culotte and tap.
You play karo.
Dr. Srinivas,
Rahul, can you show your angio? You are taking epicranial view also, or are you only watching on LA?
No, we have taken an epicranial view. Show that epicranial view. So the maximum diameter, it's all a disease, but it's a stable plaque, looks like in the proximal LED, fibrotic plaque. And I'll just take for the this thing, I'll just take a small picture. So this is how the LED looks like. So my idea is take the stent from the just below that lesion, which we see the hazy looking lesion, which is the culprit lesion, and take it to the proximal side, which looks slightly better. So maybe the length is coming about 30 millimeters on the. So we'll take a 30 millimeter stent, and we'll take a 2.75 stent, and then dilate it up to 3 millimeter in the proximal part. So that's the approach. We'll see how the diagonal behaves, and then we'll work on the other vessels. Meanwhile, if you want to go to the other lab, or if there is any other discussion point. So give me a 2.75 30.
Any other comments, Ferenc? Shall we go to Hiramat Center and come back finally here?
Give me the Onyx 2.75 30.
Yeah, this will be a good idea to take a look what Dr. Hiramat is doing.
AV team, can you make this mute and switch to?
We'll be able to approach the distal circ. Right. Sure.
Hiramat sir, we are with you now.
Hello? Okay, go. Okay. All right. Are you with us, Srinivas?
Yes, sir.
Okay. So we have done that circumflex distal.
We'll dilate at a very low atmosphere.
We're doing a post dilatation. We'll show you the images, and then after that we'll do the FFR for the LED.
12, 14.
Hiramat, which wire finally did you use for the successful crossing?
This is run through hypercourt.
Oh, nice! Really very good.
Boost or fluorocine.
Run-through has become most workhorse wire in most of the labs today. It looks like
yeah, it's a
quite
high quality wire, definitely.
quite good wire.
I need one more.
Boost lagel Vikas.
Okay, boost.
Dr. Paranka, is deload the most preferred bifurcation strategy when you go for a infection strategy in Europe?
18.
Okay, get me the microcatheter. Hello.
Europe, usually we try to go
Right one.
in around 20.
You want to do LED first? Okay.
So in Europe, I was
FFR wire.
kind of will be done by a lot for TAP. Maybe you heard this story. So
You're ready for picture of this?
very
Contrast ready?
in Europe.
Okay, contrast.
Main study.
Contrast.
Process is only 5% study. I think
Can you increase the sound?
from my perspective, the best way to cover patterns is easiest way is cloth.
So
Cloth is also perfect, but it is much more challenging and to have much more prices, which also play, I think, important role, not only because of more costly or expensive, but also according to the no use of plastic, etc., etc. Then I would will
zero ke liye?
the plastic. I think we have to do all these steps to avoid too much.
Hiramat sir, you are telling something, sir?
Yeah, I mean, we have put a stent which is 33 length, and there is a lesion proximal circumflex just after the branch, OM1 branch. So that is a discussion issue, whether we should stent that or whether we should do an FFR to that proximal lesion. What is your suggestions from the audience?
No, it looks like middle six a little ectatic. If you do FFR, sometimes it could come negative also. Where is the proximal stent ending there, sir? The middle six, we couldn't see that correctly. If it is very close to the lesion, generally it tend to cover. But if it is away, the lot of normal segment in between that proximal lesion versus stent, I think you can do FFR and decide.
Yeah, that is our plan. We have about 8 to 10 millimeter gap between the stent and the lesion, distal end of the lesion. So before that, we will do FFR on the LED. Can you show us the LED pictures in epicranial? Okay, can we show them the LED pictures? Just 1 second. They just show the LED pictures. So the LED in the proximal portion, proximal to the diagonal 2 branch, that's under consideration. It looks about 50%. If FFR was not there in those early days, we used to leave these lesions behind.
Diagonal looks tight, sir, but proximal LED looks not much important, at least angio.
Yes. So Dr. Mukhe is with the FFR wire, right? Mukhe?
Yeah, I'm with the FFR wire. So, yeah.
So we are in a small match.
Okay, now wait, let me take this thing out. Introducer, give some
fingers.
Dr. Ramat, is it a little? It seems to be a little tough lesion to for the FFR wire, isn't it?
No, FFR wire is tougher. It's not that lesion is tough. It is not like a run-through wire. You always need to handle FFR.
Done.
It's a bit difficult to manipulate the FFR wire through these tortuous lesions.
What Zabir is telling is a very valid point. You should not
go to epicranial.
Totally equivalent to like a routine workhorse wire.
So we have done the equalization. Can you see the FFR on the screen there?
Yes, sir, we can see it.
Yes, we can see.
So we have done the equalization. Now we are moving forward. Next, small contrast.
Which modality you prefer, intracoronary or intravenous?
Intravenous, sustained 3 minutes hyperemia.
Yeah.
Are you going to do a RFR or a IFR first and then going for FFR or only FFR?
Only FFR.
Actually, what we have observed is intravenous actually less chances of getting a fallacious value, because intracoronary sometimes when you're trying to change the 3 ways this side that side, and you could get a fallacious value sometimes.
I agree. I trust more of the intravenous. Start adenosine, please.
Only thing is intravenous consumes a lot of adenosine. Hospital owners may be a little worried, but intracoronary it is a lesser thing. But from patient point of view, result point of view, I think intravenous could give more reproducible result.
I think we all now consider intravenous continuous infusion as the gold standard, and the errors are much less with that.
Just focus on the.
Dr. Hiramat sir, we also see Dr. Gary Meds and Kirti Punamia joining for the next session. And anything, Dr. Gary sir, any comments on this? Welcome to TCT India. Thanks for joining. We'll just finish these live cases and go to your session, sir. Just another 5 minutes more.
Sure, thank you.
So we are seeing figures like 0.78, 0.79 on the LAD. And adenosine has just started, about 1/3 has gone.
Oh, then it becomes important, sir. Generally, once immediately in the first half itself, it has gone less, it is more likely to. But once it goes to a lower level, generally it stays there. 0.79, 0.8.
So what is the advice from the floor? Do it or wait?
If values are definitely positive, like less than 0.75, there is no ambiguity. But if values come in between 0.75 to 8, and keeping the clinical scenario and angiographic appearance, lot of things, we need to take a decision. Angiographically, it was looking less, and but only the issue is here is the proximal LAD. Important thing, you have to be absolutely sure. Is having angina, sir?
I believe this is a LAD region, which has definitely an impact on prognosis for this patient. So if we have here such result, we have to handle.
No, if FFR comes 0.81, what do you do, Farag?
Yeah, we are actually 0.79, 0.80, as you can see.
Yes, yes.
So it is really a very borderline.
I mean, if I can make one comment. So,
yeah, Gary, go ahead.
Sure. You know, it's very difficult to normalize an FFR after you've treated an LAD. So you've got 3 potential regions for the FFR being borderline: proximal disease, distal disease, and the stent itself. And if you look at the entire literature, having an FFR like this after stenting is much more common in the LAD than in the circumflex or the right. So you really should also do a careful pullback, making sure that this is localized to the proximal vessel before you jump when treating the proximal vessel, and that it's not, perhaps that the stent is not fully expanded.
Dr. Gary, they didn't do stent to LAD, they did stent to RCA and LCX.
Oh, I see. I'm sorry.
They're studying the LAD lesion.
Oh, so I came in late. I thought they'd sent it to you.
Yeah, that's right.
So you know, in this case, it's a borderline FFR in the LAD. And when you have somebody with an FFR in the, in the 0.8 range, they tend to do well irrespective of whether you treat them medically or with revascularization.
Take out the FFR wire?
To the circumflex. Huh? We should take this to the circumflex to assess the proximal circumflex.
But they should also do a careful pullback and make sure there is some occult disease in the left main.
Sir, Michael, sir, what sir is advising is take a pullback and see that.
Hey, wait. Okay. They want you to take a pullback.
Okay, we live on this thing.
Yeah, so that we'll see exactly where the pressure is, drop is happening, where it is becoming normal.
Okay. You know,
That's fine. We are much distal to the lesion. You can come back now.
That we
You can keep the FFR on, please, on one small screen. FFR on small screen, and then angio on a big screen.
Show the FFR on the screen, please.
Yeah. Okay. We are seeing, sir, now. Go ahead.
So it was all the time more than 0.9.
So that's what is the problem. It's not a step. They got stepped up only proximal to the lesion. There is. I think overall the decision would be to leave it, sir.
Leave it.
Okay.
But what is the wisdom from your end?
It's only 0.9, and angiographically also it was only an intermediate lesion.
Yes.
I think once we do FFR, we shouldn't fall back on angiography, because angiography is showing a sort of moderate stenosis.
And the FFR is 0.9, we can comfortably leave it.
The FFR, which was 0.79, 0.80.
It is 0.79.
Yes, 0.79 and 0.80.
So it's exact borderline, then a tough call to take.
Now we are seeing assessing the proximal LCX, sir.
Yeah.
Yes. Just show the last picture of the LCX.
Yeah, we saw that, sir. We can see the FFR now.
Last picture of here on the main cine. Last picture after stent to the circumflex. Okay, freeze. So you have a stent in the mid circumflex, and now we are checking the FFR on the proximal lesion.
Okay, now we'll be doing the FFR for the circumflex.
And what's your decision on the LAD? Are you going to stent the LAD or leave it?
Leave it.
You all told us leave it, so we are going to leave it.
Start adenosine.
We'll leave the arena after the live.
Yeah.
I think don't forget this patient got during this procedure. You open the right coronary artery, so it's now open vessel. You open nicely distal circ, so we definitely improve perfusion in this patient dramatically. You could ahead and order the patients in few months back.
Generally, sir, before adenosine, if it just above 0.95, 0.98 like this, even if you go adenosine, it could become like 0.9 or 0.85 maximum. It will generally come negative. But by and large, baseline, if it already drifts to 0.9, 0.85 like that before adenosine, then after giving adenosine, it will become important. Here, it looks like baseline is just 0.9. Now, after adenosine, it could go down to 0.85 things like that. You started adenosine now?
Yes. About 30 seconds now, the adenosine is going on.
Generally, after IV, we start getting response after 1.5 minutes of infusion or so. And it goes down to some level and then it sticks around there, even if further infusion also.
So what do you get? The good steady state rather than, those jerky movements.
Yes. That's the advantage of
that adds to the confidence of what you are doing.
So actually, we are giving adenosine through femoral vein. So it's a central line, not in the peripheral vein. So you would probably see the effect almost immediately.
Okay. The lowest we saw till now is 0.85.
Get the wire, run through hypercode. We'll start doing the diagonal. What? 275. So we are given about 2/3 of adenosine, and
Brady.
Yeah, Brady card.
Yeah. Stop adenosine.
No. Let it continue. How much is gone?
I think even this came 0.83.
Yeah.
So we leave it, right? What do you suggest?
Yes, sir. Because if you had to follow FFR, probably we'll leave it.
That's a nice answer, huh? If you follow FFR. So
the idea of doing is it to follow it, no, sir. If you are if you are believing it, then probably you should leave it.
So, but then you cannot say if you follow FFR.
No, you should leave it then.
When you do FFR, it means you are going to follow.
Yes, sir. Yes, sir. I correct it. If your FFR came more than 0.8, you should leave it.
So I'm removing the FFR wire.
So FFR.
You can see the drift, sir. For the sake of everybody, what Gary was mentioning, while withdrawing at that particular point where the lesion is, if you come back, the transducer comes proximal to it, suddenly it jumps up. I think now it is gone up.
Now it is 0.94.
So that means what we have done is reasonably correct, and that again proves us that what we did is right. Thanks, sir, for excellent demonstration of a triple vessel disease. And with LAD not being there, many of the times there is no point sending these patients for surgery. Many of the times in periphery, it is written as triple vessel, and people keep sending for surgery. But the LAD is not important, and only RCA and LCX, you effectively shown that we could revascularize by PCI. If any final words, sir, Dr. Hiramat, before we break, sir?
No. We need to look at the diagonal. Diagonal is quite important vessel. And
diagonal will be positive, sir. Angiography wise, it's tight, no?
It's tight. So we are going for diagonal now.
Because
we'll have to leave you guys.
Yes, sir. Is it okay?
Yeah.
If it comes positive, you would stand diagonal. Otherwise, you leave it. That is the plan. Thank you for effectively showing a multi-vessel PCI very well demonstrated. Initially, it was RCS CTO, and then you showed effectively how to tackle LCX, and now also FFR-based decision of leaving LAD. Thank you, sir. Any final words before we break from you, sir?
Thank you for the opportunity. It's a big pleasure talking to somebody like you and the audience there. So this was multi-vessel, and the right had already given him an infarct. The two vessels, the LAD and the proximal circumflex, we said no to dilatation based on the FFR. And now we are going for the diagonal.
Thank you, sir. If Gary Mitt, sir, if you permit, we'll just see for 1 minute what happened in the Mumbai lab, and then we'll close that live case, sir. Then can you connect the Mumbai, Rahul?
Yes, I'm there.
Show the final result. Can you show the final result?
Yes. So this is where we place the stent. Go ahead. Next slide. Next. I rewired the diagonal again. After that, I did a post dilatation. Next. Did a pot. Then these are the final pictures. So the diagonal is flowing very well, and the stent, the LAD results appears to be reasonably good. And these are the final pictures. So now we are going to work on the other vessels as we will break from here.
Okay, thank you, Rahul, for effectively demonstrating the railway catheter system, how 7 French can take in the radial artery. Anyway, here diagonal LAD were occluded before. Even if you have some suboptimal result in the diagonal, it looks okay, but diagonal doesn't seem to be flowing as good as LAD, but many times we tend to accept it as long as the flow is maintained. But it looks like TIMI 1-2 flow in the diagonal. Probably if needed, you can work on it. We'll allow you to work in peace, and thank you for effective demonstration. We'll break. Any final words you want to say before we break?
No, I think it was a nice opportunity to be here with all of you. And Pillai sir, you want to say something? Yeah.
No, we have effectively treated this complex lesion as single stent.
Okay.
Because we know the results are better without making
provisional approach.
Yes, provisional approach, because the diagonal does not look very large by diameter as well as length. So we have decided to do that, and we got a very good result. Thank you.
Thank you. Anyway, you were geared up to do that by 7 French railway system, but it was not. Fortunately, you are not needed to work on it. Thank you for effective demonstration. I think AV team, now we can break. We'll go to the next session on the imaging symposium, which all of us are waiting for Dr. Gary Mins and Dr. Akiko. They have already joined. Thank you very much for joining, sir. It's a pleasure to have you in this year's meeting. And any imaging session, people always look towards you. And we also have our Indian expert, Dr. Kirti Punamya, and Ramesh Dagupati, again, It's difficult for us to tell whether he's in US or India. Always there to help us too, and he will also share his experience with ACS. And with these few comments, I request Dr. Gary Mills to take over and conduct this session. I think Dr. Akiko Mehra also joined. Other panelists, if they are there, please join. Ajit Mehta, Balaji, Pradeep Deshmukh, and others. Over to you, Dr. Gary.
So thank you very much for asking us to put on these 2 imaging sessions. There's a 2-hour IVUS session, then a break for live cases, and then a 2-hour OCT imaging session. My co-chairs are obviously Akiko Mehra and Sanjov Kalra. So I'm going to start with my talk. Can everybody see my slides?
Yes, sir.
Good. So this is a talk that I put together and constantly update to show how important intravascular imaging has been in the development of PCI. Everybody knows that Andreas Grunzig invented PCI, but not so many people recognize that it was Jeff Hartzler that is responsible for modern PCI, including multi-vessel, CTO, primary PCI, evidence-based medicine, formalized PCI fellowships, and so on. He really is the father of the PCI that we practice today. But they only had balloon angioplasty, and it became obvious that balloon angioplasty had severe limitations, and that ushered in an era that we called the new device angioplasty era that included coronary atherectomy, laser angioplasty, and intravascular imaging. Intravascular imaging was invented by Paul Yock. This is his original poster presented at the AHA in 1988. And his conclusion was that catheter ultrasound may be useful in directing mechanical atherectomy, laser ablation, or other forms of catheter-based therapy, and it may allow maximum debulking of atheroma while minimizing the risk of vessel perforation. Using intravascular ultrasound, we understood the limitations of angiography. This is a paper that I wrote many years ago in 1995, which showed that angiography is extraordinarily limited in assessing the presence of calcification. We also looked at lesion eccentricity, and it became obvious that irrespective of what a lesion looked like angiographically, half were eccentric and half were concentric. And if you looked at a bifurcation lesion, the plaque is almost always opposite the flow divider. This is the circumflex. This is the plaque in the ostium of the LAD. And then became obvious that most of the atherosclerosis is hidden and is angiographically silent. In fact, 3/4 of the atherosclerosis in the coronary arteries are segments of the coronary arteries that look normal by angiography. And this substantiated in vivo what Seymour Glagoff showed in the pathology laboratory, that is, Glagovian remodeling or positive remodeling occurs to maintain lumen dimensions and hide most of the atherosclerosis. Well, we also use intravascular ultrasound to assess the successes and failures of these devices and the mechanisms of restenosis in a way not possible with angiography. And prior to the seminal serial IVUS studies, it was believed that intimal hyperplasia was the cause of restenosis in non-stented lesions, and that in-stent restenosis was caused by chronic stent recoil. But we saw cases like this. This is an LAD after directional coronary atherectomy. Here is a diseased septal perforator, no residual plaque of any significance. The patient comes back with restenosis, presenting as a total occlusion, and the vessel has totally collapsed or shrunk or been constricted. And again, here is the same diseased septal perforator. And Jeff Isner wrote an editorial, "Honey, I think I shrunk the artery." Well, nobody was quite sure what this meant. So this led to my first trip to Japan in early 1990s to initiate the SURE study because Nobuyoshi and his colleagues were doing serial angiography in patients after angioplasty and atherectomy. So we did a study where IVUS was performed pre-intervention, post-intervention at 24 hours to eliminate recoil at 1 month and at 6 months in a relatively small number of lesions, 26 treated with atherectomy and 35 with balloon angioplasty. And this is what we saw. And let's just look at the example. Pre-intervention to post-intervention, no change at 24 hours. The vessel grew at 1 month and then shrunk at 6 months. And that's exactly what we saw in the overall data set. And in fact, there was very little increase in plaque from post-intervention to 6 months. We'll come back to this at the end of my talk, but keep in mind that restenosis in non-stented lesions is the result of shrinkage of the artery or perivascular scar formation and constriction. Well, as part of the new device angioplasty era, Julio Palmaz invented the bare metal stent, and in-stent restenosis was thought to be the result of chronic stent recoil. The other thing you should understand is that the early experience with the Palmaz shot stent was terrible. Most of you don't remember it, but these stents would thrombose acutely. We would have the patients on anticoagulation to prevent stent thrombosis. Even if they had a GI bleed, we were fearful of stopping the anticoagulation because of the fear of stent thrombosis. It was a horrible, horrible experience. Until Colombo and his colleagues using IVUS showed that suboptimal stent deployment was common and identified the proper technique for optimal stent implantation, using high-pressure adjunctive balloon inflation in particular. And finally, the FDA approved the bare metal stent in the US. And we used IVUS to understand the predictors of bare metal stent early thrombosis and restenosis, the number 1 being under expansion, and the number 2 being edge problems or geographic miss. And we also used serial IVUS to understand why stents restenose. As I mentioned, Julio Palmaz thought that in-stent restenosis was because his stents were not strong enough and they collapsed, but the serial IVUS studies showed that chronic stent recoil was rare and that most in-stent restenosis was the result of intimal hyperplasia. We also identified mechanical causes of in-stent restenosis. Chronic stent under expansion was common. The stents were just never properly implanted. And we saw cases such as this, where in-stent restenosis in the osteoproximal right coronary was because the stent was crushed to the side of the vessel wall. During the procedure, they lost wire position, and in rewiring the stent and then post-dilating it, the stent was crushed against the vessel wall. Conversely, edge restenosis was the result of negative remodeling potentiated by a large residual plaque burden, just like restenosis in non-stented PCI procedures. Well, new bare metal stent designs did little to reduce in-stent restenosis. Some patients had recalcitrant and recurrent in-stent restenosis, and clinical and IVUS studies showed that bare metal stent restenosis did not respond to balloon angioplasty, any kind of atherectomy or laser angioplasty, or restenting, irrespective of the acute result. And that led to the short-lived routine brachytherapy era in which bare metal stent implantation was followed by anticipated intracoronary radiation to treat inevitable cases of in-stent restenosis. But it was the IVUS findings that helped to end routine brachytherapy by identifying aggressive edge restenosis, black holes in the tissue representing immature cells in the neointima, late-acquired stent malapposition, non-healing of edge dissections, and aggressive late catch-up in neointimal formation. The obvious solution, of course, was a stent to prevent chronic negative remodeling that is present in non-stented lesions, plus a drug to prevent intimal hyperplasia that was common in bare metal stented lesions. And obviously we had the first generation DES, Taxus and Cypher, but we used intravascular ultrasound to identify drugs that would work. In small numbers of patients, you can do a serial IVUS study and see the percent neointimal hyperplasia volume and see which stents will and will not work, because the standard metric in bare metal stents is 30% NIH volume. Randomized clinical trials led to the FDA approval of DES in the United States, as well as for treating bare metal stent restenosis, which finally ended routine brachytherapy. And we looked at the predictors of early stent thrombosis and restenosis with drug-eluting stents, and they turned out to be identical to bare metal stents: under expansion and geographic miss. But then came the ESC firestorm in 2006. It was suggested that drug-eluting stents increase patient mortality, not cardiac mortality, but all-cause mortality. And Forbes magazine had an article calling drug-eluting stents a million ticking time bombs, and the use of DES in the US plummeted to the mid 60%. Well, about that time, Gary Tierney applied optical imaging to the coronary arteries and invented optical coherence tomography. These are his early images. They're obviously very primitive. And we used OCT to try to see if there were additional predictors of DES failure, but the OCT findings merely substantiated the IVUS findings, number one being stent under expansion, and number two being edge problems or geographic miss. But OCT was able to assess stent thrombosis and in-stent restenosis in a way not possible even using IVUS, and we used OCT primarily to study tissue characteristics after in-stent restenosis. And here, for example, you see neointimal rupture, thrombus formation, and so on. But it was actually angioscopy that identified neoatherosclerosis as an important cause of restenosis in first-generation DES. And once neoatherosclerosis develops, these are OCT studies, stent failure is predictable. You see an example on the right, no neoatherosclerosis, and at long-term follow-up, once neoatherosclerosis is recognized, stent failure is almost inevitable. We also used OCT to look at causes of very late stent thrombosis and recognize the importance of neoatherosclerosis in this setting as well. And of course, stent optimization using intravascular imaging led to better patient outcomes, as was shown in these many randomized trial publications, meta-analyses, and registries, and I will just highlight one or two. This is the National Registry in the UK of left main stenting, showing that intravascular ultrasound guided left main stent implantation has a nationwide 34% reduction in cardiac mortality. And in the Korean online AMI registry, intravascular imaging, whether IVUS or OCT, reduced patient and device-oriented events because of reduction in all-cause and cardiac mortality. Of course, we have to mention the bioresorbable scaffold era, which started around the year 2000, now 20 years ago. Imaging was used to understand the absorption characteristics of the bioresorbable scaffold, and also to understand the restoration of normal remodeling, and in fact, even potentially plaque regression. But as you all know, there were a number of studies showing that scaffolds had a higher event rate compared to modern metallic everolimus-eluting stents. And in response to the FDA's concern, Abbott stopped selling Absorb. So what were the IVUS or OCT findings or predictors of early scaffold thrombosis or restenosis? There weren't any. Why? Because the use of imaging was not only not recommended, but was actively discouraged. And the systematic serial imaging studies were limited to a few patients in cohort A and cohort B, and there were no acute implantation studies similar to the early reports of Colombo and his colleagues. Only recently have we begun to understand mechanism of scaffold restenosis and thrombosis, and here you see the INVEST registry showing using OCT scaffold discontinuity, neoatherosclerosis, and so on. And as I mentioned, scaffolds are not immune to neoatherosclerosis. That was one of the hopes, as shown in this paper from 2018 from Japan. So let me just share with you quickly one case. This is pre-intervention, post-intervention, 6 months and 15 months after a bioresorbable scaffold. Notice how the vessel has shrunk from post-intervention to 6 months to 15 months. And restenosis was mostly caused by constriction of the vessel, almost exactly as was predicted by the serial ultrasound restenosis study more than 20 years previously. A few quick words about primary PCI. Let me just skip ahead. So intravascular imaging has looked at lesions associated with primary PCI, and it was recognized that if the fibrous cap was intact, the patients did better at long-term follow-up, and this led to the concept of erosions that could be treated medically, as was shown in the erosion study from Harbin, China. But also intravascular imaging was used to recognize the presence of SCAD and calcified nodule, and in fact the intravascular imaging studies were the earliest studies to recognize these phenomena. Jim Miller, of course, started the vulnerable plaque era and was instrumental in developing near-infrared spectroscopy, and now we have the evolution from Prospect 1 to Prospect 2 and Prospect Absorb, and a Prospect Absorb showed that it may be possible and it may even be scientifically valid to treat vulnerable plaques using some kind of mechanical device. The last thing I want to quickly mention is education. Everybody thinks that Andreas Grunzig invented the live demonstration course, but that is not correct. These are two paintings by the American artist Thomas Eakins in the 1800s, and it showed that all procedures, surgical procedures in this case, were taught in live demonstrations. The Gross Clinic painting on the left, the Agnew Clinic painting on the right. You see the students in the audience, but these were also used to identify progress in technique. Notice that here in 1875, Professor Gross was operating in street clothes. In 1889, Professor Agnew and his colleagues are now using gloves and surgical gowns. And Thomas Eakins even painted himself into these paintings as an observer. Well, the first TCT in 1988 predated intravascular imaging. This is the first live demonstration course that I was able to identify, and what I just want to show you is what the early images look like. So this is what we had to work with in the early days of intravascular imaging. Nobody could have imagined that this was the nidus for what we do today. And in 2018, second to the last live TCT in the coronary theater, you can see that on the left, OCT angiography co-registration guided stent implantation, and on the right, zero contrast PCI. So if I can quickly conclude, intravascular imaging has been fundamental to the evolution of PCI and the understanding of coronary disease and its treatment from a time in the past when the images were primitive and PCI techniques were limited to balloon angioplasty to the present when images approximate in vivo histology and PCI techniques are science fiction-like in their sophistication. Thank you for your attention.
Thank you, Gary. If there cannot be any better person to take all of us through this evolution of imaging. That's why we selected. And even in Indian mythology and philosophy, Charaka Samhita also did some live demonstrations. You quote there. But in India also there is some history of doing some live demonstration through surgery in Charaka and Samhita. It is long time thing. But you showed early imaging orientation pictures, how the imaging came down and how it improved. All that. We have little time left. Kirti, you want to say comments? Please.
I think this is a tremendous journey that Dr. Mintz has shown. I mean, it's right from the early days to now. I think it was just detailed and exotic. Thank you so much, Dr. Mintz, for that journey.
Yeah, if anybody ever goes to Philadelphia, those two paintings hang in a single room in the Philadelphia Museum of Art. And the Gross Clinic is considered to be the finest work of art ever by any American artist. It is a magnificent painting.
Thank you. I think you can invite Dr. Kirti.
Sure. So, Akiko, why don't you do the next two, or the next invitation, and then I will introduce you.
Okay, so let's go to the next talk. Next talk is Dr. Kriti Punarmir, and he's going to talk the advancing IBUS, HD IBUS image interpretation and case-based discussion.
Slides visible there?
Yes.
Okay, great. So I'm going to quickly breeze through what I've learned. Thank you so much for this podium space and the opportunity to speak, with such an august audience. It has been a journey for me in my private practice, which is a solo private practice. From the year 2010, we've made an attempt to IBUS image just about everything that we did in the cath lab. And from then, it's been a tremendous improvement in imaging. 2000, we had the 20 megahertz volcano to start with. We went on to the 40 megahertz OptiCross series till we've got to our present. 2 years ago, a year ago, we got a 60 megahertz OptiCross HD. And you can see the refinement of the imaging and also the software that goes with it to kind of understand. I'm just going to quickly go into areas which have influenced me greatly as far as imaging is concerned. We all know the left main space is probably one of the most influenced as far as imaging is concerned. While we all believe that a pre-PCI imaging is mandatory, it is not always possible because of the calcium and the inability for imaging catheters to pass through. But I think it is mandatory that we should have a pre-stent imaging at least to get good sense of what we're doing and not lock ourselves into a point of no return prior to placing a stent. Then the left main can be divided into these two very basic areas, the browns and the blues, the browns being the landing zones, which tell you size and length of stent, and the blues being the core images, which talk about lesion characteristics, stent strategies, and device selections. When you get into the single stent strategy, of course, it's this one second branch in the ostium of the second branch that with the plaque burden, the distribution of plaque and its relationship to the other branch osteums adjacent. It tells us how we're going to treat it, whether we're going to involve it or not involve it in the PCI. To go into examples, this is the left main, and you can see that this lesion involves the shaft of the left main extending into the LED over a length, and the circumflex ostium on the angiography looks little involved. However, if we have to look at the IBUS images, we know that we have to go right from the ostium of the left main right onto the landing zone in the LED, which is 51 millimeters downstream, and kind of considerably goes down in size. But what is important is this ostial circumflex image. And this kind of an image, which shows very little plaque burden, less than 40%, and most of the plaque eccentrically placed away from the carina, is a single stent strategy for me, and I don't even wire these arteries anymore. Here is a story of how we do it. It's very important that at every stage we need to go back to imaging, because we think angiographically we're doing well, but here was a malapposition in the left main there. We had to expand it. And this particularly is an important step if you're going to consider a second, going into the second step, which is going into the branch for a provisional approach, because we would have a substrut wire if we had left these malapose struts in the left main. And of course, this is the final result. What is it essential? And I think Ivis has told us that it is essential, needs to be done systematically. The idea is to achieve a complete apposition in the main brachial artery. And here is a great example of what looked angiographically great. However, when we did an IVUS, you can see that the distal left main confluence was hardly dilated. So our pot was not only not done well, but also we realized that we needed a bigger balloon to kind of go and oppose these stents in the shaft of the left main. When we get onto this calcified shelf in the left main extending into the circumflex ostium and a very calcified critical stenosis in the circumflex, I mean, we look at it, and post-rotational atherectomy, we've used a rotablator followed by a flextome and NC balloon. And what is important is not just the artery, which is the artery of interest, but actually the other artery, the second branch, and the ostium of the LAD is very, very important. And here with the MLA of 6.5 and the kind of images that I see, I am quite confident to say that I could restrict myself to just this one stent extending from the left main into the circumflex and be okay with it and leave that LAD on its own. So that is exactly what we do. And using these images, we can tell the length of the shaft of the left main, which helps us decide the stent length. And then we can actually go ahead and follow through with the second stents into the branch. And of course, once we've done that, this is the final result. The question always asked to me is, I mean, we got a great result. The MLAs are great, commensurate with the sizes of the stent used. 4 years later, this person, this was done in 2017 and 21, he developed new lesions in the LAD. The question is, should I have opened up the struts of the branch to facilitate my future PCI? And what we've done in 2021 is gone through those struts and easily done a rota, an IVL, and then cracked those lesions and converted into what I refer to as a deferred culotte over the 4 years. And therefore the question is, side cell recross, do I always do it? Yes, if there's flow restriction with a suboptimal result in the branch, yes, but otherwise for a downstream PCI expected in the future, I really have my doubts, and we really have no data whether that's the right strategy or not. I would wait for a little more data to come onto, especially in the left main space. At this present time, I do not routinely open up a side strut in a provisional stent. Should we extend every left main stent to the aorto-ostial end? Again, the IVUS is actually instrumental in telling us this. In this case, of course, this left main looks great, the ostium is great, and we don't need to come back to the ostium in this artery. But in this in this lesion, of course, the left main ostium is rather involved, and here you would have to extend your struts back into the ostium and a little outside probably. Whereas in a left main, which is very short, sometimes we have no choice with the plaque coming into the confluence zone. I think we have no choice but to extend it to the ostium. And so these are those images which kind of make you, which give it a comfort to kind of conclude a procedure with good sense of what's happening rather than just an approximation. So I think these are two important points. One thing I'd like to make is in the large left main, which is more than 6 millimeters, it is not always necessary to come back to the lumen of 6 millimeters. You can stop short at a lumen which is 5 millimeters or 5.5, and that's good enough. And if there's no plaque at all in the left main, then I think just an ostial location of the LAD or a circumflex stent will work in a roomy left main. But what happens when you're looking for these left mains in the post-PCI imaging? I think that's where I think everything changes. We look at the edge for plaque burden, dissection, and appositions. But what is important is those blue images down there, which talk about the areas, the minimal stent area, the residual plaque burden, and the tissue prolapse, defining whether we've undersized or correctly sized and expanded those stents to optimal. This is just a brief for every one of us to remember in the cath lab as to when we use a 4.0 stent, we need to get it to 12.5. But that never really happens in the ideal world. When you put a stent in, which is 4.0, it never gets to 12.5 millimeters square, and you might have to go to larger balloons to get to that point. And when you look at Kang's data, which is actually the pivotal trial for me as far as image guidance in left main PCI, my interpretation is that if you want to get great results, you need to put a 3 millimeter stent in the circumflex, a 3.5 at least in the LAD, a 4 or 4.5 in the left main, and expand it completely. And that's when you're going to get a great result. This 80-year-old who had a calcified lesion in the ostium of the circumflex extending into the proximal circumflex with an angle which is around 70 and a long lesion in the circumflex. I thought rotational atherectomy followed by a balloon dilatation of flextome or NC, and then a single stent from left main to LAD. After the rotablator, we pulled back an IVUS from the LAD and the circumflex and see the story. When a circumflex ostium looks like this, with an eccentric calcified lesion facing the other side, and there's tissue at the carina or the divider, then you know that if you're going to even take a 3O balloon, you're going to push it in. And then if the LAD ostium is already compromised, in calcified lesions particularly, for me, this becomes a 1-1-1, and this became a planned 2-stent strategy from a single stent, and that's important. So these decisions based on IVUS, the finding of the ostium of the second branch based on the plaque burden, based on the MLAs that are there, the plaque, the distribution of the plaque, are all important in deciding a single stent strategy. I just want to get onto a space which is the two areas that we are most vulnerable to erring is the right ostium and the circumflex ostium. This is a case which is a 10-year post-transplant, 61-year-old unstable angina, calcified mid-RCA, extending right up to the proximal end. The operator did a rotational atherectomy, followed it with a Guidezilla-supported 2-stent strategy, 2 long stents, and the proximal stent was extended all the way to the ostium, and this was the final result. He did not use imaging at that time. And this is a recurrence of symptoms in 1 year, and 3 years later, 2 weeks ago, we did an angiogram on this gentleman and we've got an ostial recurrence. So why did this really happen? We did an ALCA with a 60-60 with a saline infusion, did not go, we changed it to contrast, and yes, readily went in. We did a few runs, got a lumen to get an IVUS catheter in. And I think once we had this, so what did the IVUS tell me? Just to put things into perspective, at this present time, the stent shadows are right to that point there. The ostium of the artery is right here. And when we look at our images, we can see that it's a very well expanded stent as we go down into this artery. But as you come towards the edge of the stent, you can see the cross-sectional areas going down to the point that the edge of the stent is actually just 2.9 millimeters square. And why did this happen? And there's this eccentric plaque, which is the plaque from injury, which is in the geographical miss. So my take on this is that this was a stent deformation caused right at the index procedure with guide catheter trauma and not realizing it. And of course, there's been a geographical miss because some of the struts have been pushed into overlapping each other. There's a deformation and you expose an area which you've injured. And I think this is important. And we corrected it with a 3.5 Wolverine and expanded a stent. And what we do now is keep our guide catheter away and take these 120 centimeter diagnostic catheters, 5 French or sometimes 4 Frenches into the arteries to take the final picture. And this is what we achieved, which is a great, which is a much better MSA, cross-sectional area for the stent than before. In my own practice, this is a case when I go back and I wonder, have I done something like this as well? And yes, of course, this is from 4 or 5 years ago, where this very calcified tortuous artery, we did a rotational atherectomy, did exactly what the other operator had done, Guidezilla assisted stents, 3 stents all the way to the ostium, 4 proximally, and we thought that we'd have done an excellent job. And when we looked at the IVUS, you can see the IVUS, we were so taken aback by the cross-sectional area that what we forgot to look at was the actual EL and the entire artery in perspective, thereby just ignoring the residual plaque burden or putting into perspective the deformation that is missed here. This patient came back in 3 months, and of course, this IVUS shows that there is a deformation, and that deformation actually led to a stent. This was again corrected with a large stent, and of course, we have to make sure that guide catheter trauma in the ostium and the proximal segments of the RCA are so prone to deforming the stent, and we need to make a conscious effort at changing that practice. This unfortunate surgeon colleague who had a circumflex bifurcation lesion ended up having 2 stents placed in a classical crush pattern, and with a final kissing balloon, no mention of pot in that report. He had a great result here. 10 months later, failed and came back with this recurrence in the OM, which is a rather significant reduction of flow, persistent pain. This is just a cartoon which represents what was done. And a post laser, we got some flow into both those arteries, allowing us to image. And when we image, this is a pullback from the circumflex back, and this is from the OM back into the proximal circumflex. And when you look at it, you realize that in the OM, the residual plaque burden at the edge was rather high, and this would have easily been extended a little further on to get a better stent size. And the stent diameter is just 1.8 in an almost 3 millimeter artery. Same story goes on, and this 4.1 millimeter circumflex ostium rather received just a 2.2 millimeter stent. That too, not completely covering the ostium. There was a deformation of the stent at the branch point in the circumflex as well with an undersized stent. So just everything that is going to spell a failure. When we look at the LAD to the left main pullback, you realize that there's this soft plot which has actually grown in very, all across this to a lumen which is narrowed, which extends into the ostium with an MLA of 3.5. And when such a plaque burden is opposed with an OM which is around this way, and you have carinal tissue as well, then you know that you are going to compromise it. So let's see what happens. We put in a drug-eluting balloon in the circumflex. We did a Wolverine and a trio at a high pressure to get a good expansion of this segment over here. And when we did that, you realize that the LAD had actually worsened. And here a pre-PCI FFR, which might have been negative, does not decide the future of this LAD when it gets compromised. And when you see a compromise in the lumen from 3.5 to 2.2, these LADs, once you put in a stent there, is going to remain, and they will progress because of the trauma. So we have to include the LAD, which we included in our angioplasty. We did a bifurcation. We put a drug-eluting balloon in the circumflex and did a decay crush for the left main and the OM, and this was the result. You can see that the LAD ostium is around 10 millimeters square, and the circumflex ostium is expanded to around 8.55 with a very good expansion of the left main. This is a similar theme when we do left mains, and this was a left main decay crush that was done similarly with all the steps followed. And why did he have a recurrence at the end of 2 years? He had a recurrence because when we go back to our index procedure and look at it, it's very clear that this is what we did. And when we look at the IVUS over there from the other time, we had accepted a 7.3 millimeter square area in the circumflex ostium as rather good. Because we were just blinded by things and saying that just a figure of 7.5 should be good enough for the circumflex. That's not the case really. What we at that time, we did not look at the residual plaque burden of the ostium. We did not try to identify the size of that artery there. And we did a rotational atherectomy for that ISR, and once we did that, the Wolverine did not expand, so we went to a IVL catheter, a 4O IVL balloon, which then further expanded that area, cracked the calcium, and allowed us to improve upon that circumflex ostium cross-sectional area from 7.3 to 12.4. I think we might have done him a favor this time, but we will see in the next 2 years whether he kind of does well with this strategy. Seems like a big improvement, and the plaque burden now is around less than 40%. I think in conclusion, TLR, as I've understood, is a result of under expansion and undersizing, and in these cases resulted from an inadequate lesion preparation for the most part, my own follies, and that's the circumflex. But more important, I realize is the need for caution in the right ostium because of limitations, inadequacies, and mistakes that we make, and our defensive approaches and lack of temperament at times to complete the procedure. I think we need to deep dive into why all this happens, and hopefully we will attempt to make better results out of these cases. Thank you.
Thank you very much. Those are really, really, really great and educational cases. So I'm now going to ask Akiko Mihara to talk about clinical and anatomic scenarios where IVUS is still the gold standard. Akiko?
Thank you. Sorry, I have the trouble. No, I can't.
OCT is becoming very popular. That's why I thought we should hear from her, where it is still very important.
Okay, I've got your slides. Go.
Let me start. My talk is more practical and clinical anatomical scenario where IVUS is still gold standard. So those are the scenario where the IBUS is very important. And let's go through. What is the most important is left main, and both case it's clear left main disease, and left hand side is a little bit unclear. And when we open the IBUS, it's quite different mechanism, and the left-hand side is very severe calcium, and the right-hand side is actually very negative remodeling. So understanding of the disease is very important, and that IBUS is gold standard. This is a case. The distal left main was treated 111 and cured stenting, and looks like okay at the end of the procedure. However, the patient is coming back 2 months later and non-STEMI, and you can recognize osteocircumflex having some thrombus. And we look into the IBUS. This is how it looks like an index procedure at the end. This is now. And what we see in the osteocircumflex was first, underexpanded, and second, there is no stent strut at the carina site and dissection. So that's giving us this organized thrombus. So it is quite important to check how it looks like at the end of the procedure to eliminate this type of the complication. So this is how it looks like in the DK clash. After the stenting into the circumflex, we can check the wire position from the LED pullback. And you can see the circumflex wire here and here, and we can easily recognize where the wire in the longitudinal view. So whenever we do the two-stent technique, the wire has to be proximal portion. In the previous case, probably wire is too distal, making such complication. So after the stenting, what's happening? This is a case from the circumflex to the left main. Only one stent was implanted, and we can see double layer or multiple layer the stent at the ostium. This is so-called stent deformation. Many times happen in the ostial left main. In the Excel trial, it is not rare phenomenon. We see 6.5%, and the majority was left main ostium. And if the patient having the stent deformation, they have poor outcome, even the MSA was corrected. And ostial lesion is very important to do the IBUS as a gold standard. And this is a case, you see the relatively normal distal portion, but proximal portion is very focal calcified ostial lesion. And after the stenting, we thought we finished. However, it was not. And stent was implanted more distally, and ostial right coronary artery was totally missed. That recognition is quite important. And this is really gold standard to do the IBUS. And how it looks like this instantly stenosis at the ostial right coronary artery. As previous speakers spoke, this is quite vulnerable place. And we look into the cause. And we confirm the stent was actually well covered ostium, and the stent was actually well expanded, and actually no fracture or deformation. And really ended up, the main reason was really neonatal aplasia. So understanding of what's happening in the ostial lesion is IBUS is really gold standard. And how about this case? This patient having the proximal LED, and after the balloon, we see the acute occlusion. So in such scenario, we have to understand this is due to the mechanical cause or due to the distal embolization. In such, because already we don't have flow, OCT cannot do, and IBUS is really the gold standard. And what's happening in this case, as dissection extended distally and big intramural hematoma pushing to the lumen. So when we recognize we have to put stent from here to here, that's making very clear. So what about this case? Also, the IBUS is gold standard. This is a patient, 55-year-old woman in the STEMI. And after the wiring, we thought this probably atherosclerotic STEMI, but we have to do the IBUS to understand what's happening. And we did the IBUS, and actually this is SCAT. And very proximal, and this is so normal. And in the middle is all intramural hematoma. It was due to the SCAT. And very important to understand the mechanism of this disease. And then this has to be by IBUS, because if we flash, which making worse and worse, and this is still IBUS is gold standard. How about this case? This is a CTO in the proximal LED. You see the occlusion in the proximal LED from here. And I do believe many people thought proximal cap could be here, but we have to check the IBUS. And we did the IBUS from the limas to this portion. And we recognize occluded LAD and also the possible blood speckle. And actually, the proximal cap is not here and actually here. And this is how it looks like the final after the stenting. So recognition of the proximal cap by IBUS is really gold standard. And reverse cut is also very important using the IBUS as a gold standard. You can see the CTO in the proximal right coronary artery. After the overlap of the wire of the retrograde antegrade wire, we check. And we recognize retrograde wire is intraplaque and antegrade wire is in the subintimal space. This is really the worst scenario of the reverse cut. And we really have to rewire this retrograde wire into the subintimal space. And IBUS can recognize this very simple four pattern of the antegrade and retrograde wire. And as I showed, this pattern is the worst scenario. When we see this pattern, most of the time, I never seen this reverse cut is successful. It's really, you have to redirect the wire. And IBUS is really gold standard to recognize this type of the pattern. And this is a different CTO in the mid-LAD. And after the antegrade dissection re-entry, we recognize the true lumen was collapsed. And I saw this could be the true lumen, but you see the some tissue, and we push more, and we see the true lumen completely. So recognition of the true lumen at the end of the procedure of the CTO wiring is quite important. This is really only IBUS can do. And this case was different. It's very diffuse LAD lesion. We have almost no idea what's the vessel size. And OCT is a little bit tough because we could see only the lumen, such diffuse disease. And we performed the IBUS, and we really surprised and proximal to distal and how big the vessel was. And very distal is 3.0 and proximal is 4.9. In such disease, IBUS is really gold standard to evaluate the vessel size. And finally, this is a clinical scenario which IBUS is gold standard. And this patient was renal insufficiency and having the diagnostic angio, we can do the all procedure without contrast. First, the operator put the wire into the main and side branch, and using this marker, we can recognize how big the vessel was, and 2.5. And after the stenting, again, we perform the IBUS and confirm the minimum stent area. So to summarize, this is a conclusion. This is a scenario where IBUS is really gold standard. Thank you.
Excellent, Akiko. We now have the final talk of the session by Ramesh Dagubati. He's going to talk about IVUS and acute coronary syndromes.
Thank you very much, Gary. Great pleasure being with all of you today, and I'm really humbled to be presenting in front of all of you. So let me just, where is my... So you can see my slides and intravascular ultrasound in acute coronary syndromes. I have no disclosures. I'll just start off with a quick case where imaging has been used, not particularly IVUS. This is a patient with ST elevations. I was called to take care of the acute MI in the midst of an EP procedure. You can see all the ablation catheters. And obviously, without imaging, we could have gone and put a stent in, or balloon and thrombolytics, or all the other medical therapies. So what the eye doesn't see and the mind doesn't know, it doesn't exist. I don't think that's really true. So you have to make sure that your eye can see first. And in this patient, from my prior experience, I kind of suspected what it is. So we went with the GR4, gave nitroglycerin. The vessel did not open up. So put a BMW wire, gentle balloon dilatation with the 2x12 at 4 atmospheres, and then did an OCT. And actually OCT here showed there was no plaque at all. And so, I mean, I just wanted to quickly show that. So obviously, compared to histology and OCT, IVUS, because of grayscale, we always feel that maybe it's not as great. But now with the new high definition IVUS, as was shown by Gary, now you can identify all the 3 layers of intima media and adventitia even with the intravascular ultrasound. So this patient had obviously resistant spasm, and there was no need for any stent in this patient. So in acute coronary syndromes, and what are the cause of coronary thrombosis? Majority of it is due to plaque rupture and or plaque erosion. So rupture occurs in about 60 to 70% of the patients. Erosion is now being detected more commonly, especially in India, where people with the age of 25 and younger present with acute MI, they are having plaque erosions, and obviously some other reasons are calcified nodules. So detecting vulnerable plaques is of great interest for most of us, and on grayscale IVUS, you can have some criteria, whether it is plaque volume, plaque burden, and thin cap fibrinomas. All of them could be detected. And the virtual histology or integrated backscatter can detect what is the lipid core and the spotty calcifications as well. On IVUS can also be signs of acute coronary syndromes. And obviously, I'm not going to be talking about OCT or NERS in this talk. So OCT might appear that it gives a better picture, but we also can easily identify thin cap fibroatheromas, and usually thin cap fibroatheromas are anything less than 65 microns, and the necrotic core, and the cap may be infiltrated by macrophages and lymphocytes, and obviously type 1 collagen. So an OCT, this is how a thin cap fibroatheroma might appear, where you can see that very clearly. But how does it appear on IVUS? We'll look at that. And obviously, there's several stages of plaque formation to rupture, and again repair. And so these are all defined as starry lesions, going from starry 1 to starry 6 lesions, and coming back to the repair and maybe healing of the thrombus and plaque rupture that happens, and maybe resulting in a stabilization of the plaque. So Feita and Ozaki actually looked at these and acute coronary syndromes and the stable angina pectoris as the lesions that can how they look, and IVUS as well. So this is somewhat similar to what you were showing in the first probably of TCT at current MedStar in those days, Washington Hospital Center, right, Gary? Very difficult to know where the plaque thin cap fibroatheroma is on IVUS, but early on, actually, there is a great data to show that detection of spotty calcification in intravascular ultrasound, as you can see in this picture, that actually has been associated with the higher incidence of acute myocardial infarction or unstable angina pectoris as compared to less incidence of spotty calcifications are detected in stable angina pectoris. So you can see, but plaque burden and virtual histology is of great help, giving us much more information on similar to OCT on the plaque burden and how much of a necrotic core is there actually. So this is what I think is much useful rather than just grayscale alone, but combination of IVUS with virtual histology gives us a very clear idea of where the lipid pool is, and similar to OCT here. And I think probably compared to OCT, in my opinion, I think for residents and fellows, they can actually detect with this color differentiation by virtual histology much more clearly where the plaque necrotic pool is. So great study by Gary and Stone and so Greg Stone and partners, and Akiko is the second author in this actually. So detection of plaque burden along with virtual histology, TICFA, minimal lumen area, all of them are important. And in this study, you can see the plaque burden, MLA, more than 70% of the plaque burden, and TICFA or the highest prognostic factors for people with resulting in acute coronary syndrome. So TICFA plus plaque burden plus minimal lumen area less than 4, definitely they have a higher median 3 to 4 year MACE rates in these patients with lesions. So as we know, majority of the TICFAs are 54 to 84 microns, and as I mentioned that now with the high definition IVUS, you can clearly demarcate where the layers of the artery are, and similar to OCT here. So we have done a study in India that we have looked at impact of TICFAs on coronary flow in acute coronary syndromes. The more number of TICFAs are actually are associated with slower flow, but definitely even having a single TICFA there that is associated with the slow flow. So not just having multiple TICFAs, but any single TICFA is associated with the slow flow in this first picture, as you can see. So plaque rupture and TICFA with the varying luminal stenosis. So you can actually see that the luminal stenosis can be assessed by IVUS very clearly. And as with the high definition and virtual histology, and also other features such as positive remodeling, we can identify the necrotic core in these patients which have caused intravascular ultrasound. Again, in Srinivas Reddy and myself, we looked at these people who actually had on intravascular ultrasound, positive remodeling is associated with much higher incidence of necrotic core in about 24% of the patients. And so you can see that another feature where you can detect on IVUS and see that it matters in acute coronary syndrome. So a few slides about new integrated backscatter intravascular ultrasound done by Ozaki in Japan, and looking at the Terumo system, we do not have that, and probably Gary probably can show some in the discussion part that he can talk about it. So how does this look? In lipid core abutting the lumen can be detected by integrated backscatter, and saying that actually these people who have a higher LCAL high chances of having acute coronary syndrome is much higher in these patients. So you, similar, as was shown with the OCT here, now with the intravascular ultrasound, you can clearly assess very clearly that where the lipid core is and the lipid pool is, and where the fibrous tissue is. So in take-home message, and intravascular ultrasound can recognize, as mentioned just earlier by Akiko, that plaque rupture, thrombus, positive remodeling, spotty calcium, and plaque burden and TICFAs can all be identified with the intravascular ultrasound, which is grayscale. Virtual histology and the integrated backscatter IVUS can recognize the lipid pools and the necrotic core, and I think in ACS they're of great value. So with that, I'll stop here and I'll be happy to take any questions. Thank you.
So I think we're actually exactly on time, and we now have 2 live cases, one from Medanta and one from Apollo. Is that correct?
Yes, sir. Yes.
Are they ready?
We can have a few minutes of discussion.
Okay, fine. I don't like to hold up the cath lab if they're ready to do their cases.
Dr. Ramesh, thanks for an excellent talk. You highlighted even the usage of virtual histology in IVUS, especially in acute coronary syndrome type of situations. People use it regularly, the virtual histology. I thought it is hybrid a lot, but not much used.
No, it is actually very useful, and we do use regularly because it's just pressing a button. I don't think you really have to do a lot of technology-wise. It's just a push of a button, you can get the virtual histology.
Colors appear, but do they always correlate with the scenario clinical picture? Kirti is harding the net horizontally.
I know, but I think a prospect absorb. I think Gary or Akiko could comment on that. Nowadays, with the much more usage of virtual histology, is going to come back up. What do you think, Gary?
I think virtual histology is dead.
Yes.
Dead. Okay.
So I think it's even taken off. The new software from Boston it's off the shelf. Really.
Yeah. So Boston's equivalent was never approved. No, actually, Boston had something that they were trying to develop to compete with Volcano's virtual histology. It never was approved in the U.S. And as far as I know, the Volcano virtual histology software is effectively dead. It's actually, every time you develop a new transducer, you have to revalidate and it's been supplanted by so much easier technique. If you're just looking for lipid and necrotic core, something like near-infrared spectroscopy is so much easier and so much more reliable. It really takes a core lab to utilize VH, and even then you have to know how to filter out artifacts.
I think we also felt the same, but we don't use nowadays. Usage of IVUS is coming down slightly in our place compared to OCT. But whichever thing we are comfortable with, we heard from Gary before, and 80% of the times both are interchangeable. But maybe specific subsets like what Dr. Akiko mentioned was very optimal. Unless there is flow, you can't do OCT. So obviously acute MI and total occlusions and osteal lesions and CKD patients were most ideal, which is covered well. I think with your permission, Gary, we'll go to live cases. I see the case.
Absolutely.
Thank you.
Connect to Medanta. Sir, Dr. Praveen Chandra, sir, we can see and hear you. Please start.
So, good evening.
We have Dr. Gary Mids, Dr. Akiko, Dr. Kirti Punamia, Dr. Ramesh.
Okay, good.
You here on this side.
Okay, fine. So the panel is appearing to be absolutely tremendous and fabulous, but we are going to present a simple case today, not so complex, so much complications, but certainly we will have some interest during this case. So along with me is Dr. Neeraj, Dr. Sakshi, and the entire team from Vedanta, and we will present.
Sir, if you give me half a minute, I'd like to mention to you, Gary and Akiko and others, like Dr. Praveen Chandra is most wanted person in the country, both valves and imaging. Kirti also got into valves now. The Praveen Chandra has been doing it before. He is very good at both balancing out Indian products as well as international ones, and extremely difficult to accommodate all the company's requests. So, but he's quite helpful, always cooperative. So, in spite of all troubles and busy schedules, he agreed to do 4 roles. Thank you, Praveen. Over to you. Sorry.
Thank you. Thank you. So thank you, Dr. Srinivas, and it is a pleasure to participate in TCT Asia Pacific, which you are spearheading in such a nice way. And thanks for all the support you are getting from Dr. Gary Mintz and Dr. Akiko, Dr. everybody who's on the panel today, and also the other physicians from US. So Dr. Neeraj, would you like to present this history?
So he's a 67-year-old gentleman, and he presented to us with shortness of breath. Actually, initially he had a class 2 dyspnea, but later on, off late, he had class 3, and when he presented to the hospital, he's in class 4. And he had orthopnea, PND, and in fact, he was in some sort of heart failure, and he was managed conservatively. And once he was fit enough, we did the angiogram, but echocardiogram done prior to angiogram showed that his ejection fraction was only 20%, and he had a global hypokinesia. There was restrictive mitral inflow patterns, PA pressures were raised, and with decongestive therapy, the PA pressures and the LVEDP settled down, and we did the angiography. And the right coronary artery was normal, and there was a LAD bifurcation lesion, and there was a lesion in the large OM, the proximal in the mid segment. And as far as his ECG was concerned, there was no LVVV. In fact, it was a narrow QRS complex. So seeing the whole scenario, the double vessel disease, low EF, a narrow QRS complex with frequent ventricular ectopics, bigeminy and all the stuff, he was managed medically, and his cardiac PET scan was done. And the cardiac PET scan revealed that there is no area of infarction in which, but there was all hibernation in the LAD territory. And the remainder of the segments were well perfused.
Yeah, so we can go to the fluoro, please. Fluoro. Yeah. Okay, so you saw the brief history of this patient. He comes with low ejection fraction and then is found to have coronary artery disease. And his coronary artery disease, as you can see on the fluoro image. Next, please. There is a lesion in the OM which is significant but not critical. And here you see that there is a bifurcation lesion in the LAD. So the idea was that, since he's having significant lesions in the coronary angiogram, it may be a reasonable idea to take him for revascularization, because his ejection fraction is already low and he has no infarcted myocardium. So with this, the plan is to treat this bifurcation lesion first, and then of course we'll treat the circumflex lesion. So at this point in time, we thought that it may be a good idea to assess this lesion very carefully. So we have done OCT also, which we will see a pre-procedure OCT has been done in this patient. So can you show the OCT picture? Yeah. So run it, please. So you can see that the picturization is reasonable because it is done with just saline. We didn't want to give too much contrast to him as a upfront thing. So we have been giving only Visipaque, but the OCT has been done with just saline. So you can see that this is without any pre-dilatation, and there is a fibrocalcific plaque calcification just at the bifurcation, and also just above that there is a chunk of calcium from almost 2 o'clock to almost 6 o'clock position, and here beyond that it is all fibrotic lesion. So maybe at this stage we can have some comments or suggestions or discussion by the panel. Srinivas.
Yeah, this is Akiko. I think that this region is actually majority was lipidic plaque, except the calcium at the site of the bifurcation.
Yes.
That's number one. So, and also because long, but I think the vessel size is actually much larger than what we see by angio. Its distally is almost 3 and the proximal is much larger. So that's very good news. And finally, because you are using the saline, I'm surprised it's very nice picture, but saline is a different inflection compared to the contrast. So measurement itself is a little bit smaller than DL, so about 5% by area. So that's important to understand.
Right.
Most of the calcium is in non-stenotic segments.
Yes, yes. So it is just at the bifurcation. So we have to actually, if we have to, when we are going to stent it, it will be starting from the proximal segment, even between the two septals actually. So that is the area where there is a calcification, and the stent will land up into that area, definitely, because we'll have to treat the diagonal also, it appears, because the diagonal is appearing to be, the ostium is appearing to be tight. So now the question is what kind of technique we'll have to choose before we start doing this procedure. So in our mind, I thought that it may be a reasonable idea, since we are thinking that this is a significant lesion in the diagonal ostium, and the diagonal may need a treatment. So the option could be two. One is that we do a upfront, a DK crush or a mini crush stenting, or an ultra mini crush stenting, or we go for a provisional stent. Yeah, Dr. Mintz.
Yes.
Yeah. So what do you say about this? These two approaches in this case, looking at the angiogram and the images which you saw in the.
I mean, I must admit, I'm a fan of provisional stent strategies.
Mm-hmm.
I don't, even unless the side branch has long diffuse disease,
Mm-hmm.
most of the time you get away with single stent strategies, and there's no data to suggest that routine 2-stent strategies have any benefit compared to a single stent. I think what the OCT shows you is clearly where the landing zones are. As Akiko mentioned, the vessel size, which you have to increase a little bit because of
Mm-hmm.
saline techniques and so on. You've got clear stent length measurements.
Mm-hmm.
Yes, you're going to land the proximal edge in an area of calcium, but that you just have to be careful not to cause a major dissection.
Mm-hmm.
I think, as I said, I'm a fan of one-stent strategies.
Okay.
I think based on the OCT, what we see in the osteodiag, it looks like disease, but we really don't understand what's osteo disease without doing the OCT from the diag.
So show the OCT of the ostium of the diagonal. Yes.
Yeah, Akiko would like you to.
Yeah, just a minute. Yeah. You can see that it is like looking diseased, but not so critical in any, So we can actually opt for a provisional stent strategy. So can you see this image?
Sure.
Yeah.
But I think we are looking at the diag in the 6 o'clock,
Yes,
but we don't see the entire segment. So we just see carina side, no disease, but we have no idea what's rest.
Yes.
So without having the OCT.
I can even do a OCT of the diagonal if you want.
So there are two approaches. One, you do OCT of the diagonal. The second is there are 3-dimensional reconstruction techniques that can give you a better look at the ostium and maybe a couple of millimeters into the diagonal. But it probably takes less time just to do OCT of the diagonal than it is to do the 3D.
I think we can do it quickly. Yes. Okay. So I'm taking the OCT for the diagonal, and then we will see how it looks, because this is very critical. This decision which has to be taken in a bifurcation lesion to get the best outcomes, and doing extra imaging is not bad. And we already have the catheter, so just a small effort and we will know exactly where we are. Okay. So we will just do a short, quick run here. And I think we can do with this thing.
You want this line?
Yeah, 20 ml. 20 ml door lock.
Here, there.
There we are. Yeah. Okay. So the catheter is there. You can see. Can you also show the floor? They can see it. Okay, fine.
Yeah.
Can you put the guide a little bit inside?
Yeah.
Okay. Hold the guide. Hold the guide as you inject. Okay.
Just wait.
Okay. Enable. Just a minute. Okay, fine. This time we use the contrast. And can you show the image?
So the diagram is also big, at least like 2.5.
Yes, yeah, it is a big artery.
Yeah, and
so that is why we have to be, kind of cognizant of the fact that we cannot lose this diagonal at any point. And you can see.
It looks like the region was really only the ostium and kind of negative remodeling. And we see the calcium, so now it's already LED. And then actually the branch of the diag is almost trifurcation.
Yes.
No, go back.
Go back.
So that's a distal diag, which is completely.
Can we see the case and not a Kiko?
Play.
Can we see it?
Yeah.
The case.
Okay.
So we're only seeing a Kiko.
Okay. No, we are seeing the case. Okay, fine.
You see, that's the ostium, kind of trifurcation, and very focal. And then the calcium is minimum and something like fibrolipidic. So I think provisional seems to be reasonable. What do you think? Based on the OCT.
You know, what happens is that there are two things. One is that if you look at this ostium, it looks, reasonably significant to me, at least on the angiogram. And on the OCT also, can you just show the ostium of this diagonal again?
That's not the
No. Yes.
Yeah. That's a place.
Okay. So I think this is a significant plaque here, because why it is so important is that because if we don't treat this ostium well, it will be very difficult to put a stent and expand it completely. So if we are thinking that we have to, there is a 90% chance that we'll have to stent this diagonal. So it may be a reasonable idea to treat this ostium better beforehand and then do a dedicated stenting, rather than just, leaving a very suboptimal result on the diagonal if a stent is required. So this is with this idea, I think that, it may be a good idea to, can you show the fluoro image in the big?
Even the ostium of the diagonal is very fibrotic.
Yeah, it's very kind of fibrotic lesion. So what I was thinking is that we should do a good dilatation of the diagonal, good dilatation of the LAD, and then do a DK crush technique in this case. Because proximal artery is quite roomy. So this is what I was kind of contemplating, and we will go ahead with dilatation now. Give me the balloon, please.
2.5. You want a 2.5 cutting at diagonal?
I know that it's after the EBC results, everybody is now talking of this provisional stent technique and single stent definitely is a good idea, but with such big diagonals, it's not reasonable to leave them behind, especially in those patients where we are thinking that it is all ischemic cardiomyopathy. So we are dilating here.
I mean, that's the other question. Is there another cause of his cardiomyopathy?
1, 2, 3, 4. That, I mean, basically, yeah, we were discussing about this earlier. 2, 3, 4, 5, 6, 7, 8, 9, 10. This is a 2.5 millimeter. I have actually chosen a Wolverine here because I want to really do the ostium also with the Wolverine and the proximal segment where there is bifurcation. So we are doing with just one balloon. Deflate, please. Although in the distal segment, it is not so critical to use this. Check, please. Check a little bit. Okay, go up, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Not opened.
12. Okay, deflate. So I will go to the bifurcation now.
You want to rotate it here?
No, it's okay.
No,
Check, please. Okay, okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8. Deflate. Deflate, please. So I will pre-dilate both these lesions because in my mind I am ready for a 2-stent technique, and hence I will have to do a good pre-dilatation so that the stent expansion is not an issue once we are doing it. Okay, so we have done the pre-dilatation of the LAD. Now we are pre-dilating the diagonal. Here
Wolverine
we are.
2.5 by 10.
Yes, and it is the same Wolverine 2.5 by 10. And we know that this vessel is at least 2.5. So, okay. Virus come back a little bit. Branch mein. Okay. Check, please. Little bit check.
Pull in.
Check. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 15, 16. Deflate. So we have gone up to 16 atmospheres with the balloon, and now okay. So now we'll take a 2.5 into I think 8 or a 12. 12 should be okay. We'll take a 12 stent for the diagonal. Yeah, move the wire a little bit distally. Check a little bit.
Did you measure the median external elastic laminar diameter in the diag?
You can tell how much is the EL diameter in the diagonal.
Distal diagonal.
Diagonal. So you are thinking that we can even go higher with the stent size?
Yeah.
Okay.
Yeah,
We'll
seems
check.
to be large diagonal. Let's check.
Okay. Yeah.
EL to EL.
So the diagonal is quite a
2.6.
big one. How much?
2.6.
2.6.
Oh, okay, I see. Yeah, 2.5.
So we'll take a
is good.
2.5. 2.5,
Yeah,
12?
yeah.
Yes. We'll take a 2.5, 12, please.
And give a 3 millimeter balloon?
Yes. And a 3 millimeter balloon for the
312
LAD. So we'll put a 3 millimeter balloon in the LAD. 312. Give me 2.5, 12. Stent. This is expedition.
This is expedition.
Okay.
Dr. Praveen Dr. Praveen sir.
Yes.
Dr. Srinivas.
Yes. Yes, Srinivas.
Though we always follow mini-tap and tap, many of this bifurcation stenting techniques showed that culotte has a better results because the ostial mesh is not there at all. And we were discussing with Ferenc just 1 hour, session before.
Yeah.
But we also, same with us here, we still follow using, because we always wanted to avoid the 2 layers of stents in the proximal artery.
Yeah, because this artery is not so big. I mean, you know, I would have chosen a culot if it was like a 4 millimeter. I am happier that way. And although on OCT it looks big, but on angiogram it initially, okay. Can you check please? Check please. Okay, give me the balloon. Balloon please. So now we have the 3 into 12.
3 into 12 millimeter balloon.
3 into 12.
For first
Into the LAD. And
Dr. Gary sir, for your doubt of not seeing Akiko big, and when whoever is talking, Zoom automatically selects it to make big, I believe. If you have to avoid it, you have to go to the right corner and pin the picture, whichever you want it to be bigger. So then that will continuously remain big for you.
Okay. Check please.
But all the other delegates who are just logged in for streaming, sir, they're enjoying the program on the bigger screens. In India, we're following first time this screening onto the PVR cinema halls with following all COVID precautions. About 50, 60 at each hub in the country. They're watching these things in the big screen. You see one in the Zoom, the below window, how it is being streamed to outside. You are seeing it below Akiko here. So that's how all others are watching on the big screen. Unfortunately, we panelists and we have to see in this smaller ones.
So I am positioning the stent in the ostium near, you know, for the diagonal. So this is where we are. So how many people like Srinivas, are you happy with this positioning, or you want a little bit more distal, the stent?
No, that's okay.
It looks okay?
Because if you go distally, then you could miss the osteum.
Yeah. But at the same time, we don't want too much of the stent also to be inside. Protruding inside. So just a fraction of millimeter, I would be happy that way.
And what is the general protocol? You first inflate LED balloon and pull it back?
No. I'll just keep the balloon there and we'll do this.
Just to crush, you use it, not to
for the crush, nothing else.
Okay.
Yeah, this looks okay to me.
Some people, what is recommended is inflate the balloon and pull that stent back totally. So
stent.
that
1, 2, 3, 4.
Stent.
5, 6, 7, 8, 9, 10. You see how the stent is expanded very well 12. At 12 atmospheres. 12.
Softly and.
Yeah, very softly, nicely. Yeah, deflate.
Down.
Okay. So I'll pull it a little bit back and go a little higher. Okay.
Yeah.
So I'll do a stent boost. So do a stent boost.
Live.
So you can see the stent boost. No, they can't see this fluoro image. Actually, there is a new system where you can. You see it? Okay, fine. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Stent.
Stent. 10, 12, 14.
I think
it's fully expanded, deflate. So I'll take it out.
We'll take out the balloon. We'll check for the edge dissection and perforation.
So I will check for the edge dissections.
And perforation, there's nothing.
This looks nice. Okay.
So we'll take out the.
So I am taking the balloon out, the stent balloon. Yes. The only thing is, sometimes I have seen that if you don't position the balloon in that main vessel, it becomes a little difficult to cross it if the stent is actually pressing on the other wall of the main vessel.
Yes, sir. It's very important to have a balloon and crush it. Otherwise, many times the struts will make it create trouble.
Okay, fine. So I'll take it out. I have taken the wire and check, please. I don't. Go up now. We are crushing it. Go up. 2, 4, 6, 8, 10, 12, 14, 16. Okay. 16, 18. Take 20. Deflate.
Okay.
So we have gone with a 3 millimeter
NC
balloon. Okay. So we'll recross, do the first recrossing and then do the first kiss. Okay. Yeah, give me a wire, please. Okay. So, Srinivas.
Yes.
So, how many times now these days you do a mini crush, or whenever you are crushing, you always do a decay crush?
For LED, left main definitely, sir. For LED, if the diagonal is not that big, sometimes we may still go, use mini crush or tap, whatever.
Okay, okay. But for left main, you always do a decay crush, right?
Yes, yes.
Okay.
Please.
Unless LCX is totally free from disease, where you just want to do a crossover. You're talking about two stent technique.
Yeah, yeah, that's right. Okay, epicranial.
Now we have distal start.
No.
You generally go distally and then while coming back enter into that thing, or you directly enter the vessel?
No, in this first crossing, I will
Yeah.
try to go as proximal as possible.
Okay.
Okay. Because otherwise I will miss the, the stent will actually do a geographical miss at the carina.
Yes.
So you're fine. Okay.
Generally, but when you're following two stent technique, it may not be that important, but when you are doing provisional, definitely the
Yes.
distal stud crossing will help to.
No, so the second crossing will be distal.
Yeah.
The first crossing is proximal, the second crossing. Give me the balloon, please.
Okay,
A 2.5 millimeter balloon.
2.5 and why?
Yeah. 2.5 balloon. So now I will do a kissing with a balloon in the diagonal and the balloon in the LED. So give me the 3 millimeter till then. 2.5, 2.5, 12, NC track.
Gary, lot of stress is importance is
Or
given
2.5,
to
8.
identify the strut proximal or distal in OCT.
8.
What are your comments on that, sir?
Well, I mean, I think the data shows that it's important, but you can't always achieve it.
Yes.
And you're not doing really OCT guidance. You are crossing into the side branch and then you're checking.
Are you going to check the OCT to confirm the proximal wiring, or you are very confident to wire?
I think we are confident, and yes.
Yeah.
Okay. So I have taken a 2.5 balloon and see how easily it will cross or not. Yes, it has crossed. It is okay. Crossed very well. Okay. Connect, please.
Sometimes if there's difficulty for the stent to enter, we might use a regular balloon also, which is compliant.
Yes.
NC balloon sometimes
yes,
create
sometimes
trouble.
may. Yes, totally agreeable. Yeah, but here it was a 8 millimeter balloon, a rather straight path, so it should be fine.
Angulation was also aligned.
Yeah. So here we are. So this is a 3 millimeter going into the main vessel. Okay. Okay, and I'll pull it a little bit back. Okay. Okay. Yeah, check please. I think we are okay. Yeah. Okay, go up with the 2.5. First we'll open the struts. 2 each, 4 each, 6 each, 8 each. No, 8 for the 2.5. 2,
4, 6, 8.
2, 4, 6, 8, 10, 12.
That's all.
Deflate. Okay. Now I am going to do a kissing. Okay, 2, 4, 2 each, 2 each, 4 each, 6 each, 8 each, 9 each.
Some people prefer going, keeping one at nominal and going the high pressure in the other one. And
yeah, so we have gone to moderate pressures, about 8 to 10 for each of them. And now I'm taking this out. Now we'll take the second stent. So now what size of stent? Second stent, 2.5 or 3? Distally.
I think, what is the measurement on the?
Yeah, the measurement was 2.6.
2.6.
Distally 2.6.
No, that's diag, right?
No, for the
distal,
we can check it again. Yeah, no problem. What is the measurement?
They're asking on the OCT, I think, sir.
Yeah, OCT, yeah, we are showing you. Show the OCT measurement of the distal reference of the LED. It's 2.6.
2.54, 2.56. So about like 5% smaller. So real number is like 2.6 or 2.65. Yeah, 2.5, unfortunately, yeah.
And it's a large, it's a long lesion, Akiko, so maybe a little underperfused.
Yeah, so should we take a 2.75 or 2.75 may also be fine, because I agree that there could be some, because of the saline, because this was a saline injection.
So proximal to the diagonal, it looks quite, the normal segment place, it looks quite okay to take 2.75 also.
Yes. So and then proximally we'll dilate, maybe going up to 3.5 or 3.25. 2.75 into 33.
30 millimeter length.
33.
Probably you need to have lateral amount of stent proximal to the bifurcation also.
Yes, we will have. Yeah. Give me the stent, please. 2.75, 33. Yeah. So I'll take the wire out. Take the wire, diagonal wire out. Okay. Hold the wire, please. So I've taken a 2.75, 33. And we won't go to very high pressures, because distally we don't. Now I've taken this diagonal wire again out. Oh, hold this.
This again is done because to avoid the diagonal wire getting crushed between two layers of stent.
Gets trapped. Okay. Let me check. Light check. Okay.
What stent you have taken, sir?
Yeah, this is again Expedition 2.75 into 33. Okay. Check, please. So distally we are reasonable. We can pull it a little bit back if required. So I want to check in other view also now. Let's check in the
Always important to check in caudal views, the proximal position. Caudal or low caudal.
Absolutely. So we are coming to the areocaudal position and check it again. Looks okay. There is a dissection, listen. There is a dissection which I can see.
Pull it.
You can pull it a little bit back.
In the superior edge.
Yes, in the superior edge, I can see a flap coming up.
I mean, this is Kirti. I was just thinking, would it be better to take a 38 so that you're landed well?
Yeah, in fact, I was thinking.
Because I feel that you undersized your stint in terms of length.
Yeah.
If I look at OCT, I think you should go from landing zone to landing zone.
Yeah.
And that size precisely. You have the imaging tool right there. So why don't you use it?
Okay, epicranial. I was thinking the same.
Yeah.
But I was,
You wanted to come back more, Kirti. What are you saying?
No,
I think that he needs to. He has an OCT run from the LED. He should use that optimally and figure out the landing zone.
So this looks okay to me. This looks okay to me.
You might have a very small area to do a pot proximally. So you might want to extend it a little, cover it all the way to the ostium of the LED.
I can extend it. There is no problem. Okay.
Exactly. Just take that out and take a 38. Go from the ostium to down.
No problem.
And you have enough to do a pot.
Yes.
That streaming type of thing, I think when you checked it when the guest see once without any stent or shaft across, you can see whether there is a dissection proximally, what you're suspecting.
Yeah, there is a small flap which is going up. Yeah, 38. There is no harm in taking. There is no difference. Like if you use a 33 or a 38 for the long run, there is no problem. So I completely agree with Professor Kirti.
Thank you.
You felt in OCT, the disease is starting right from ostium, is it?
No, I think, see, when you have a couple of millimeters of the
Yeah,
ostium,
no,
there's no point in leaving them. You may as well take that ostium as your starting
and also,
point and
what
just take it to
happens
the
is
landing
that you
zone.
will keep, pulling, pushing, and it's just
you're just
trying
mucking
to
around over there. You may as well make a simple procedure.
Yeah, make it faster and then put 2-3 more millimeters, and that's all.
Because I think Praveen mentioned there was a calcified area there. He doesn't want to.
No, that's right. Absolutely. Check, please. Check, please.
Okay.
We have place here. Okay, fine. And then go to ariocaudal. Or ariocaudal is also fine. Check, please. Center. That looks nice. This is what they want. Check, please. Yeah. Okay.
That looks great, actually.
Yeah. Okay, iliocaudal also. I will just reconfirm because I don't want to come into the circumflex now. In that enthusiasm. Yeah, it's overlapping a little bit. It's overlapping. The circ is overlapping. Okay, apicaudal. Check, please. It's okay, but this stent is actually on the half on the marker. Yeah.
Yes, we might want to just come back.
Just
yeah.
Check, please. It's okay. I think we are fine.
Yes.
Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. That's all. Deflate. Epicranial. I'll pull it a little bit back. I think it's done all. Don't inject.
No, I'm not injecting.
It's okay. So the stent distally looks expanded. We went up to
12.
10, 12.
12 is the nominal. 10 is the nominal.
Yeah. All right. So can we have a balloon for the proximal expansion?
What is the size of the
I think finally you will also do a kissing and imaging.
Yes.
If you permit us, we'll go to Chennai and we'll finish that presentation, come back to you. We already exceeded 10 minutes with this.
No problem. Please go ahead. Yeah.
Thank you. I think, can you connect Dr. Gary? Because we wanted YVC to show a robotic PCI, but there are some challenges. That's why he's showing a live in a box case of a robotic PCI. Connect Dr. YVC Chennai and make Medanta mute smaller. Over to you, Dr. Vijay Chandra Reddy.
Hello.
Yeah, we can see you, sir.
I'm audible. Yeah.
1
minute. Good evening, and thank you, Srinivas, a distinguished panel there. I'm very delighted to be a part of this TCT India Asia Pacific. As you said, I had some exigencies and I'm presenting a live in box of a robotic case. So you can actually, I will start the thing. You tell me, we're able to hear now?
Yeah, we are perfect. We can see you and hear you well. Go ahead. So you started your video, that we are not able to increase the sound.
Can you, I'll just.
Did you start your presentation?
Yeah, I'm going to start the presentation. You tell me if you're able to get the sound.
Make the presentation bigger and show. You didn't share? You have to share your screen, I believe, sir.
I did share the screen.
Doctor, you have to share
green
the
one.
screen.
Bottom green.
Bottom green.
Yeah,
it's coming up.
Okay, I'm sorry. Yeah. And thank you very much. Yeah. we are going to do a robotic assisted PCI. I would call it a proof PCI, proof for robotic precision, optimization by imaging with OCT, and optimization of physiology with RFR, pressure wire, all robotic assisted. Let us talk about the case. She's a 52-year-old diabetic lady with chronic stable angina for 3 to 4 months, strongly positive treadmill test, ECG normal, echocardiography normal without any wall motion abnormalities, angiography done a few days back. So let's show the angiogram, almost like a co-dominant right coronary artery with a shepherd's crook. Proximally, you can see the upward going up shepherd's crook, critical mid-RCA lesion. The lesion is a little bit longish from here to here, and then 2 small PDA branches, a leash of branches over here, over here, over here, over here, over here, multiple branches, which will pose a challenge in negotiating the wire using the robotic drive. And we are going to use a pressure wire X because we are planning to check the RFR resting full cycle ratio. We are going to use this RFR measure, which is a non-hyperemic flow parameter, to assess the physiological significance of this lesion and see how at the end of the case the RFR comes out. As we know, RFR of 0.89 and below is significant, and at the end of the case, if you can achieve an RFR of 0.95 or more, we know that physiologically we have achieved an optimal result. The second thing is we are going to, as I said, we are going to use robotic precision in this case to measure the exact length of the lesion, and so that we can choose the appropriate length of the stent. Same, we are also going to do an OCT at the end of the procedure just to see the MAX algorithm wise, we have achieved an optimal result with and without any dissections. So this is a robotic assisted precision optimization PCI. So with 3 arms, precision in selecting the right stent and locating the stent up exactly using the robotic PCI, as well as by flow indices, as well as optimization by imaging using OCT. I will show you the left system as well. She has a mild mid-LAD lesion with some bridging and a diseased thin calibered diagonal. And as you can see here, the left system has mild disease of the circumflex. We are going to start the case in 15 minutes, and as we go along, we'll show you the steps, and then hope we'll have a good educative session. So as we proceed to the case, first we gained the right femoral axis. The radial was weak, hence the femoral. 6F JR 3.5 guide catheter was placed and connected to the manifold, which of course you need a special drive for the attachment to the manifold. Parallelly, the sister had put a sterile cover to the robotic drive, and she had connected the cassette to the robotic drive arm. And now the job is to connect the sheath, the femoral sheath, to the sheath from the sleeve sheath from the robotic drive, so that the control is a drive gate catheter console. A small shape was given to the pressure wire X guide wire, and it was passed through the guide catheter Y connector till the distal tip of the guide catheter, and then the guide wire was put into the guide wire slot of the cassette, and the cassette doors are closed. Then the machine, the robotic console is now ready for enabling. Now I have taken control. The robo console has now been enabled for all the 3 joysticks. I disable the guide joystick and I take over the guide wire manipulation using the second joystick. I have passed the pressure wire catheter just enough so that the transducer is in the proximal part of the RCA for equalization. As you can see, the sister is connecting the wireless transducer of the pressure wire X now. You can see the green light on that. We should take care that we should never put this transducer of the pressure wire button off at any time during the procedure. And as the robotic console is there, sister has to hold that transducer with her hand so that we can get the pressure recording. There was some damping, so we just pull the guide out and the damping has disappeared. There is a pressure wire X, zeroing was done, equalization was done. Then just give 1 ml of dye, manipulate the wire distally, and as I am passing the wire distally, they will be helping me with a little bit of dye injection. Center and a little bit cranial view.
Sir, I think we have a problem with your internet connection, sir. It's not breaking. IVC, sir. Can you hear us? AV team, can you rectify that or inform sir that we are not able to hear him?
Hello?
Yeah. There is some internet problem, sir. We are not able to see
Yes,
that.
yeah, you are able to.
That is breaking. Voice is breaking and the picture is coming jerky.
Increase the volume.
Yeah. And I think you can show the important step of stent placement because I don't know. We are not able to see it continuously. Our technical team says poor internet connection that side.
Yes, sir. That's his. He is not able to hear us also in between. It's lag.
Yeah. It's not only lag. We're getting a lot of jerky break.
Yeah. Okay, I think the internet is not that. I'm
We show
sorry
the
about
important
that.
steps and the final things.
So I was just trying to highlight the fact that in RCA, the RFR probably has an advantage over AFR.
Yeah. You're not worried about putting this wire which is more stiffer compared to the routine wire to robotic PCI because even the routine wires handling is different.
My voice is better off than the live in box.
Yeah, when you talk it is okay, but the live in the box is not coming at all.
Oh, you're not able to see it or you are not able to?
It is coming in jerky motion, sir.
Srinivas,
it is coming in a jerky fashion.
exact length of the lesion. You can choose the anatomic angiographic landing zones, and with the balloon, you put it in the distal landing zone and use something called the reset button here. So, and then drag it back to the proximal landing, and you can have an exact measurement, sub-millimeter measurement of the landing zone to landing zone. This is one part of the robotic PCI precision, which we can use in the procedure. The second part of precision, of course, is here we have chosen the measurement came out as 32.5. So the pre-dilatation balloon helped us in choosing the 32.5 length. So we're going with a 2.5 33 Zine stent. And again, for positioning the stent, precision is going to help out. The sisters in the lab inside, once you tell the stent, they'll load the device. And once the device is loaded, again, I will take over from here and use the joystick for guiding the stent over here. This is a long stent. You can see here, 2.533, but despite that tortuosities with the pressure wire and the robotic drive straight, it went in, and at 14 atmospheres, we had placed it there. And again, the precision part, the second point, every millimeter you can advance the stent or withdraw here. There is a millimeter. So this is another part of the precision. Manually, it is a little bit difficult, especially as Medanta was showing that if you want exact 1 mm positioning, we can do that with the robotic precision. This is another big aspect of the robotic precision PCI. Then after we do that, we check the, this is the RFR. We check the PDPA post-procedure after taking out the stent balloon. It is 1. Perfect angiographic physiological result. And this is the RFR. The RFR post-procedure is 0.99. Wonderful. As we said in defined PCI, any RFR or IFR 0.95 in IFR was used there is an excellent, is good result, but 0.99 is almost like physiological normalcy was established. So you know now that there's unlikely to be any geographic misses or incomplete stent expansions. That is one good part of it. And then, of course, this is the physiology optimization. And now we'll go for the OCT for the optimization of imaging. We have to load the OCT catheter manually with the robotic drive because it will get crushed. Only the Volcano IOS can be used as the current iteration. So OCT catheter, the sister had placed manually, and then we have done an OCT run, and this is what it shows. Well expanded stent, well opposed, no tissue blast, no thrombus, excellent anatomic angiographic result as well. So this is, as I was telling, a classical robotic PCI with precision using the robo, and for optimization by RFR, pressure wire X, and OCT imaging. As to start a PCI robotic program is a little bit of a challenge initially with the learning curve, but then I think once you start doing these cases, you can get a great result.
Thank you, Vijay. Actually, you're not able to appreciate because you are seeing only.
I'll just 1 minute I'll take to just show that.
We see Ajay joining. Welcome, Ajay. Yeah, you can play the video. Otherwise, once you try that, if you want the final picture, what you prepared. If it comes all right, we'll see. Otherwise, we'll go to just.
Yeah. So this is the final shot I'd shown. This is what we have been doing in our institute for the last 1.5 years. Multiple types of cases have been done. This we are pioneering the physiology guidance in robotic PCI as like in this case. So this would be the probable future. In fact, the defined GPS study is going on just to see whether such a physiology guided PCIs are good. And if you can combine both physiology and OCT optimization, I think that will be the future. And if you use the robotic arms for doing all such cases, these are all what we have done in our institute, we will be achieving a lot of benefit for ourselves in terms of radiation reduction and in terms for the patient as well, because we will be doing less of geographic misses, precise positioning, and we can reduce probably unnecessary usage of stents as well. We have done several types of PCIs using the robotic, including even the SVG graft PCIs. So I thank my team for having done a great job with this case, and I'm sorry for the net issues. I think we can have a discussion if you have some time there.
I think we already see Dr. Greg Stone also joining. Welcome, sir. And we just request you to stay for 2 minutes. We'll just see the final picture in the other lab and then come back to your session, sir. Just 2 minutes. Can you connect it to the Medanta lab to see the final? Dr. Praveen Chandra, we are with you, sir. We also have Dr. Greg Stone and Ajay joined here. Dr. Chandra, can you hear us?
Yes, yes, I can hear you. So we have done the, all the steps of, double pressing, and now I'm going to take a final picture for you. We did the 2.75 into 38, and then post dilated proximally with a 3.5 and distally with a 3 millimeter. And this is the final picture I'm going to show you now. Okay. It appears that there is a small dissection proximally in this view. Can we also look at the OCT? I've just done the OCT also. Show the OCT pictures from the very beginning.
The intersections are seen quite well in OCT.
Yeah, yeah. So now you can see this is the distal.
No dissection distally?
No, nothing.
Very good landing, yep.
Yes.
So those are the original lesion start. The lipidic plaque was well pushed. Stent expansion is good, and we don't see the diag yet.
Yeah, we'll see that now. Yes.
That's the, wow, diag is even bigger than LAD.
Yeah, it's quite big.
Yep.
Yeah. So we have done
3.5.
3.5.
And then look into the proximal edge, which is concern.
Yeah,
still
that is the concern.
We see the stent. Oh, there is a dissection. Yeah,
there is
stent.
There is a dissection here, just at the ostium. You see that?
Yep, that's 3 o'clock to 4 o'clock.
Yeah.
That's medial dissection.
Yes, yes, absolutely. So this situation, I think we'll have to fix it. Okay.
First we fix circ.
Yeah.
We'll put the
And we'll put the diagonal wire into the circumflex now before we put the stent in the circumflex. Okay.
I think you can work in peace, sir. Hopefully, we will stabilize everything. Thank you for an excellent demonstration of LAD diagonal bifurcation and usage of OCT, how to demonstrate dissections, optimal stent expansion. Thank you, sir.
Okay. Okay.
Yeah, we
Thank you very much.
Yeah, Dr. Greg Stone already joined. That's why we request you to allow us to break. Thank you.
Thank you very much.
We request Dr. Gary Mitz, sir, to continue because next session, the OCT symposium, again, you are chairing, sir. And this complex PCI session is a DES optimization symposium. We called it as OPCI symposium. And thank you, Dr. Greg Stone, sir, and Dr. Ajay, for always your support and encouragement in running this conference since last decade. This is 12th year. We are very thankful to all the support, sir. This year, we are very happy to say that we had excellent response from the doctors. Maybe due to COVID or various other reasons are gone, but we have 5,000 plus doctors registered for routine registrations. And we have about 1,000 doctors registered for prime registrations, which we are doing this live streaming of this entire Zoom thing. Somehow I wanted to see these pictures which come on from the cath lab on the bigger screens. We will show you a brief video later, which we run in the PVR cinemas here. And about each cinema hall, we are converted to this, we call it as education in entertainment zones, edutainment. And about each hall, about 50, 60 doctors, about 10 hubs across the country are there. We are following all precautions and doing it. In 2 of the states, we couldn't have it. With this brief thing, I now request Dr. Greg Stone and Dr. Ajay. I think we are Dr. Ashok Seth also supposed to join. Did he come in, the AV team? Otherwise, he will be joining. I think Ajay and Dr. Stone, sir, you can take over and conduct this session. Over to you, sir.
Great.
One more request we have, sir. After your talk routinely, we requested to give us about 10-15 minutes time to have some discussion on some other topics apart from the regular stents with you. Thank you, sir. Over to you.
Of course. Well, thank you for having us. This is something that I really enjoy doing every single year with Ajay and Ashok and all the other directors and co-directors. And again, hopefully we'll be able to meet next year in person, but at least for now, this is a great way to do this. So thank you again for having us. So we have a great session over the next hour on the stent decisions that we make every single day. What's more fundamental than choosing the optimal stent for the optimal type of patient, and to really look at the data and clinical experience to see the extent to which this really makes a difference to the outcomes for our patients. So why don't we go directly into it? And our first talk is going to be by Ajay, and he's going to talk about the major differences between durable polymer and bioabsorbable polymer drug-eluting stents, evidence and experience.
All right, thanks so
This
much.
is being done by Dr. Dundas, and Ajay will be talking on the tailoring antiplatelet therapy in our patients, what is old and what is new.
Yeah, there was a slight change in the agenda, and then
I'm sorry, I didn't know
George. No, that's okay. It'll be a great session though, irrespective. And honestly, from our side, you know, it is, as I'd echo Greg's statements, it's too bad that we can't be there. It's amazing that you're able to pull this off in multiple cinemas throughout India, and we just you know, long for the time when we can all be together again. We have to keep deferring it over and over again, but I think it'll come at some point soon. So I'm going to talk briefly about tailoring antiplatelet therapy to our patients specifically. I'll talk a little bit about history and then what's new out there with some data updates in that regard. Here are my complex nuns particularly germane to this topic. So I think it's important to talk, when we talk about antiplatelet therapy and what we're trying to do with it, to speak specifically about stent thrombosis, because for those that are junior and weren't around in these times, it's remarkable that the initial rates of stent thrombosis were almost 20% in the early history of stents. It was only after first Coumadin, then Dextran, and all kinds of anticoagulants that it could be reduced to under 5% levels. But until Antonio Colombo and others sort of identified the fact that you could inflate these stents at high pressure and institute DAP, that then the rates of stent thrombosis became under 1%, which allowed stents to become ascendant as the primary way we would treat coronary artery disease in the cath lab. So that's an important evolution over time. These are just some of the data showing how it got to that point, because again, if you're above 1%, more than 1 in 100 patients having a stent thrombosis, it's going to be very hard for that therapy to be the default. And so it was with studies like this that looked first with aspirin plus ticlopidine that demonstrated reductions in stent thrombosis that stents could then move forward. Now, fast forward several decades, and what you actually saw is that perhaps if we continued dual antiplatelet therapy for longer periods of time, because with drug-eluting stents, we knew there was a risk of late stent thrombosis, could we further reduce adverse events? And that was the primary hypothesis of the DAP trial. And while that study did show that you could reduce ischemic events by continuing dual antiplatelet therapy beyond 12 months, the study also showed that you increased rates of bleeding. And so ischemic events were down, bleeding events were up, and the net of that actually within that study was to show an increased mortality with extended duration dual antiplatelet therapy. That really is emphasized in this slide, which shows that there's no free lunch. There's a risk associated with stent thrombosis, which causes you to try to increase your antithrombotic therapy, but that also incurs a risk of increased bleeding. And so there's a balance here, and in an individual patient, we can't choose a one-size-fits-all approach. We need to titrate the balance of the ischemic risk versus the bleeding risk, and then come up with the best prescription for the patient. And that allows us to maximize their outcomes. And this is just a slide from the DAP study that showed that there was this increased risk of bleeding associated with extended duration DAP. Now, Greg and others have been very involved in the work with looking at bleeding outcomes. George, Roxana, our group. And this was in a paper published in JACC in 2015 that looked at if you had a bleeding event post-discharge, that was associated with a greater incidence of 2-year mortality than if you had a post-discharge myocardial infarction event. And that's one of the reasons why, as cardiologists, we tend to fixate on preventing myocardial infarctions. But as physicians, not just cardiologists, we need to fix on the whole picture, and that's both a combination of bleeding events and ischemic events. This was just an analysis we published from the ADAPT-DES registry, where we actually looked at the specific agent itself and its potency and the response of the individual patient to that agent. And what we basically showed is that if you reduce the antiplatelet effect, in other words, if you reduce platelet activation to the point where platelets are very inhibited, that's great for preventing stent thrombosis, but it also increases bleeding. On the other hand, if you don't really respond, on the right of this slide, to the antiplatelet agent clopidogrel, then your bleeding rate is lower, but of course you're at higher risk for ischemic events. So it's not just the duration of effect, it's the potency of the drug, it's the patient responsiveness, and all of this needs to be taken into account. There's been a lot of interest of late in terms of looking at high bleeding risk with scores out there assessing what this bleeding risk would be. And there are many clinical characteristics and presentation findings that would actually cause what we call predictably high bleeding risk. But then there's also unpredictable bleeding risk. So in some patients, they may be at low risk for bleeding, but then they undergo a car accident and they automatically become at high risk for bleeding. And so there are other things that contribute to that. And I like to show this picture as an example of that. This is a patient of mine, this was with permission, who is very strong. He's an elderly gentleman, has enormous biceps, but he also has this spontaneous bruising, not only in his arm, but also in his face. And this is just from the dual antiplatelet therapy that he's on. So by all clinical characteristics, he might be low risk based upon certain things, but then if you look at him, he's actually higher bleeding risk. And so we need to titrate our therapies to this patient. So let's get to the data. How do we make some of these decisions? Should DAP be titrated based upon clinical presentation? Well, first, if we look at acute coronary syndromes versus stable disease, our guidelines do say there's a difference. And if you have acute coronary syndromes, typically you're going to treat for longer. And if it's stable, you could treat for shorter. And that's true both for normal bleeding risk as well as high bleeding risk patients. This is based upon data from studies like the DAP trial, which looked at the absolute risk reduction in patients with myocardial infarction, which was greater with extended duration DAP than it was for non-acute coronary syndrome patients. In addition, trials like the Pegasus trial, which continued ticagrelor after an MI event and randomized the ticagrelor versus placebo, showed a benefit in terms of reduction in ischemic events for these patients with prior myocardial infarction. So it does appear that patients with systemic inflammation, if you will, systemic plaque vulnerability, are going to benefit from longer duration dual antiplatelet therapy. And there is this one intriguing study, the SMART DATE trial, which looked at discontinuation early in patients with acute coronary syndromes, and there does appear to be a hazard of increased myocardial infarction with this early discontinuation, if you will, versus continuance for 12 months. So I think these MI patients are probably a little bit different. In terms of the type of agent we use, these patients are probably also different because it's one area in the ACC/AHA guidelines where a specific drug is recommended over another specific drug. Unlike the European guidelines, which do that all the time, in the US, we're very loath to do that. And in this particular circumstance, more potent antiplatelet therapy, either with ticagrelor or prasugrel, is preferred to clopidogrel in patients that have acute coronary syndromes, particularly non-ST segment ACS. Finally, I'll point out to this paper here, which basically was a meta-analysis looking at guided versus standard dual antiplatelet therapy. And it did appear that through either escalation or de-escalation based upon guiding the therapy on responsiveness could be associated with increased outcomes. I think there's a lot of controversy in this area because no individual study has shown it, but in amalgamation together, there is this signal that suggests that guidance might be beneficial with the caveats of a meta-analysis, including observational and randomized trials. What about anatomic complexity? Well, it turns out that as you get more complex in terms of your lesion characteristics as defined on the left of the slide, there is a greater instance of ischemic events, and there is some data suggesting that longer duration dual antiplatelet therapy might be beneficial in that patient population. But what's interesting is that if you're at high bleeding risk, then that complexity does not supersede the higher bleeding risk. And if you're at higher bleeding risk, those patients across the board, whether they're complex or not complex, at least in this study, did not benefit from longer duration of DAP. And so it's important that we as interventionalists often fixate on the lesion, but we need to fixate on both the lesion and the patient. And if the patient's bleeding risk is high, that might supersede what we talk about. This was nicely put together in the editorial to that analysis that I showed earlier, where essentially there are a variety of characteristics that go into the decision-making and can guide switching, can guide de-escalation or escalation. I'm not going to go through this in detail. I just show you this slide so that if you want to read the article and read the way it's synthesized, it makes a lot of clinical sense, and it's one of the most updated things that you would potentially read. Now, briefly moving on to minimum duration of DAPT after a coronary stent, and I'm not going to go this in detail because I know Greg is going to cover some of it. I'll point out that this question is, while the studies have been generated and done in patients at high bleeding risk, these data are relevant for all patients because you never know who's going to become high bleeding risk, who's going to have a surgery or otherwise that you might need to discontinue your dual antiplatelet therapy. In addition, because the studies are done in high bleeding risk patients, most of those data can likely be extrapolated to lower bleeding risk patients as well, because they tend to be lower risk as a whole. So there are a variety of ways that you can modify stents and do things to them to make them safer and to reduce their thrombotic risk. And I'm just going to go through some of the data with various stents quickly. If Greg covers it as well, I'm sure he'll do it in more detail. This was the first data sort of looking at a drug-coated stent within liters free that basically showed that you could, with a reduced duration of dual antiplatelet therapy, get better than the results with the comparator bare metal stent. That's the same stent platform as the BioFreedom. And what's important to note is that these things are not commoditized. It's not that they're all one size, it's one size fits all. All of these different stents have different strut thicknesses, they have different polymer types, they have different polymer distributions, elution characteristics. And so my view on this is that in general, you would like to see data with specific stent types demonstrating safety of shorter durations of DAP. That's one of the things we tried to do in the Evolve Short DAP study. This was a registry looking at patients treated with 3 months of dual antiplatelet therapy and then discontinuation to aspirin alone implanted with the Synergy stent. And what we were able to demonstrate is that in these patients that were event-free out to 3 months, there was a very low risk of adverse events, especially stent thrombosis, in the subsequent follow-up period. And this data was published in Circ Interventions. In the Onyx 1 trial, which Greg and I have both been part of, what we aim to do is actually randomly compare 1 month of DAPT with the Onyx zosterolmus-eluting stent compared to the BioFreedom stent, also with 1 month of DAPT. And by randomizing, it's a true apples-to-apples comparison as compared to some of the other registry studies where it's a comparison to a historical control. What we were able to demonstrate is there were really no differences in the primary endpoint of cardiac death or myocardial infarction or stent thrombosis seen with this approach, therefore establishing that a 1 month duration of DAP could be sufficient with this Onyx ZES in high bleeding risk patients, and actually high bleeding risk patients who were somewhat unselected. So this included STEMIs, it included complex PCI lesions, which also differentiates it from some of the other studies that have been out there. We further went and looked at patients in that study enrolled in Europe, combined them with patients enrolled in the US and Japan, and showed that the results of stent thrombosis in particular, but also cardiac death and MI, were quite acceptable based upon the assumptions that we had made previously. You know that there's new data with the Xience stent, similar sort of design as Evolve Short DAP, where we looked at patients, where patients were looked at 28 days and 90 days of dual antiplatelet therapy and then discontinuation. Once again, very low rates of stent thrombosis. This is the 90-day data. This is the 28 data, and also similar to a comparison with the Xience v. USA data as a whole. So with that, I think we have established that shorter durations of dual antiplatelet therapy in high bleeding risk patients can, for the most part, be done safely. It's not proven per se, because we don't have the sample sizes to justify it, but overall it looks pretty good. But are there other options besides shortening the duration of DAPT? And is there a way to perhaps de-escalate therapy? And one of the ones that we've seen a lot of data most recently is monotherapy. So this is one of the first trials that came out with regards to that, STOP-DAPT2, done in Japan. Very high rate of imaging-based guidance. So I want to throw that caveat out there because that's important for clinicians to understand, especially if you're using clopidogrel where you know there's some degree of non-responsiveness. This data is hard to extrapolate unless you're using a lot of imaging, but essentially a course of 1 month DAP appeared to be more beneficial, specifically reducing bleeding risk compared to 12 months of DAP. And that's what these studies will all show, is that if you de-escalate, you're generally going to reduce bleeding. And the question is, do you incur a greater ischemic risk in doing a strategy like that? This was Smart Choice, similar study presented, I think at the same time as STOP-DAPT2, showing that you could reduce bleeding events by just going to P2Y12 inhibitor monotherapy as opposed to aspirin plus the P2Y12 inhibitor. We all know the Twilight study that Roxana Moran led, which was basically a study where aspirin plus ticagrelor was given for 3 months, and then the aspirin was dropped. And in this study, there was a clear reduction in bleeding associated with that strategy without a penalty in terms of ischemic events over the long term. Now, I do think that ticagrelor or prasugrel, for that matter, are probably safer ways to discontinue your aspirin, because as I mentioned before, there's a certain rate of non-responsiveness to clopidogrel. And if you drop aspirin and continue clopidogrel, but the patient's a non-responder, which I know you all see in the South Asian population, then the patient's really on no antiplatelet agent, and that's something that would give me a little bit of concern. There are some studies that have done that, though, at longer periods of time and haven't shown deleterious events. Finally, in the STEMI population from TCO-STEMI, same sort of findings as Twilight, reductions in major bleeding without an increase in ischemic events. Two other final studies I'll show before I wrap up that were presented at ACC, which are, I think, pretty important, are this first one, which was host exam from Korea, where patients who were event-free under DAPT after PCI were then randomized to aspirin or clopidogrel, just one of those agents. And this is something that comes up in the office all the time. In this analysis, there was a reduction in events, thrombotic events, and actually, interestingly, in bleeding events seen with clopidogrel monotherapy versus aspirin monotherapy. I will say, even before this study, this was something I've kind of adopted in my practice for patients that are on dual antiplatelet therapy. I do often drop the aspirin over time, and it was nice to see this data somewhat corroborating that. Finally, the last study I'll show is Talos AMI, which was a trial where patients were treated with aspirin and ticagrelor for 30 days, and then essentially de-escalated to aspirin plus clopidogrel versus aspirin plus ticagrelor. And at least in this study, there did not appear to be a harm to de-escalation to clopidogrel. There was certainly a reduction in bleeding that was seen in the study as well. So I gave you a ton of data, a ton of data points out there, but let's bring it back to the patient and how do we think about titrating DAPT to our patients? I think first, it's important to state that current generation DES are very safe. And recent studies have demonstrated that shorter DAPT durations, especially with the stent types that have been studied, are also safe. And so that's a good thing because it gives us options. But it certainly doesn't mean that it's shorter DAPT for every patient. We need to think about the patient individually, just the clinical scenario, the angiogram itself, and understand that there's specific populations that might benefit from longer or more intensive DAPT duration and potency. And so ACS is one group. I think I showed you examples of that. And then complex PCI is another, although it doesn't necessarily supersede high bleeding risk. Finally, the stent protective effect aspect of DAPT is always a priority. But remember, it's not just about the stent, it's about the overall patient as well. And so this is going to be a moving target over time. That's one of the reasons why we like to continue DAPT, particularly for our higher risk patients. And in that regard, the thing we really want to do is lower bleeding risk. And the way we can do that is by going to monotherapy and de-escalation in that way, which ultimately may be the sweet spot for our patients. Thanks so much for listening, and happy to take any questions at the end of the session.
Thank you, Ajay, for an excellent talk. And what we have been doing was also same. Whenever patients were intolerant, we were stopping aspirin and giving clopidogrel. And probably in future, clopidogrel could take the place of aspirin. And one other point which you highlighted very well is whenever you're moving from DAPT to single antiplatelet, it's not the aspirin which is safer to continue immediately, but the ticagrelor or prasugrel. That's what you mentioned. Though in some resolute onyx, some of them were also put on only aspirin after 1 month. I think that in clinical practice is important to follow, especially as you said, in Indian scenario, we do see little more thrombosis. I think it is very important. I think we are all waiting to listen to Dr. Stone, and we thank once again, and over to you, sir. Your topic is the same, sir.
Well, great. Well, thanks. I'm glad that my talk title didn't change and I didn't know about it. So let me share my screen.
Ajay interchanged with George Dangus.
Okay, you should be seeing my slides. So I'm going to comment the issue of that Ajay discussed, but a little bit differently. And that is how to improve outcomes, or can we improve outcomes by choosing different types of stents? And there's a lot of different types of stents that are out there, and they're constantly evolving. They have been for the last 30 years. So how can we make a difference in our patient outcomes by improving stent selection? These are my relevant disclosures. So it's, just historically looking back, we've come a long way in terms of stent design. These were actually the first two widely used stents in the United States, the Cook GR2, which followed up from the GR1, this clamshell design, and the articulated Johnson & Johnson Palma shot stent. You could see these approved in 1993 and 1994 by the FDA. And when you look at these are so rudimentary. I mean, it's just hard to believe that this is what we were putting in our patients back then. But they amazingly worked. They were really designed initially to prevent acute closure, and they did work because they sealed dissections. But of course, the Achilles heel of these bare metal stents was restenosis, which, as we treated complex lesions, would occur in 50% of patients due to all the neointimal proliferation that would develop after medial injury. So we then decided to put a drug, an anti-proliferative agent, on the stent, and we used a polymer to control the dose and the release kinetics of the drug. And of course, the first two drug-eluting stents were Cypher and Taxus. Marty led the Cypher program. I led the Taxus program. These were FDA approved in 2003 and 2004. These were at originally fairly thick strut stainless steel stents. The polymers were not particularly biocompatible. Sirolimus is a very well tolerated drug. Paclitaxel can be reasonably well tolerated, but it's got a very narrow toxic therapeutic ratio that Boston Scientific got right for Taxus. And we learned a lot from this first generation VES era, particularly when these things worked. They were absolutely amazing. And they would allow you to take the acute result that you would get from your bare metal stent performance and from preventing stealing dissections, preventing recoil, and then basically freeze the result at 1 year, 2 years, 4 years, 7 years. So really fantastic. And we published very transparently that even though these had great anti-proliferative effects, they weren't perfect, but they were very, very good. So target lesion revascularization, the purest clinical surrogate for DES efficacy, was reduced by about 50%. And this is from the summed Taxus program. So we made, again, major improvements. Of course, we introduced a new complication, and this was very late. That is greater than 1 year drug-eluting stent thrombosis, where you get a good result. It would look really terrific initially. The patient would be absolutely fine until suddenly, 3.5 years later, the patient would present with sudden thrombotic occlusion of the stents. And we almost never saw this with bare metal stents. And again, we reported this very transparently. You could see, for example, looking at myocardial infarction in the Taxus program and stent thrombosis as well, within the first year, they were very similar between the two devices. But then between 1 year and 5 years, you could see the curve separating with a higher risk after the first generation drug-eluting stents, both Cypher and Taxus. And we even published this in the New England Journal of Medicine. We learned a lot as to what were causing these early events, which informed future drug-eluting stent design. First of all, delayed healing was very important. Bare metal stents would completely endothelialize, where 6 months after drug-eluting stents, only about 40% of the surface would be covered. We saw that the polymers and, in some cases, the drugs were inducing inflammatory reactions, eosinophilic or giant cell infiltration. There was abnormal vasomotion distal to the stents. And probably most importantly, the polymer and the drug would sometimes cause vascular toxicity, which would cause acquired malapposition. The vessel would just basically grow to try to escape the stent. The stent would be floating in the lumen, and likely not due to that effect, but more due to the underlying inflammation in the vessel, we would get this very late stent thrombosis. So this led to the development of second generation drug-eluting stents, and we tried to address all the different aspects of the three components of a DES. We basically moved to the Limus drugs, and pretty much that's been persistent ever since this time, because again, they're extremely safe and they have a very wide toxic therapeutic ratio. But very importantly, perhaps the biggest difference was we went to very biocompatible polymers. I led the Xience and Promus Element programs in the United States, and I can tell you these are very elastomeric polymers. They have almost no vascular reactions on histology. The Resolute program, initially Endeavor, but then going to Resolute, had a very interesting copolymer dual layer called BioLinks, again, very biocompatible. And importantly, we went to better stent platforms. We thinned out the stent struts. We went from stainless steel to cobalt chromium, which is much more malleable and still has good radial force, to induce less neointima just from the injury from the metallic stent itself. And also the lower stent strut height would lead to more rapid endothelialization. And sure enough, this led to improved outcomes. And again, this was from the Zion Stent program, 4 different trials. We put them together in a patient-level pooled database. And you can see, looking at, for example, 2 years, the overall incidence of MACE, cardiac death, MI, or TLR, was substantially reduced, both by Zion's compared to Taxus. And you could see it was an early difference, so they were safer in the peri-procedural and 1-month period, and then the curve spread over time. And I think what was most impressive was there certainly was greater effectiveness, with about a 1/3 reduction further in effectiveness. But the biggest difference was safety. These devices, particularly I think because of the more biocompatible polymers, were much safer. And you can see stent thrombosis rates, which always about 2/3 of them occur within the first month, were reduced by about 2/3 overall in 2 years with Zion's compared to Taxus, from 2.3% to 0.7%. So now we've really got safe devices, they're more effective, and we can really start treating more complex disease. So do we need better stents as we're in 2021? Why does industry keep spending a lot of money and time and running large trials to iterate stents? And I would argue that we do need better outcomes. The question is how we get them. And why we need better outcomes is to further eliminate early and late stent thrombosis and restenosis. They're not yet zero, neither of them. To reduce the dependency on long-term dual antiplatelet therapy, and Ajay talked about a lot of that, but certainly in still complex anatomy in high-risk ACS patients where you've got ongoing inflammation and activation of the coagulation system and a lot of metal that's prone to thrombose, we still, again, have situations where longer-term DAP does reduce those adverse ischemic events. And we want to improve the lifelong prognosis after drug-eluting stents as relates to the stent. And this one is really important and still not as much appreciated, although recently several groups are publishing on this. This was from our work. We put together 17 randomized trials and 22,000 patients. See, as we've gone from bare metal stents to first generation to second generation DES, target lesion failure rates, these are events that are coming from the stent, as best as we can tell, have gone markedly down, especially from being MS to Cypher and Taxus, but then also, of course, with second generation DS. But what's interesting is if you look from 1 year to 5 years, you see that all 3 stent types have about a 2% per year event rate after year 1. And these are events arising from the stent that are still late stent thrombosis or late restenosis. And we used to think that with bare metal stents in particular, once you got out to 1 year, you were essentially invulnerable. The patient, nothing would happen to them. But actually, that's not really true. And now we know that they clearly are late restenosis and thrombosis events, even with bare metal stents. In fact, first generation DES made this a little bit worse. That's the 9.5%. Second generation DES brought it back down to about 2% per year. And this has now been seen out to 10 years. This was from one of the ISAR test 5 studies, 3,000 randomized patients, randomized to 2 different types of drug-eluting stents. And again, you see what happens within about 1 year. But then again, from 1 year to 10 years, you see this linear increase in target lesion failure events. Here, with a more unrestricted patient population, it's about 3% per year. And it's linear and it keeps going. Data from Japan out to 20 years suggests with bare metal stents, it keeps going. So, what is the etiology of these? Some of this is neoatherosclerosis, some of it is late stent fracture, some of it is ongoing polymer reactions and ongoing inflammation and thrombosis from platelet adherence and lack of coverage, etc. So can we improve these long-term outcomes as well as the short-term outcomes? So how can we further improve metallic drug-eluting stent outcomes? Well, one, we could make the stent struts thinner, okay? Because the thinner the stent struts, the less medial injury there may be just from the stent implantation. And again, the more rapid endothelialization will be. 2, there's the concept of using bioabsorbable polymers. If the polymer is causing inflammation, perhaps removing the polymer after a certain amount of time and restoring the bare metal stent surface will eliminate some of these very late events. And if the polymer is the problem, perhaps we should just eliminate the polymer altogether and just insert a drug-coated stent that does not have any polymer. That will be the safest. And of course, the fourth way would be eliminate the stent altogether, which would be bioabsorbable stents, but I won't talk about that because of time for the rest of this talk. So let's talk about how metallic drug-eluting stents are evolving. This is kind of an expanded picture of the one that Ajay showed. Looking at the early generation to newer generations, you can see we went from paclitaxel and sirolimus to now almost exclusively sirolimus analogs. The polymer material and thickness changed from a lot of durable polymers to a lot of biodegradable polymers. And you can see, though, variable thickness, some of them extremely thin, some of them substantially thicker. And then the platform material and struts have gone, in general, to thinner stent struts types to more, again, malleable struts, such as cobalt chromium and platinum chromium platforms. You could see how big, in retrospect, the early Taxus and Cypher stents were. So our outcomes improved with ultra-thin drug-eluting stents. You would have less side branch coverage, so maybe you'd have fewer periprocedural MIs, less turbulence, more rapid endothelialization to lead to less stent thrombosis and restenosis. That would be the theory. Well, we've done the recent meta-analysis because there's been a lot of work in this area. There have been 16 randomized trials, 20,701 patients with 2.5-year weighted mean follow-up, looking at the overall outcomes of what we can call ultra-thin DES, that is less than or equal to 65 microns, versus more classic second-generation DES, 81 to 120 microns. And you can see these 4 ultra-thin strut DES are Cyro, MyStent, Biomime, and Superflex. So several of these coming out of India. Should be very proud about that. The controlled DES range from Xience to Resolute, Integrity and Onyx to Endeavor, Nabori, and BioFreedom. And overall, target lesion failure was a little bit less with ultra-thin DES, with about a 15% risk ratio reduction at this longest term follow-up, although there is some heterogeneity between studies. When we look at the individual components of target lesion failure and target vessel failure, which are reduced, we see the primary reduction is in target lesion revascularization, which is clinically driven, where here there might be about a 25% reduction in target lesion revascularization. So this probably translates to about an absolute 1% difference in TLR. You'll note there's really no difference in myocardial infarction, although the point estimates are below 1. No difference in stent thrombosis, although the point estimates are below 1. Actually, interestingly, we did have a little signal towards a potential slight increase in all-cause death. This was both for cardiac and non-cardiac, but it did not reach statistical significance, and without a clear mechanism, I suspect it was due to a play of chance. So, our outcomes improved with bioabsorbable polymer-based drug-eluting stents. Again, once the polymer is completely resorbed, now you have a bare metal stent remaining, which should hopefully lead to fewer late and very late stent thrombosis events and possibly less late restenosis. And the polymers in these different stents are gone anywhere between about 4 months and 12 months, depending on the stent design. So polymers are not good for a variety of reasons. I already mentioned the inflammatory reactions that can occur, but also the polymer, again, holds the drug. And you need uniform polymer delivery to get uniform drug delivery. And less appreciated is that as you pass these devices through tortuous or fibrocalcific vessels, you can strip off the polymers. And you can get bonding, you can get webbing, and sometimes you can strip off large swaths of polymer. And this alone can lead to either be a nidus for thrombosis or can lead to restenosis. So we first published a meta-analysis of 89 randomized trials, 85,000 patients, looking at stent thrombosis and other outcomes with bioabsorbable polymer-based DES versus durable polymer DES. And while these devices were a little bit better than bare metal stents, they weren't any better than more contemporary durable polymer DES in any of the measures that we looked at. Perhaps the absolute best test of this was a single randomized trial, which involved the Synergy stent, arguably one of the best bioabsorbable polymer drug-eluting stents. It's relatively thin struts, 74 microns. It's very conformable. It elutes everolimus over 3 months, and it has the bioabsorbable polymer coating of PLGA, which is very thin on the abluminal side only, which absorbs within 4 months. So a very good bioabsorbable polymer stent design. And this was tested in the INVOLVE-2 trial of 1,684 patients randomized to the durable polymer-based Promus Element Plus stent. And you can see there was absolutely no difference in target lesion failure, either early or late. And stent thrombosis rates were also identical between the two devices. So it really doesn't seem that compared to a good durable polymer, a bioabsorbable polymer makes any difference. Now, what about polymer-free drug-eluting stents? Maybe these are the answer. So the concept, theoretically, is that once the drug's eluted, a bare metal stent is left behind. There's no polymer. So this might lead to more uniform drug delivery. You don't have that polymer being stripped off. No adverse polymer reactions at all at any time period. And that might be important because remember, stent thrombosis is most common within the first 30 days and more rapid healing and shorter mandatory DAP duration. But there are potential disadvantages. It is difficult to control the drug and the elution rate from a bare metal stent. And it is possible that some polymers, particularly the fluoropolymers from everolimus eluting Xience stents, are thromboresistant and may promote healing. So the prototypical drug-coated stent, we don't even call them eluting anymore, we call them drug-coated if they don't have a polymer, is the BioFreedom stent. And this is a stainless steel platform in its early iteration. And you can see the abluminal side is micro-etched. And this creates a sub-architecture which is able to basically hold on to the drug long enough to get it to the site of the myocardial injury from the stent stuff itself. Again, this was a relatively thick stainless steel stent, 120 microns, and in early studies, the late loss was about 0.17 millimeters. The other thing to know is that it elutes biolimus A9, which is a limus analog, but compared to the other limuses, it's much more lipophilic. And that is to overcome for the fact that some of the limus is going to get washed off by the time the stent actually gets to the injury site. So again, this will deliver enough of the limus to the injury site to hopefully be effective. So as Ajay mentioned, this was tested in the Leaders Free trial. And the initial concept was that this stent should be the ideal stent for high bleeding risk patients because we knew that bare metal stents we would always treat with only 30 days of DAPT. And after 30 days, there was always a very low rate of stent thrombosis. So the Leaders Free investigators led by Phil Urban took 2,432 high bleeding risk patients and randomized them to either treatment with either a BioFreedom stent or a similar metallic bare metal stent. And they used 1 month DAPT only. And the primary endpoint for effectiveness was clinically driven target lesion revascularization. So do these things act like a drug-eluting stent? And the answer is they do. They reduced, you could see TLR by about 45 to 50%. And then the question is, well, were they safe? And the answer is yes, they were. And in fact, if you looked here, cardiac death tended to be reduced. In fact, myocardial infarctions were reduced with the drug-coated stent compared to the bare metal stent, with no difference in stent thrombosis. Although I will point out the 2% incidence of stent thrombosis at 1 year is pretty high with both of these different stents. So the question is, can contemporary drug-eluting stents do the same thing, even if they do have a durable or a bioabsorbable polymer? And again, Ajay went through a lot of the studies. Most of the contemporary DS have been tested now for short DAPT of either 1 month or 3 months in either registry or randomized trials. And we led the Onyx 1 randomized trial, which I think is important because it is a reasonably powered large-scale randomized trial of 2,000 high bleeding risk patients randomized to the BioFreedom drug-coated stent versus, again, the Resolute Onyx zotorolimus eluting stent, which has a durable polymer and a cobalt chromium platform. And you can see there was absolutely no difference in the overall safety endpoint of cardiac death, MI, or stent thrombosis between the two stent types, and there was also no difference in effectiveness outcomes. And most of the stents that have been tested now have reported either very good registry and some randomized trial data for safety and effectiveness with only 1 month of DAPT. But as I mentioned, the BioFreedom is not a perfect stent because, again, the first generation thick stainless steel struts. And actually, if you look at an all-comers trial, which did not consider using this for its bleeding risk characteristics, but just as a stent, this was an all-comers trial called the Sort Out 9 trial in a large study of more than 3,000 patients, where stable CAD patients had 6 months of DAPT and ACS patients had 12 months of DAPT. And you can see here that the stent did not prove to be non-inferior. And while there were equal rates of cardiac death and target lesion MI, suggesting safety, that the ultra-thin strut Aciro stent compared to the BioFreedom stent had a clearly lower rate of target lesion revascularization. So again, the thinner the struts, the lower the rate of TLR will be, and this led to a clear difference in effectiveness between these two devices. So finally, I want to close to a common issue is what is the role of bare metal stents in the contemporary drug-eluting stent era? And actually, this is from a recent meta-analysis of 20 randomized trials of 26,000 patients. And believe it or not, there's actually been 20 randomized trials of bare metal stents versus new generation drug-eluting stents in a variety of clinical syndromes from stable CAD to ST segment elevation myocardial infarction. And the overall rate of cardiac death or myocardial infarction is actually less with drug-eluting stents compared to bare metal stents, about a 16% reduction. And if you look here, in addition, drug-eluting stents are even safer than bare metal stents. There's about a 1/3 reduction in stent thrombosis, and they're more effective. You can see in this meta-analysis, there's more than a 1/3 reduction in target vessel revascularization, almost a 50% reduction as well. So really, drug-eluting stents, the contemporary DES, this excluded Cypher and Taxis, are clearly safer and more effective than bare metal stents. So in summary, if I was to summarize where we are with stent technology in 2021, drug-eluting stents have gotten really good. Bare metal stents have no role in 2021. Take them off the shelf. But drug-eluting stents are not perfect. Iterative improvements are being made in stent configuration and delivery system construction, but it's difficult to further improve outcomes from where we are. Major outcomes can still be substantially improved by better technique, for example, intravascular imaging, physiologic guidance for lesion selection and lesion preparation strategies, and optimal use of pharmacotherapy, as Ajay mentioned, to balance this risk of ischemic complications versus bleeding. And future major clinical advances are going to require breakthrough technology. We were hoping bioresorbable scaffolds would be the solution to that very long-term ongoing risk of events that we've seen with every single stent, every single permanent metallic stent, and it remains to be seen whether or not newer iterations of bioresorbable scaffolds can break through again and deliver that promise. Thanks very much.
Thank you, Dr. Greg Stone, for an excellent lecture. As usual, we have heard enough of stent talks, and we are excited to hear you again. And welcome, Dr. Ashok Seth, sir, also just joined. We wanted to have, with your permission, sir, we wanted to have slightly different perspective, different opinion from you apart from the stents. If you permit us, we'd just like to ask, because we don't get to talk to you this off the track type of discussion, which is apart from the stents. With your permission, what I would like to ask is, you are a great role model and inspiration for all of youngsters for clinical research, and you pioneered in making left mains coming into interventional cardiology era, and also domains of mitra, clip, and other things. Also, you made positive outcomes by planning the proper clinical trial, I feel. So when did you get interest in this clinical trials? Was it right from your childhood levels, and how did you get into this?
No, I must say when I was a child, I wasn't that interested in randomized trials. I was more interested first in sports and then in girls. But that changed, I think, as I got deeper into medicine. And really, I would say the seminal event that showed me the importance of randomized trials was the Caveat trial. And many of you may remember it, may not remember it. I'm sure Ashok remembers the Caveat trial. We were very excited about going beyond balloon angioplasty, and the first new device angioplasty technique was directional coronary atherectomy, which was a very large catheter where we could excise the plaque, and we would get beautiful angiographic results. We'd rarely see dissections. Maybe the residual stenosis was 10%, but compared to balloon angioplasty, angiographically, it was just night and day difference. And we were 100% convinced that the long-term outcomes would be different. So Eric Topol was the principal investigator and led the Caveat trial, which actually showed a higher rate of periprocedural myocardial infarctions with DCA compared to plain old balloon angioplasty, and no significant difference in restenosis. And that was a shocker to all of us. And it actually then, and Gary Mintz could speak to this, made us look into, well, why was this happening? And really it was intravascular imaging that showed us the mechanisms that we weren't really being very effective with DCA. Not only was it a big bulky device that could actually cause some harm, but we were actually not removing much of the plaque. And again, the angiogram looked fantastic, but angiogram is a terrible discriminator. And so we then were able to do optimal atherectomy type studies and show that we could get better outcomes, but it would require much more aggressive atherectomy, often image guidance, to prove that we were doing a better job. All of that then got supplanted by stents. And again, stents were also very important in the randomized trial era, especially then the FDA was starting to come on and believe that randomized trials were the only way to prove safety and effectiveness, and they wouldn't approve stents in the United States, other than a very short, very strict purpose to treat acute closure. And they insisted on the initial stress trial being done, and that really ushered in the stent era. And ever since then, pretty much, if you really want to understand the relative safety and effectiveness of devices, of pharmacotherapy, of different strategies, you really need randomized trials. That being said, randomized trials do have their limitations, and there's an important role for large observational registry experiences as well to look at clinical practice patterns, and of course to look at low frequency safety events and other outcomes that you can't see in even 2,000 or 3,000 patient randomized trials.
In fact,
that's great, Greg. I think.
Go ahead.
Sorry. Yeah, I was just going to say, I mean, it's an amazing perspective, and I think really important for trainees and people that are not familiar with that history to think about. I just wanted to ask you specifically, Greg, one thing, because I think especially abroad, everybody sees you on the podium and sees you moderating cases and that sort of thing. Can you talk a little bit about your early days recruiting patients and how that kind of has informed how you are today? Because that's a unique perspective that many people don't know. I don't think about you is that, when you were in practice and you were the only guy there and recruiting, maybe talk a little bit about that.
Well, thank you, Ajay. When we started doing clinical research in general, and I really got involved in clinical research as a cardiology fellow. Well, actually, I started even as a undergraduate student, but that was in basic science laboratories. But then as a first medical student, an intern resident, and then cardiology fellow. And for the most part, there weren't big organized research units back then. So we would go consent the patient ourselves, and we would sit there, 30, 45 minutes with each patient. It's describing the pros and cons of a research study and what they would expect from it. And I can tell you, when you do that as a physician, your recruitment rate will be 95%. I mean, if you've got trust with the patient and you really sit and spend the time, very few patients will ever object to being in a well-designed research study, which might be in their best interest. Of course, you can't promise that, but it might be. And most patients really want to help society as well, and that's a real big motivator for patients. But when you use a big system and research coordinators just flying in and saying, here's a study we want you to participate in, I think then you've got more about a 1 in 4 chance for the patients to sign up. So that's just one perspective. But the second perspective is that we didn't have funding for a lot of these research trials. So we would fill out our own case report forms. We often didn't have research nurses. And so, for example, the PAMI trial, which I was one of the co-principal investigators on, led by Cindy Grimes, that changed the world for primary angioplasty. We did that at 12 sites. The database was an Excel spreadsheet, and we had a 10-page paper case report form. And we would, fax the paper case report form to William Beaumont Hospital, and they would enter the data, into an Excel spreadsheet. We had one person outside the physicians that was involved in the stent PAMI trial. So it just really shows you what you can do when you're very, very motivated to address research. And there's no doubt that obviously our systems have gotten much better, and our quality control is much better, and we have more accuracies by monitoring patients and separate oversight, et cetera. But it has come with a cost and loss of the personal touch between the physician and the patient.
Thank you, sir. I think you mentioned to us the negative trial inspired you, and more you came into research. But what is the most positive trial which you had part of it and which excited you more and which gave you maximum happiness? Excel trial?
Oh gosh, I don't know. You know, fortunately, I've led about 130 different trials, and they're all like your children. And so I don't know that I can choose between one of them. But I will say, most recently, the COAP trial, again, of the MitraClip in patients with secondary MR and heart failure, was just such a pleasant surprise. It was such a difficult trial to complete, and then seeing the marked magnitude of benefit, it's really something that none of us had dared hope was going to be that positive. Given the fact that it was the right trial at the right time, because I think the field of mitral valve therapeutics really needed it. And so it was very gratifying to be involved in the COAP trial.
Thank you, sir. And yesterday, Dr. Martilian mentioned that there's a lot of scope for work in heart failure. And what is your future plan? What are your interests in future trials? What is your what do you feel where we should concentrate more?
Well, obviously, you know, the coronary intervention has become, you know, a very mature subspecialty. But as I said, I do really think that we can continue to improve outcomes with appropriate lesion selection, especially with intravascular imaging guidance as well. I think, you know, new techniques such as QFR, you know, angiographic fractional flow reserve assessment, even pre-cath lab lesion assessment for physiology is going to make a difference. We're running the Illumian 4 trial, a 3,500 patient randomized trial of OCT guidance versus angiography guidance, which I think will be very important. Lesion preparation strategies. Ajay and I are involved in leading the Eclipse trial, looking at atherectomy in severely calcified lesions as a routine approach, not just for non-dilatable, non-expandable lesions compared to standard angiographic guidance. And that trial is almost done enrolling. So there's still work to do on the coronary side. But number one, on the coronary side, I'm a total firm believer that to reduce cardiovascular death and myocardial infarction, we have to switch from physiology to the concept of vulnerable plaque. You know, we and others have now shown that you can identify vulnerable plaque, particularly with invasive technologies, but also non-invasively. And we now have to do the therapies trials to prove that either with pharmacologic intensification or with local plaque passivation strategies that we can improve outcomes for patients. And then the second major thing I'll say is that, you know, our field has shifted with an emphasis to structural intervention. And it's really exciting to see what's going on there. Obviously, TAVR is now, I would say, a clear established subspecialty, and now we're playing on the edges of looking at bicuspid outcomes and asymptomatic disease and moderate aortic stenosis, et cetera, et cetera. But mitral valve therapy, tricuspid valve therapies, left atrial appendage occlusion, I think is just really barely getting started, and you'll see more data on that later. We've got a lot of exciting technologies for heart failure, as you mentioned, whether it's interatrial shunts or partition devices, ventricular reconstruction, other types of therapies for heart failure, endovascular baroreceptor modulation, et cetera, and hypertension. Again, structural approaches to hypertension, and Ajay's led a lot of those trials on the renal denervation side. I think all of this is going to really change the way we treat patients with a variety of different systemic disorders, not just that are directly related to the cardiovascular system. And that's not even mentioning endovascular, which of course is continuing to improve outcomes, starting from intracerebral stroke interventions all the way down to the lower extremity.
Thank you, sir. I think George Dangar sir is waiting. We ask him to excuse us for 2 more minutes. Dr. Seth, sir, you would like to ask anything, Dr. Greg, on this perspective?
My comment to Greg is it's just been a privilege to know him for such a long time as a friend, but I've also admired him for all these years. And Greg, I'm going to ask you a very frank question. We've admired, you've been responsible for all the pivotal trials, but we've also admired you for the way you convey your thoughts to all of us at every talk. It's even the most complex subjects and even the most complex trials are made so easily logical by you, simplified, in a manner which is very convincing and in a manner where even in the most debatable topics, we end up being convinced by you. So there's fluency and smoothness of conversation and talk, which you are so admirably convey to everyone. Did that come right from the beginning? Were you a smooth talker all the time? Did you train yourself to be a smooth talker?
He did say he was interested in the
time?
girls. Ashok, he said he was
Correct.
interested in the girls.
I was going to
so
mention
from the
that as well.
beginning,
Well, you give me too much credit, Ashok, but thank you for those kind words. And in terms of simplifying things, maybe it's just that I have a simple mind is all it is. No, look, it's, when I started out, I don't think I had at all that clarity of thought. And to be very honest, and frankly, it just came from a lot of work and a lot of repetition. It really, to me, I think it started from writing and writing again and again and again. And I was not a particularly good writer at the beginning. And I was always a strong science major, but I was terrible in English and those sorts of communicative skills. So I think it just came and over time. And, I did learn that, it's great to have all these thoughts inside your head, but unless you test them, and then unless you can effectively communicate them, then you're never going to be able to have a major impact outside of your own sphere. And so I did spend a lot of time making my own slides. I always write my own manuscripts. Ajay will testify, even when I'm not the first author, I'll always spend 4 to 6 hours reading every word and working on every single word of revisions, et cetera. And I think that's, basically what led to that over time.
Thank you. That's extremely helpful to a lot of audience who's listening to you.
I think
can I just, Srinivas, can I say one thing? Just because I've observed Greg in this way, and it's a good lesson for the junior doctors, is that you do need a level of compulsiveness, just like in a case. And when you check the wire position, you check everything in the same way every single time. That's the same that when you observe Greg, how he, as exactly as he said, when he edits a manuscript, when he prepares a talk, you might say it's the 800th talk. Why do I need to spend so much time doing it? And the reason is because if you don't do it for the 800th one, then certainly you're not going to do it for the 900th one. And then by that time you're obsolete. And it's that obsession with, trying to be perfect and to be compulsive about it that, in my opinion, really sets apart someone like Greg and then others like him as well.
Great.
Thank you. We wish we had more time, sir. But one last word of advice to younger colleagues.
Yeah, if I could just jump in.
Sir.
Greg has set the example for the rest of CRF. Greg's standard is CRF standard. Maybe we don't quite do it as well as he does, but that's, what Ajay described, is the CRF standard. And there's no reason why it can't be practiced by everybody.
Well, Gary, thank you. But now you're making me blush because I do have to tell you, it's so totally true. I mean, I have been blessed by working with people like you and Ajay and Marty and Roxana and George and so many others. And I must say, being around so many other driven, bright people who have their own independent source of ideas has totally contributed to my growth, and it's continued to motivate me as well. But thank you for saying that.
I think, thank you, sir. And we have the last lecture of this session. Other panelists are also joined. We request you to apologize for 10 minutes delay. And we'll have George Danga's talk now on durable polymer versus bioabsorbed polymer. Some of it were touched by Dr. Greg already. Over to you, Dr. George. Sorry for keeping you waiting for some time.
Great. Thank you for inviting me. It's been great to hear and see Greg and Ajay and everyone else. You see my screen?
Yes.
Okay, great. Let me go to the presenter mode. I say great. So I get a chance today to talk to you and have a lively discussion, perhaps if there is time left, regarding durable and biodegradable polymer drug building stents, as if we can make some sense out of this. We have too many stents to discuss. These are my related disclosures. I want to try to group them in order to go forward. As probably indicated in this conference earlier, We have the aspects of recoil and negative remodeling, as well as the neointimal hyperplasia, and the stents have been very successful in isolating one versus another and make us focus on neointimal hyperplasia as a main mechanism of restenosis after stenting, provided the stent is adequately expanded, as alluded in your other sessions, and ultimately how we can target the neointimal hyperplasia by adding a drug on top of the stent. In order to do that, we have to have some type of a polymer in order to hold and elute the stent over the time. May I say also there are some innovative designs of stents without any polymer. I'm not going to go into that at all today, but they do exist. The current DS technology, and forget about looking at the small font, I just want to show you how different the struts are and how much they differ. So just an aerial view of how big or small some of these struts are, the cross-section of the struts. It gives you an understanding of not all metallic stents, or the metallic part of the stent, are not created equal. And even further, there's some research, basic research, indicating that the thinner of the strut, the lower the degree of injury induced by the metallic stent, and the less chance of uncovered stents and less chance of further problems down the line. So in general, thinner strut are preferable, although one must also caution that this is not extensive clinical data. This is just hints from mechanistic studies. An example of the drug-eluting stent with good durable polymer that I'm going to talk quite a bit because it's been used in many trials is the Xience durable polymer that indicates that includes the coating technology with the fluoropolymer, the multi-link design, and the overall stent with an elution principle for specific elution kinetics. Just to again give you an aerial view of how different the stent designs may be among different kinds of stents, you can also see this one here, the peak-to-valley, the peak-to-peak designs of the various stents, and even among the peak-to-peak on the right-hand side, you can see that they vary quite a lot among each other. So adoption to the band, side vertexes may have a lot to do perhaps with CKMB elevations after the procedure or other issues that we may encounter, including deliverability, etc. And obviously, the more deliverable the stent is, the drug-eluting stent is, the less banging or the less injury the stent device itself sustains in the trip throughout the coronary arteries towards a lesion, with less chances of losing parts of the polymer or the drug, and therefore causing some form of geographical miss, some form of non-eluted drug in certain aspects of the vessel wall due to prior injury the stent may have sustained during navigating the proximal vessels. This is a few more details about the fluoropolymer. I think it's very important to understand that this also has been used extensively in the vascular endovascular graft procedure for many years by different manufacturers. It is well, in many ways, it is well, it's very well described and utilized in cardiovascular medicine. I want to stay very shortly to the clinical results of last year with the Xience 28 and 90. This means essentially monotherapy after 28 or 90 days. This is a trial designs with aspirin alone after this type of original dual antiplatelet therapy. And in general, they met their endpoints, which is historical control of the Xience V United States database, highly significant for the Xience 80, similarly highly significant for the Xience 28. And as far as the combined endpoint, always we're interested in interventional cardiology. Stent thrombosis is very close to our heart. Very, very low stent thrombosis, 0.2%, despite the early interruptions of the various things, and 0.3, the definite. The bleeding, needless to say, with less with aspirin monotherapy versus dual antiplatelet therapy, you have a lot of bleeding savings in both of them between 3 and 12 months and between 1 and 6 months. So you have the bleeding savings and you maintain efficacy, very clear results in this aspect. So let's move on to the no polymer, no roller polymer, and how about the biodegradable polymer technologies may have brought on some kind of a revolution here. If you don't need the polymer long term and you just need it to elute the stent, how about the polymer goes away shortly after it elutes the stent? And why would that be? Because theoretically, particularly with the first generation stents, there were certainly some, not that many, but certainly some hypersensitive reactions and inflammation due to the polymer. Again, what kind of polymer? Maybe they weren't exactly fluoropolymers and were other polymers, but nonetheless, they were polymer-related hypersensitive reaction. Over here, I want to say also, when you hear biodegradable polymeric stents, one can say that sure, the strengths and weaknesses allows a prolonged drug release, minimizing risk stenosis with a durable polymer. Ultimately, the polymer itself, for example, the fluoropolymer may have anti-inflammatory and antithrombotic effects, sure, or may improve the stent biocompatibility, certainly, well, but others may not. So you have to be very specific what polymer you're talking about. And the durable polymer come in and say, you know what, well, we're going to all go away. And again, you have to think about it. Some of the biodegradable polymers, they don't go away until a year or so. Is that short enough, for example? If the drug is eluted by a few months, is it short enough that the biodegradable polymer goes away in a year or two? Maybe it's not. So again, you have to be very specific. What is the kinetics of the drug elution and the kinetics of the biopolymer disappearance over the time? So these are some examples of newer generation biodegradable polymer. The top one particularly includes not only the PLLA polymer, but also an ultra thin, super thin metallic stent, 60 microns. And I think that's where also we have to pay attention. Not anything is okay, well, BPDS or DPDS and everything else kind of all the same. Sometimes BPDS may be combined with a super ultra thin stent strut, and that may have certain merits. Let's see how the trial have become. First of all, there's a complex network meta-analysis. I don't need to state the word complex. You can all see on the left-hand side how complex the diagram is of all these comparisons. The cobalt chromium everolimus eluting stent is a common comparator in the middle, and most comparisons have been done with this stent, and you can see on the right side the long-term definite stent thrombosis, not a tremendously lot of difference except for one, of the stent, the BPB by BS in the one before the last, and the long-term definite or probable stent thrombosis, not a lot of difference between the two, unless the top ones that includes the nearly obsolete bare metal stents, as Dr. Stone alluded right before, as well as a well-known obsolete stent, paclitaxel eluting, that's no longer manufactured or distributed. Talking about some trials with biodegradable stents, you can see that they try to compare with the biodegradable polymer. The results are sure they're on the non-inferior aspect, but the stent thrombosis is just a tad higher with the biodegradable polymer. This particular design that you see here in the Swiss trial. And then we have the idea left main trial. Obviously, when it's a left main, what is it? Is bigger size stents. And in the bigger size stents, one can say that perhaps the non-inferiority worked out much better, and there was not a lot of difference in the two groups when the stents are in the biggest of the sizes. A further trial was presented in just last TCT, a rather complex name coming from South Korea, the host-reduced polytech ACS trial in ACS patients. You can see the comparator there on the right-hand side. Durable polymer was that biodegradable polymer, DS, and overall, the results were rather similar. There was a penalty towards a higher target lesion revascularization, and the related device-oriented secondary endpoint was slightly higher in the biodegradable polymer DS, but overall the numbers were rather low, one can say. And this was what underlined this whole situation was that you only had an extraordinarily low 0.1% stent thrombosis with a biodegradable, with a durable polymer, fluoropolymer DS, here extraordinarily low, so that even a great rate of 0.4% came out to be higher than 0.1%. Numerically, not statistically, but again, at the device endpoint, there was other TLRs as well, drove up the endpoint in the over the statistical significance bar for the biodegradable polymer in this very large South Korean study. Talking about Orsiro itself, again, the combination biodegradable with a super thin strut, 60 microns. I'm sorry, I'm missing the micron, is not 60 meters. The thin strut is micrometers. And you can see that the clear result in favor of this type of stent versus the durable fluoropolymer in this one study. The BioFlow trial that you can see here, the 2-year results, the original results rather durable over the time in all aspects of how you compare it. The red is higher than the blue event rates. Talking about in an Indian course, I must also say that the BioMime stent is not available in the United States, however, is again a sirolimus-eluting stent with a very thin strut and indicates some good results of non-inferiority regarding the drug-eluting stent, the biodegradable polymer, the durable polymer, fluoropolymer drug-eluting stent. And again, over here, they have again a combination of biodegradable polymer with a 65 micron strut thickness. Again, maybe that's a good combination, ultra-thin plus biopolymer, time will show. So in conclusion, we know that current durable polymer drug-eluting stents have appreciably improved safety and efficacy profile compared to the first generation DS, and this is particularly true with utilization of the fluoropolymer, which has been used widely in endovascular stent graft for many years before from other manufacturers. Biodegradable DS come in offering great advantages over, in general, the durable polymer DS. However, we have to all understand that they're not a homogeneous class of devices. Not all are the same. There are some ultra-thin biodegradable polymer. Maybe this emergence has something more to say. We need to understand that both biodegradable polymer DS and comparable durable polymer are non-homogeneous groups. An individual stent design comparison should be guarded. So in my opinion, the appropriately sized randomized trials are needed to further determine specific stent design, specific stent to stent, because we have 3 parameters: the polymer, the drug elution, and the type and thickness of metallic stent struts. Thank you so much for your attention.
Thank you, Dr. Dangas, for that lecture. In India, we have a Science platform, which is the leading strength in the country, probably has about 1/4 share in the country. We wanted a talk specifically on that. And we should also thank Abbott Vascular for not only in spending some money for the meetings, but also helping in organization of the meetings. They become part of our organization team. I think Ajay and Greg, all of you know how to organize meetings better. But it's always helpful. Now we also have OCT with them. They have been also helping us in taking this technology to various places. We thank Abbott for making this possible for in our country. And with this, I think live cases are scheduled to are waiting already. We are slightly delayed. Any final words before closure, sir? We have to leave. You said, Dr. Greg.
Not for me. I'd like to thank you for the invitation. I don't know if any of the faculty of the moderators or the panelists would like any comment regarding, but I think it was a very inspiring talk by Dr. Stone before, and I'm glad I got a chance to also fit in and chip in before your live case program.
Thank you, Dr. Greg Stone. You would like to say anything because you have to leave, you said?
Thank you. No, this was a terrific session, and you know, again, I really want to emphasize that the growth in interventional cardiology has really been driven by the advances in technology, our drugs, the techniques that we apply. Of course, you can't test every single one of those in a randomized trial, but they've made a huge difference, and driven, though, all by the science and the careful collection of data and transparent reporting. And I think in that regard, our subspecialty has really served as a shining example for all of medicine. And this has been a great session because I think you've had as faculty, some of the key people that have contributed a lot of the data and a lot of the evolution in our thought processes that have happened both from India and the United States over the last 3 to 4 decades. So thank you again for giving me the privilege to be part of this session.
Thank you, sir. I think with this we'll go on to the next symposium. Ajay, anything? Please.
No, thanks everybody, and once again, congratulations. We'll see people tomorrow. I'll see people tomorrow.
We have your RDN lecture and other things tomorrow. We won't leave you today. Thank you. And now we come to another interesting session on OCT. A lot of interest is happening in the country with this imaging symposium on OCT. And we have none other than Dr. Gary Mitz. He was helpful to us in our session too. Now we request Dr. Gary Mitz, and we have Dr. Ashok Seth, who is very cooperative. We did a live case yesterday, the tower, and my good friend Dr. Sridhar Kasturi. I request all three to chair this session, and other panelists, Dr. Ajay, Dr. Jaspal, Dr. Davidson, Dr. Rajneesh, Dr. Suresh, if you're there, please come on to the podiums. And with this, both live cases are ready, sir. We first go to Bangalore, then we'll go to, after reviewing some, then we go to Chandigarh, and you can interact. Over to you, Dr. Seth and Dr. Gary Mitz and Sridhar.
Thank you very much. I think we're ready to move in the interest of time, so we should go on to the first live case. Welcome to my co-chairpersons, and really it's great to see Gary as well as Sridhar with these, whose comments would be so valuable in this session on imaging and optimization.
Hello, good evening. It's a wonderful working evening at Apollo Bangalore. Thanks for giving us an opportunity to come and share our work with you. I thank the organizing secretary and the chairpersons for today, Gary Mitz, Ashok Seth, and Dr. Sridhar Kasturi. Sir, Dr. Seth has been a father figure for us. We've seen how to twist catheters from you and my good colleagues, Dr. Ajay Swami, Rajneesh Kapoor, and Dr. Arneja. Here at Bangalore, we have a team. Can you just show? My colleague, Dr. Praneeth, Dr. Venkatesh, cardiologist, and my techs, Mr. Sakaria and Mr. Ketan, Mr. Pandu, and my colleague anesthetist, Dr. Mahalings. Here we would be showing you a case of a young lady, just 55 years old, but very calcified disease. It's a 57 years old female, had a typical angina, crescendo for last 10 days, rest angina for last 2 days. ECG was sinus rhythm with ST depression in inferolateral leads, echo, no regional wall abnormality, good LVEF 60%. Diabetic and hypertension for 10 years. Can we just play? This is the right coronary artery. Very diffuse disease in the freeze, please. Very diffuse disease in the PDA. The proximal, angiogram was done elsewhere and they reported a 60-70%. Go to the left side. These are the left injections. There's a very critical lesion in the obtuse marginal, and then the osteoproximal circumflex is densely calcified and diseased. And same with LAD. Can you go to the cranial views? Yes. Yes. You can see here, it's a very diffuse disease, and surgeons thought it's prudent not to do the surgery, and if we could do something percutaneously. And that was the plan. If I may ask the chairs, how do we proceed? Our plan was to do an FFR for the RCA, just to know whether it is significant or not, and we did one. Can we just show the FFR? And it was 0.97, insignificant proximally, and we thought the PDA, if at all symptomatic, will deal later, and we moved on to the left side. Yes, can we play the caudal freeze? This is the angiogram. So there is disease in the distal LAD, looks pretty calcified. The OM is very, very critical, and the osteoproximal circumflex is very densely calcified and, moderate to severe disease. Going forward, the whole outcome depends on how well you understand the disease in the wall rather than just the final results we may achieve by implanting a stent. And that's where imaging is so crucial. And imaging has brought such a great understanding to the disease and the plaque modification that you can very wisely choose whether you want atherectomy, you want opium balloons, or you want shock wave, or you can do away with none of these. So here we had the privilege of doing an OCT. Can we play the OCT? Sorry, before doing the OCT, we knew that it wouldn't cross that critical lesion in OM. We dilated that lesion with a 2.5 millimeter balloon. Can you go ahead, please? Next with the balloon. Yeah. This was pre-dilated with 2.5 millimeter, expanded easily at about 12 atmosphere pressure, NC balloon, 2.5, next. And then we ran an OCT. Can we play the OCT, please? Yeah, it's about 2.3 millimeter distally. Yes, freeze whenever you see, yeah. Go back. Yes, after the dilation, this is the distal lesion which was dilated. There is still calcium between 6 to 10, and then keep coming in. Yes, pretty narrow, you can see dissections. Keep coming in. Right. Okay, that's the broadest space, and then keep coming back. Right. You can see the dense calcium, pretty eccentric between 6 and 10. Next. As we come in, it almost encircles. Come in. Yeah. Come in, please. Yes. This is the ostium of the circumflex, almost 300 degree of calcium, right from, about 5 o'clock to 1 o'clock. And this is the, entry of the circumflex into the left main. Again, it's pretty circumferential. This adds a lot of clarity to how we deal with this plaque before you implant a stent. And left main, you can see here, between 3 and 7, again, there is a significant amount of calcium with lipid-rich plaque. And it's about 4.5 millimeter in diameter. Yeah, that's the calcium. Come back. Okay, can you go to the LAD? And we also did the OCT of the LAD. We didn't expect anything less looking at the circumflex. You can see here completely encased vessel, completely. And the thickness of the calcium is up to 1 millimeter, 1000 microns, more than 1000 in fact. And it's not focal. For a significant length of LAD, the disease is as this. This is the osteoproximal LAD. You can again see about 300 degrees from 12 o'clock to about 9 o'clock. And that's the ostium, very densely calcified. It's about 3.25 millimeter LAD, fully encased. Come back into the left main. Good. Thank you. So, I pause here and ask for your comments.
So I think I would then pass it on to the panelists. I think they should be able to comment on this. So Dr. Mahesh and I think Dr. Swami is also there. So Mahesh, why don't you say that? And I would want you to carry on, by the way, also, because unfortunately for this highly complex case, you have 30 minutes. So I'll let you proceed while Dr. Mahesh answers.
Thank you.
The problem seems to be calcium, and the calcium from the 2.5 balloon, the way it behaved, it didn't seem to be very difficult to get through that calcium in the first place.
Right.
So probably I would just go ahead and do a multiple dilatations, probably with the non-compliant balloon, and then see how the calcium is behaved, and then decide what should be done with the further thing. The LAD looks extremely complex. It is diffuse, and no wonder the surgeons gave it.
Sure.
I think
that's good.
Tackle lesion by lesion again with pre-dilatation, and then decide whether you will Will you go in for an IVL or will you go in for an OPN balloon in this case?
Okay, let me
Sridhar,
tell you.
yourself?
Sorry, let me tell you what I did, because
ahead,
I have
please.
a balloon across the circosteum. We wanted to do a left main bifurcation, but implanted a stent in the distal LAD. We used just OPN 2, 20, and then another 3 into 12. And to our surprise, we got a great lumen, great cuts. Can you just show the OCT after the distal dilatations? Just short of time, so I'm just running
I know
through this.
you're going to go, and I'll just comment on the fact that the big issues here are the osteas, where there's a 360-degree calcification. Osteas of the circumflex behave very badly with balloon
No, I haven't
dilatations.
kept it. I pulled it back.
And so that's one aspect, deep calcification, and the second is landing zones, which you don't have in the LAD very clearly. So this is going to be interesting. But my clear observation would be that I would actually do a shock wave to the osteas very clearly, which means I would do shock wave along the length of the lesion, because for me, osteas are the most important.
Thank you. Now we are at that point where we have taken a shock wave first into the circosteum. It's a 3 millimeter, slightly down. Can I just see?
Highly complex. I must tell you, you're doing a great
Thank
job.
you.
It's a highly complex case.
Thank you. Just go ahead. So we're going to start inflating at about 4 atmosphere. This is a technology where the contrast and saline mix with the impulse produces small sparks which cause sudden formation of air bubble and shock waves. At about 50 atmosphere, it affects the wall. Okay, we gave 10 pulses, and this is how it looks. Can we come back? Deflate. Deflate. Okay, wait. Pressure is coming down. Can I give a Frenin, please? Quick. Frenin? Yeah. Frenin? Good. All right. Get the pressure up. Okay, pressure is getting better. Can I have one injection just to see? Okay, doesn't change much. Can we go again? Another set of pulse. Keep the Frenin ready. Go second 4 atmosphere again. Balloon expands slightly better than the first time. We have started the impulses. This is the second cycle of 10 impulses.
Can we see the fluoro, please?
Fluoro, yes. Yeah, stop. Wait for the signal, therapy signal to switch from orange to green before you deflate. Frenin, please, again. Green. Deflate. Deflate. Okay, we are done. I think we need to accept it for now because of the hemodynamics, and we will check again. I would use half the pulse here and half for the LAD ostia because both are about 3 millimeter.
So the comments I have on this is that once you don't see an expansion of the balloon, you should deliver all the pulses here, because again, you're not doing an adequate job. You will then take a different balloon for the LAD,
right.
But it's still wise to deliver as many pulses, which will get
As
you the
possible.
maximum expansion.
Okay, go again. We're going.
If I can make one comment, there is an upper limit in calcium thickness that the shockwave device will impact. And some of this calcium is more than 1 millimeter. And that's probably the upper limit.
Right. Looking at the ease with which deflate. Looking at the ease with which I could, open the LAD, which are circumferentially calcified with the help of OPN, I would like to try and save these for the LAD ostial. I don't know how appropriate it is.
Good evening, Girish. One comment from me.
Dr. Sridhar, thank you.
Good evening, Dr. Ashok Seth sir and Dr. Means. Actually, when you are doing the LM bifurcation, there are some studies where you can put NC into the LAD ostium and IVL balloon into the LCX ostium. Simultaneously, you deliver the pulses to the LCX balloon. Most of the time, those pulses are also transmitted to LAD. So that time you can give a more effective pulses. Subsequently, you give a additional pulses to LAD. If there's, because compared to LCX, which is a focal, the length of the calcium appears to be less than 5 mm. Whereas LAD diffusely calcified, the requirement of IVL more for LAD, and as Dr. Ashok said, pointed out, the most common site of under expansion LM bifurcation is LCX ostium, seen in 35% of patients. Still, IVL is not behaving properly, and that block modification is not adequate. You may require some plot modification. If you take the OCT also, if the OCT shows the fractures, that is adequate. Are you doing the imaging again after this one?
Yes, I would do an OPN again, 2.5, and then do an imaging to know, should I have to exhaust my pulses here and take another one for LAD?
We won't want to interrupt you. So we would have a discussion amongst ourselves while you do these changes, etc. So please continue coolly because it's a complex case.
Thank you, sir.
So Sridhar, and this is again, are the other panelists here? Because I don't see them. Who else is in the panel? Swami, are you there? No. So we had Mahesh and Dr. Rajneesh was supposed to be there. Is he there? Okay, then we should have a discussion. Gary, I think that was a great comment around the one, your 1 millimeter comment around that. But I don't think, we're looking at that, are we? We're looking at the point that there could be softening of the plaque at multiple areas where it could be thinner than 1 millimeter, and therefore we would get adequate expansion, maybe elliptical, but certainly adequate lumen in that area. Your comments around that. So we're not looking necessarily at that 1 millimeter point or 1.5, but in the deep calcification, we'll have cracks, fissures, or softening without cracks and fissures that would actually lead to an expansion.
Yeah, I mean, it's entirely possible. My impression of the two vessels is that the LAD was essentially circumferentially calcified over its entire length with varying thickness. Yeah. And the circumflex was spotty calcium. But you're still dealing...
Apart from the ostium.
Right. The ostium was the worst. And the ostium, of course, has multiple issues because even if the ostium, the circumflex was not calcified, you still often struggle to get a decent acute result. And sometimes, with a case like this, there is no perfect solution. And sometimes you try one thing, you try the one that you have the best hope for success and the smallest likelihood of complications. Yeah. And if that doesn't work, you then stop, you rethink, and you go to a second option. But these, particularly the LAD, I look at this and I'm just, I don't quite understand why a 57-year-old woman would have this kind of LAD. Granted, she's diabetic, but unless she has something else going on, this is really quite unusual.
Gary, this is India. Welcome to
I know, but still.
We see a lot of this. We see enough of this. I mean, I would say a lot. I would say, none of us are surprised about it. That's all.
Yeah. I mean, I'll tell you, the other place you see a lot of this is in Taiwan for some reason that I don't totally understand.
Right. May I just have a comment? And Sridhar, this is also in relationship. You see the circumflex. If I would have actually rotablated the circumflex ostia, because if it's circumferential, then I know that the guide wire bias gets me a good deep cut. And then the IVL, which is more opposed to the deep calcification, where preferential cuts may happen, and specifically at the circumflex ostia, you get a bigger lumen because of the guide wire bias, and then it actually expands extremely well. So for the circumflex ostia, I would do a rotablator followed by an IVL, And I would take another IVL for the LAD, because we must remember the osteo of the LAD could be 3.5. We don't want to undersize that. That's probably the most important area. So I'd actually do the proximal LAD with the IVL. But I think this case requires 2 IVLs. And unfortunately, because of the expense of IVL, we always seem to ration it out. And rationing means that then we have to end up doing non-compliant high pressure balloon dilatations or an OPN balloon dilatation to get an adequate expansion.
Yeah, I mean, this is not a case where I'd ration the impulses.
Yeah.
So, but the calcium is quite deep-seated, and there was hardly superficial calcium even at the osteo of the circumflex. How effective you think the rota would be?
I'm saying rota plus IVL. You don't. So rotablator gets you eccentrically larger lumen so that your balloon opposes the calcium much better, and therefore you actually are able to fracture even deeper calcification because you're closer to the calcium now than you were to start off without any rotational arthritis.
And the choice of wire also has to be very carefully chosen in these cases because you're using OPN and IVL. If you choose a hydrophilic wire, probably it will come out along with the balloons. They get stuck very badly.
Yeah.
Ashok, this is Ramesh Dagubati. I'm sorry I joined a little bit late. Actually, I just observing.
Welcome,
I just
Ramesh.
want to make one comment. I think in Shockwave, I saw Girish actually going up to 4 and delivering the pulses and then deflating it. Normally, in our practice, at least, we would go up to 7 or 8 and see if it expands well. You know.
Okay. I think he did go up to 6. I think he did go up to 6 after.
6.
That's our practice.
Right.
That after 4 delivering, he would go up to 6 and deflate.
Right. If that was the case, then we did not see actually the balloon expanding. So I would definitely deliver all the impulses, all the pulses right here. Yeah.
So, Dr. Navasanthi, where are you at this time? We've been having some discussions, but not to disturb you.
Great learning. We dilated initially with 2.5 OPN and then 3 OPN. And we are taking an OCT. You can have a live OCT. Can you show live? Ready? Start. Okay. I see a fair-sized lesion. I'm confident that if I implant a stent, I can post-dilate it to a good size.
So 3 to what atmospheres with the OPN ultra high pressure balloon?
I went up to 30.
Okay, 30. And did you get an expansion of the 3 millimeter
Can I
balloon?
show you the cine? Can you show the cine, please, with 3? Show the 3 previous to this. This was OCT. Go back. Go back. 3. Yes. This is the balloon 3 OPN at 30 atmosphere. It looks fairly expanded, maybe eccentric dilatation, but seems a decent volume of lumen.
It does.
Thank you. So can we have a look at the OCT? Are you able to see the OCT?
Yeah.
Thank you. So this is the circumflex OM. We are coming into that lesion. Come back. Yes. Yes. This is well cracked, but still there is narrowing, but not too much calcium though. Come up, please. Come back. Yeah. There are multiple cracks. Lumen is acceptable. Come back. Come to the ostium primarily.
Yeah, because you only worked at the ostium at the moment.
Right.
So,
come back to the ostium.
Yeah, and you.
There's some hematoma. Come back. Yeah, come back. The lumen is not too much, but there are cracks.
But if you go distally slightly, we saw
slightly
cracks.
distal.
Gary, you just saw that cracks. Distally.
Yeah. So there are cracks in the calcium. There's a pretty good sized dissection, and there's a pretty large intramural hematoma.
So I think we will go to LAD now and then try to do the shock wave and then do the stent of the circumflex followed by left main to LAD.
So what strategy of bifurcation are you intending to use? Mini crush?
I think I would do a DK because there is so much calcium. I don't mind little more at the edge of the left main, but I don't want to miss it. So I may prefer a DK crush.
Yeah, but the DK crush has also evolved into a mini crush.
Yes, sir.
It's no more 3 millimeters and 4 millimeters. It's 1 or 2 millimeters.
1 or
now.
2 millimeters. I think that is what I would do. How many? We have another 5 cycles remaining with us. You
So
know
just
what?
while you carry on, again, just want again the audience to start understanding that he's using that at 30. So if we actually got a complete expansion of the IVL, think that we won't have to use ultra high pressure or even high pressure.
Sure.
We could
Call
use
him it.
moderate pressures and still get a good lumen and a good result. But if we're rationing, and that is one of the critiques which happens saying, but after IVL, you don't need to do an ultra high pressure balloon. But it's not just that. In real life, where you have deep and very thick calcification, like Gary pointed out, where you have inadequate pulses because you're rationing pulses in multivessel disease, where you got long lesions where distally would be a 3 millimeter IVL, but proximally that same 3 millimeters being used where it should be 3.5, then you would have to resort to high pressure, non-compliant balloon dilatation post IVL. And in this case, I would use OPN because it's the safest non-compliant balloon. I hope everybody's understanding that. If you use non-compliant balloon to 25 atmospheres,
From the left main,
that's unsafe compared to an IVL at 35, compared to an OPN at 30 atmospheres. Because OPN doesn't expand, it expands minimally.
Okay, I think it will deliver here. 2 pulses, go.
So I'm sure, Navasundi, you heard those comments?
Yes, sir, we did. Now we are going at 6 atmosphere. The next cycle, wherever there was significant calcium, balloon seems to be pretty expanded. Okay, we finished
Look at
one
that
cycle.
calcium on the top. You see that eccentricity of thick? That's the thickest part of the calcium.
Very
That's
true.
why you see the eccentricity on the top itself.
So
Deliver
we
more
will
pulses. Keep 2 or 3 pulses for the ostia. I think you deliver 1 more and then more for the ostia.
Yes,
Ostia
sure.
is the best.
I think this is where I need the most. I will exhaust them here. Go. 6, 6. Yeah, go 6. You can see it's fairly expanded. Okay, come back. Okay, we'll go another cycle. Stop. Okay, deflate. Front in, please. Given, thank you. And it's strange, so much calcium, but not troubling too much. We would only know, only after implanting the stent, the final picture. Okay, wait, let the pressure go up. Yeah. Now, can we go again?
One of the most important comments here is this case should never be done without an imaging. You owe it to the patient, not just to do a good job, but to give him the best outcomes. Any complex, severe calcified stenosis should always be imaged. And I don't necessarily say that for mild to moderate calcification.
One more.
That's a usual part of our lives. We see that increasingly.
Thank you.
But any complex lesion needs optimization.
Come back.
For the best possible long-term results.
Front in.
But despite so much of calcium being there in the ostium and the LED, you see the IVL balloon just went through.
Remember, he's pre-dilated that.
Yeah, with an OPN3.
In the LED?
In the LED too. Okay.
No, IVL would not traverse that calcification very easily.
I did, sir. Can you just show the IVL dilatation 3 of the mid LED?
So, you did a good job.
Thank you. Okay, can we go again? Pressures are better. Okay, now get me a 28 stent. Go, 6 atmosphere. Yeah, this is the most.
And now you finish your pulses.
I think it's expanding fairly well.
Yeah, reasonably well.
Front end, please. One more.
Sridhar, any, your learnings from you.
Very, very
I think we are done.
important. Actually,
I know, precious. I want to wait.
First, assess the block. What is the block? Calcium extent, length, circumference, and those things you have to assess. Once you do the effective block modification, it's important to see that adequate dissections are.
Can I do the imaging? One more is there.
Calcium plate fracture, very important. If the plate, if the calcium plate fractures are seen, Kubo has described very clearly.
Be ready with Frenin when I ask.
Is reduced drastically from 14% to 41%. So that's the reason it's important to see that effective fractures in the calcium, is it there or not? If the calcium fractures are there, that time you implant the
OCT, please.
Once you implant the stent, adequately.
So Sridhar, I think I'm just going to stop you here because I'm going to make a statement and then we're going to actually get Gary in. You said that we need to see fractures and it's very important.
Save this.
Yes.
I'm actually telling you that certainly for IVL, the data tells us, at least for CAD3, that nearly 30% fractures were not even seen. And yet there was no difference in the lumen achieved after stent implantation in those who had fractures and those didn't have fractures. And that was a 100-patient OCT study. I don't believe you need to see those fractures, at least for IVL. I think you're overdoing it. There are numerous mechanisms of softening plaque. Fracture is only one of them. You may have microfractures which cannot be seen by OCT. You may have other mechanisms which actually you don't know. So Gary, I want you to comment on seeing fractures being very important.
First of all, the Kubo study was only balloon angioplasty.
Correct.
Nothing else. The mistake that people make, and I don't have a solution for this, but the mistake is to assume that all calcium is the same. It's not. Some calcium is harder than others. The superficial calcium tends to be harder. And then underneath that, the calcium tends to be less hard to dilate. And at the end of the day, what's important is the minimal stent area and stent expansion and how you get there. We've known for a long time that even though rotational atherectomy, for example, does not change the arc of calcium and you don't see fractures after rotational atherectomy, the stents expand a lot easier. So, sometimes you just have to take what the techniques give you, make sure that your pre-dilating balloon can be fully expanded before you place a stent, have your tools available to work the stent after it's implanted to achieve the minimal stent area. But if you don't have fractures, it doesn't mean you stop. It means that you sort of shift your strategy a little bit. And you recognize, as Ashok said, you won't get these giant fractures 100% of the time. It's nice if you see them, because then you know you're basically done. But that doesn't mean...
No. Usually fractures are not visible.
Where is the
that means we have to take like an open NC or take high pressure NC, see that, because that is not adequate. The rota, sometimes it can shape the luminal area, maybe increase, or it may cause the fractures, or it's only block modification. That time still, if inadequate, if you don't have adequate fractures, take high pressure NC balloon dilatation or take the open NC. Otherwise, put the stent, post stent, you can put the open NC and expand it further. Ultimately, the single most predictor of the ISR is the under expansion.
Okay,
correct.
Give me a 3 mm balloon in LED.
I think I'm going modifying your answer to saying what is most important is that do not implant a stent till your balloon is fully dilated. Yeah. And your biggest predictor of stent under expansion is after IVL, post-balloon dilatation, before you implant a stent. Not fractures, but post-balloon dilatation. And I think that I want to convey to the audience.
Yes.
And by the way, that's been true for what, 20 years?
Yes, Gary. We've learned that even before the days of any of these, apart from rotational atherectomy and everything else. The interesting aspect is calcified lesions are being done for the last 30 years. We
3 mm balloon here. It will not go. OPN will not go.
But we have just more tools and more.
If I may interrupt, sir. Wonderful discussion. We have done the OCT for the LAD after OPN and IVL. Would you like to have a look?
Please go ahead.
Start from inside the stent.
And Dr.
Go inside the
Srinivas,
stent.
you're going to tell us when
Yeah.
to stop, because then we can go into the next case and come back for this final result of now Dr. Nasim.
If you could look here, this is the distal stent. Could you just see the diameter? What does it look like? Freeze.
4.9.
Okay. Look at the length of the diameter here, please. Can you see? 2.75. Actually, I dilated with 3, but even then I've got achieved 275. And now we have used IVL here. Come back into the proximal to mid to proximal LAD. Although it's a circumferential calcium, this is how it's broken. You can see. Not all over, maybe at certain places. Next, keep coming. Yeah. There are big cuts and subhematomas also seen. Yeah. Come back, please. Come back fast. Yeah. You can. It is lumen. What is the diameter? Is something like 2.65. Come back. Come back. Yeah. Now there's a good cut here at 6 o'clock. Come. Not as obvious as a cutting balloon, but lumen looks good. Come to the ostium, if you don't mind. Yeah. I think here, although there are good cuts in the calcium, you can see both 6 o'clock and 12 o'clock. There are good cuts. Come back.
No, sorry. The 12 o'clock is the wire.
No. Can you show that? Yes. Just next to the wire. Can we see there?
Yeah.
Tiny one.
There's small one next to the wire.
Very true. Thank you. Now we intend to stent. I will probably park a balloon, 3 balloon in the LAD and stent the circumflex first. 3.25, that balloon is here, no?
Dr. Seth, sorry to interrupt. I'm Dr. Srinivas Kumar here.
Yes.
You have shown excellent bed preparation and very good OCT pictures of how the calcium gets cracked and all, but we have exceeded time. Girish, we will come back to you. We'll go to Chandigarh and the last 5-10 minutes we'll come back to see your final
last 5
result.
minutes to see the final
Okay.
result.
Thank you. Have a wonderful
Thank you.
evening.
And
Do a great job. You're doing very well, extremely well.
Thank you. Can you kind of make now Chandigarh active? Bangalore, keep it on mute and make Chandigarh active.
Hi, good evening, everyone. Can you see us? Can you listen us?
Yes, Dr. Vijay Varghese, we can see you and very clearly so.
Very nice. Thanks, TCT India, South Asia for the invitation. It's a pleasure and honor for the Department of Cardiology, PGI, to present a live case to the meeting. And good evening to each and everyone, chairperson and the delegates. So let me introduce my team. I am Dr. Rajesh, Professor, Department of Cardiology. With me, Dr. Basant is there. He's Associate Professor in the department. Dr. Ganesh is a Senior Research Fellow, and Dr. Atit is the Research Fellow from the department. I do have Puneet with me, who is looking after IVAS and the FFR. So let's go ahead for the PowerPoint presentation. Dr. Ganesh, please.
Good evening from PGI Chandigarh. Our patient clinical details. This is a 65-year-old hypertensive diabetic female with non-alcoholic liver disease, post-cholecystectomy status. She presented with exertional angina from last 1 year with increasing severity and worsening with episodes of rest pain since last 1 month. Clinical examination was unremarkable. Next, please. Our baseline resting ECG showed few VPCs other than, next, please. Echocardiogram showed a normal LV ejection fraction. Next, please. So diagnostic coronary angiogram was performed, which is showing extensive calcification in the LM LAD and diffuse LM LAD 70% stenosis with mid LAD tight stenosis of 80% seen in epicranial view. Next, please. RC has mild disease and her LV angiogram was showing normal ejection fraction. Next, please. So plan for today is PCF LM LED crossover stenting, provisional single stent strategy to begin with, plaque modification of the calcified lesion, and finally imaging aided PCA optimization.
So this is the case, and this is the angiogram in the EP caudal view. You can very well appreciate a dense speckle of calcification extending. Can you run the first view, please? Extending from the left main to mid LAD. Next view, please. It's the mid LAD till the mid LAD. Next, please. This is the spider view. Osteal L6 seems to be okay with no significant disease. Next view. Just okay, stop. So this is the case. Stop. So this is the case. Left main to LAD disease, which is calcified and the significant one. And the plan is to have a provisional stenting. So, opinion of the chairperson, how should we proceed further?
We can't hear you.
I would pass it on to the panelists, and I think it's Dr. Mahesh, I think, who's there.
Sir, I would like to image the circumflex osteum, confirm that it's actually disease-free and it is safe to go in for the one-stent strategy. Then I would like to image the circa LAD to see how bad or how good the lesions are going to be, and then decide on plaque modification depending on what these two findings are.
Very nice. So here, any comment about say simple versus complex, left main bifurcation and need for say 2 versus single stent is SD?
I think Dr. Sridhar Kasturi, yourself.
Yeah, actually, the lesion length is short, less than 5 mm, limited to ostium, and mainly left main to LAD, very long lesion, calcified. It comes under simple, though complex lesion. The L6 wise, it's not very significant, but it would be preferable to do the IVS and see the plaque burden. What is the plaque burden, more than 55%, or the another luminal area also see, is it less than 3.5 square mm? If that is there, I would prefer to go. But based upon the criteria, a short limited to ostium less than 5 mm, this comes under criteria for provisional stenting of LM to LAD. Post procedure, if there is an LCX pinching is there, then I would do FFR. If the FFR positive, go with the T-tap technique. Or initially go with the simple kissing balloon. Kissing balloon, if the lesion is good flow, no need to intervene. If there's some still a residual lesion is there, some dissection, flow limitation is there, go with the T-tap.
So Gary, while Dr. Vijay Varghese he was doing imaging, would you, for the purpose of giving your pearls of experience and wisdom to the audience, tell us exactly what do you want to see on imaging in this left main? Or what are the criteria that you would say this is that we should be doing a provisional here?
Okay, so let's start with wiring both the circumflex and the LAD, imaging from both the circumflex and the LAD to the left main, and the LAD pullback should go into the aorta with the guiding catheter disengaged. So let's start with the circumflex first. You want to see how much disease is present at the ostium of the circumflex. You want to know the lumen area and the plaque burden. Then your pullback from the LAD to the left
Gary,
main.
how much plaque burden? What's your...
Okay, so it's...
can you specify that?
Sure. 4 square millimeters lumen, 50% plaque burden. Those are the cutoffs. If you have less than 50% plaque burden and a lumen area more than 4, it was actually 3.5 and 50% in the paper, but for easy to remember purposes, 50% and 4, then the likelihood of jailing the circumflex and having an FFR less than 0.8 after single stent crossover is very low.
Okay.
And so you protect the circumflex, and then you stent from the LAD to the left main. Now on the LAD pullback, your questions are distal landing zone in the LAD, where is it and how big is it? What's happening at the ostium of the LAD, how much plaque there is, how much calcium. Does the plaque extend back to the left main? And if so, does it extend into the ostium of the left main? Because if the ostium of the left main is minimally or not diseased, you don't really have to cover the orthosteal junction, and you just find a proximal landing zone. So you've got distal landing zone, proximal landing zone, which gives you the length. Your LAD landing zone gives you the stent size, and your left main size landing zone gives you the pot balloon size.
And you then see the structure of the plaque as well and decide whether you want to submit a plaque notification. Okay, that's
Very
great.
nice.
And so Rakesh, Rajesh, you
yes. Go to the next view, please.
So show yours and also continue to work along with it. So I know you have less time, so you should just
no, it's go ahead.
Most
of the session was delayed, I done most of the work. So let's go ahead. This is the IVUS across the left circumflex. Can you run the run of the left circumflex? So
and I would like you all to note, the audience to note, that he's actually got his guiding out and a wire in the sinus, which therefore he wants to image the ostia. I think that's an important aspect.
Absolutely
Rajesh,
right. Absolutely right.
So this is what Gary was saying.
Here is the run across the LCX. You see it's disease-free. We are reaching to the ostium, and this is the ostia. Left main is somewhat calcified and also disease. It's less than 180 degree of the left main calcification. Left main size is 5. Ostium is relatively disease-free. And an area which we could measure at the ostium of the LCX, the tightest point, turned out to be 5.67. So this is very much suggestive, as Dr. Gary has commented about any area which is, say, more than 3.9 or 4 is the one which can be left, and one can go ahead for the provisional stenting. So and then we next view, please. So before that, back. We did the FFR as well across the LCX. Can you show the FFR? Can you display the FFR? Yes, it's there. So
no.
We
My
have
only comment is that, and once you have a lumen area of that size in the circumflex, the likelihood of having an abnormal FFR is
absolutely right. So what we did, we first did the FFR followed by IVUS, just to have an idea about. So FFR turned out to be, say, 0.96. Post intracoronary adenosine turned out to be 0.89, and thereafter we did the IVUS across the ostial LCX, which had an area of 5.67. So the plan is to go ahead for provisional stenting left main to LAD. Next view, please.
What is the length of the left main?
Sorry?
The length of the left main?
Length of the left main, how much it's, can you measure it? So from here, how much?
8.4.
Let's say 8.4.
You have a pot problem.
Okay, so, and thereafter I did try to have say FFR across the LAD, but then wire was not going across. Next view, please. So it's a BMW wire exchange with a rota wire, and it's the 1.5 rota bar across the LAD. Next view, please.
So did you mean your IVUS catheter did not cross the LAD?
Absolutely right. And then post rota. Next view, please.
लाइव केस चल रहा है उसमें ले जाते हैं.
Can we just have the microphones off, please?
मैं हूँ उस पे online, but they have taken me to a live case which is going on.
Can we just have the microphones off? There's extraneous sounds coming in.
So we had IVUS after rota and balloon dilatation.
So you've done a rotational atherectomy. Is that
So we did the rotational atherectomy with a 1.5 bar followed by dilation with a 3 millimeter NC balloon across the left main to LAD, and then we had IVUS done across the LAD. So run the IVUS across the LAD, please.
So while you're going to run the IVUS, but just one comment I'd like to make, and that again getting Gary into it. Gary, we discussed the measurements of the circumflex when we say that this is adequate and we don't need to involve the ostia of the circumflex into a stent as 4 square millimeters. I actually have a philosophy around this and say, we said that it has to be, if we implant a stent, then the ostia of the circumflex should be 5, ostia of the LAD has to be 6, polygon of confluence has to be more than 7, and left mid has got to be more than 8, at least for the Asia Pacific region, and you can add on, but it's got to be that as minimum, anything above. And if we don't implant a stent, therefore de novo ostias need to be 1 square millimeters less, which means 4 for the circumflex, 5 for the LAD, to say we now don't need to implant a stent. Is that correct?
So I think you have to differentiate between deciding whether to treat and deciding how to treat. So if you're deciding whether or not to treat, then you really should rely on FFR or physiology, period. At least, except for the left main, in which I think imaging is probably as good or better. But I don't really care what the lumen area is in the LAD and the circumflex. If physiology is above the ischemic threshold, leave it alone. It's a little different if you are saying, well, I have a lesion that I have to stent. Do I use 1 or 2 stents? Can I stent from the left main into the circumflex and leave the LAD alone? Can I stent from the left main to the LAD and leave the circumflex alone? Those are different situations, because whether or not you want to admit it, you are affecting the non-stented vessel.
So can you run the IVUS again from the beginning? So after having a rota and also the balloon dilatation with 3 millimeter NC, we had the IVUS done across the LAD. Can you? Okay. So this is the IVUS. Calcification is 270 degree. Length, of course, is big enough, more than 5 millimeter. A indication to go out for the ablation therapy. And at particular point in the proximal part of the LAD, the area is too less. It's how much? 1.9. It's a 1.9. So this possibly is the point where the area of the LAD, despite having the rota and also the 3 millimeter NC balloon dilatation, the area turned out to be 1.9 millimeters square. Next. Next view. Okay. So now question arises after rota and also with the NC balloon, we had a calcified lesion, 270 degree arc. Length, of course, is there. Rota ablated the thing to great extent. What next? Is it IVUL or cutting balloon?
Dr. Rajesh, I think we are running slightly behind. Can you show us what all you have done till now?
Fine. So let's go ahead. There was a need to further dilate the LAD, whether it's a cutting balloon or IVL therapy. So I choose to go ahead for, say, 3.5 millimeter cutting balloon across. It's a 3 millimeter Wolverine cutting balloon from the Boston, with which I had dilated the LAD and also the left main. Next view, please. So this is what I had in a dissection at the ostium of the LAD, which is extending to the left main as well. L6 is okay. Next view, please. Next view, please. So this is 3 into 33 giants across the mid LAD. Next view, please. Next view, please. Next view, please. As the proximal LAD was 3.5, left main is 5. I put a drug-eluting stent 3.5 across the left main to LAD. Regarding the choice of stent, which can be very well discussed here, I did put a synergy stent 3.524 from left main to LAD. Next view, please. Next. So this is the result across the left coronary system. Next. The wire across the L6 was changed. Next. Port was done with a 5. Next. This is the 3 millimeter NC across the mid LAD. Next. 3.5 across the proximal LAD. Next. Next, please. Good flow across the LAD. Next. LCX has some pinching, whether it needs the intervention or not can be discussed very well. Next. I dilated it with 2.5 millimeter balloon just to open up the struct across. Next. This is the ostial LCX. Next. So here we are after doing all the things. So now the plan is to have the final IVS across the LAD. As I had dilated with 2.5 across the LCX, repeat kissing balloon has not been done across the left main. And IVS imaging has to be done across left main to LAD to look for what the result is after having a balloon dilatation with 3 in the mid part, 3.5 proximal and 5 port.
The only thing, Rajesh, I didn't see you do is after the, to do a kissing as the last step of your balloon dilatation of the side branch, which is the circumflex.
Yes. No, I have not done. I am just waiting to go live. This point, I had done the procedure, and now I am proceeding further.
Fine, thank you. Thank you.
So meanwhile, you can go ahead and discuss, and let me have the IVS catheter across left main to LAD.
My suggestion is that you do your kissing and then do a final IVS and then optimize the LAD as you need.
Okay.
Because
so now the question
it's not going to achieve you anything more apart from, we'd rather see your final results. So just go ahead, do your kissing, and then do your final IVSs.
So here the query is whether there is a need to have a kissing. We say 2.5 balloon across the LCX and 3.5 across the LAD, or should I go ahead with the port across the left main only without having a balloon across the LCX? Though angiography LCX ostium seems to be significant, but we can very well go ahead do the FFR and if required IVS as well across the ostium and the LCX to decide about any further dilatation across the ostium. So meanwhile, let me go ahead for the IVS across left main to LAD, and this point can be very well discussed.
My clear, and again I go to Mahesh, who's sitting there, because I think we'll soon. Srinivas, we have 2 minutes to see his final result.
So then let me go ahead for the IVS across.
So Mahesh, Srinivas, do we have 2 minutes or do we?
Actually, time is over. Just check with him.
Okay, I think one comment which is very important out here, and that's to understand, and I think Mahesh come in and Gary. See, when we dilate the circumflex with a 2.5, we are going to move that main branch stent away from the other side. So it's actually a mandatory. The moment you actually start to decide doing a side branch dilatation, the final is KISS. That happened in ABC main. That has happened in every other point. So for a 2-stent strategy, it is a final endpoint. For a single stent strategy where you dilate a side branch, it becomes a final endpoint that the main branch has to be dilated, either a kissing or side pot. So I just want to understand from Mahesh and Gary, and then we can just shift off to see the next point which Srinivas guides us. Okay.
So meanwhile, here is the IVS across left main to LAD. You can carry on, discuss, and have a look on the IVS as well.
Mahesh?
There is no argument about the kissing in from the left main to the circumflex in the LAD. That chapter is actually forgotten, and there's no doubts about it. My only thing was you should do an IVS into the circumflex in this case, because when the dissection came from the left main, from the LAD to the left main, I thought that the ostium of the circumflex may also have been involved in that process. That's what I was a little worried about. But you had a good flow, and probably the FFR, you may do an OCT into the circumflex to see how the ostium is. Kissing and that would be.
So, Dr. Gary, any comment about, say, FFR or IVS across the jailed LCX to look for a significance of it?
Well, I think the circumflex will look, or can look, like it's gotten a lot worse. But if you do FFR across it, it's never abnormal.
Okay.
And the reason is because you really don't get plaque shift. You get deformation of the carina, and it's extraordinarily short. And the circumflex is the artery that least commonly has an abnormal FFR anyway. If you're worried that you had an osteal LAD dissection and that it turned down the circumflex, there's nothing wrong with gently putting an IVUS or OCT catheter into the circumflex, but you have to be cautious because they don't always behave well going through the stent struts.
Very nice. So here is the run from left main to the LAD, and then we are out. Let me remove the catheter. Meanwhile, you can very well discuss the finding of the, can you run the IVUS run? And then just let me know about what next to be done for the LAD. And meanwhile, let me try to push my IVUS catheter across the LCX as well.
Yeah, I think we would soon have to move, Rajesh, but you could tell us that. I would just suggest that we would actually have a kissing. You have to optimize the LAD. It is invariable that the struts would move away from the LAD opposite wall to where you dilated into the circumflex. Your circumflex FFR would be negative, however pinched it may look. And you've yourself actually shown a tremendous case around this, even in the past. And I think that you would end up with making sure your left vein is fine.
Let me have a run across the LCX in case I am able to push the catheter across. And then
I think, sir, your final comments, and we'll break here because
so here we are IVUS.
We should just have Navisundi's final picture.
So this is IVUS across the LCX.
You can just tell us. You do just tell us what the IVUS showed.
Okay. So IVUS is fine across the proximal LCX.
Okay.
Let's
What
go
sort of
for the
area did you-
ostium. Ostium, it's there is no dissection across the ostial LCX. And left main, as we have already seen for the left main to LAD, I can very well have a dilatation with the port of 5.
So my final comments on this are that I think it is good to see a layered provisional strategy. And I think this has been a very nice illustration of a layered provisional strategy with good imaging to optimize the situation. Srinivas, if we can have the last glimpse of Navasundi's case, he just deserves to have a last look.
Just connect
my mic, please. My mic, can you switch on my mic?
Yeah, you're audible, Girish.
Thank you, Dr. Srinivas. And to come back, let me just show you what we did. Show the circumflex stenting, please. Come back. We use a 275/28 Zions expedition into the circumflex position. Go back and show the position caudal. Okay. This is a mini crush. Keep play.
Yeah, it is.
Freeze. Next view, please. Yeah. This is where the circumflex stent inflated. Next. Inflate. Next. Yes. Next. And we post dilated with a 3 OPN, the proximal part. At 30 atmospheres, this is the OPN. Next. Okay. And then we crushed that stent, recrossed, and this was a first case. Next. And then we pre-dilated that LAD again with 3.25 NC 12. Next. And can you freeze? Can you have a look at that circ ostium? Zoom, come back, one frame back. Yeah, zoom it please. Can you see the circ ostium? I think it looks fairly expanded. Come down. Down please, the other direction. Yes. Frame by frame.
Okay, you'll have to move ahead.
Next.
Because we'll have to look at your final result.
Thank you. And then you have the LAD stent. We used a 38 Zions expedition 3.5. Next. You can see, come back, yeah. You can see the expansion of the ostial LAD. Looks fairly all right on the stent itself. Next. And then again we post dilate. First we did the pot 4.5. Next. Next, go forward, fast. That was and then we did the 3.5 in LAD, and we are at this next. Now we are at this. We have just recrossing into the circumflex and doing the final pot.
So proximal crossing or mid crossing, but not distal crossing.
Right.
So you just cross distally.
I will come back for you. How do you think this is?
I think you've done a great job. I think you've done a great
Thank you.
job. I think this is commendable. This is a very difficult case, and you've just done it marvelously, and you've done it with good imaging. And I think we've learned a lot from this. So it's going to be mid, so that to redistribute carina, I'd not even go proximal. I'll just go mid, redistribute carina on both sides, have less of carina or have less of metallic carina, and therefore do a final pot and just do imaging. And I think that's great. Keep in mind that it's a 2.75 and a 3.5 fractal anatomy. Would be probably 4.5 or slightly larger, but then we leave it to Navasundi to actually complete a great result.
Thank you. You made our day, sir.
Thank you, Girish, for excellent demonstration, and thank you, Seth, sir, for concluding. We are running slightly behind schedule, and US faculty have to go for their work. You have to understand. So we request now we'll go to other talks. I think Gary, or you can call upon Dr. Ziad, who have been patiently waiting for his talk. Simplify OCT guidance with MLD Max algorithm. All of us are quite familiar with this now, looking forward to his talk. He's the one who is making it very popular. We have other person, Kevin Cross, also is involved in the same. I think we can stop there and start sharing Ziad's. Dr. Ziad, we're sorry for the slight delay because live cases were slightly delayed. Over to you now.
Ziad's apologies and great to have you.
Hello, everyone. Sorry, I don't mean to put any pressure on anyone. I'm in the middle of my clinic day, so I have patients waiting in the office. So in any case, it's nice to see you. Nice to see parts of a live case. I was able to moderate a live case earlier today. Hello, Gary. Hello, Srini, Ashok, and Sridhar. So I'm going to get right into it and talk about MLD Max and how to simplify OCT guidance. There's a lot of activity going on in the OCT world. You may have heard recently that Abbott has released the next generation of OCT called Ultron. We just did our first cases of it really about 15 or 20 minutes ago. And so more on this in the future about the next steps of OCT. But the good thing is, as Gary has probably described to you earlier, is the importance of developing an algorithm for intravascular imaging is really what gets the best outcomes. Okay, so the best way to handle this, I think, or to talk about MLD Max in the context of a case. So this is a fairly typical case we'd see in the cath lab: moderate right coronary disease, complex bifurcation disease, and a proximal LAD lesion. As is typical in many centers, we calculate the Syntax score in patients with triple vessel disease. This patient has a Syntax score of 22, and the patient elected to undergo PCI, which really means we have to get cabbage-like results specifically on the LAD. So how do we make OCT easy, or in fact, how do we make intravascular imaging easy? We really need to focus on those areas that have evidence to suggest large relative risk reductions in PCI complications and improve PCI outcomes. So we know that in the pre-PCI, we need to understand the morphology, specifically.
Can you make it full screen, please? We are just press the button below. We are seeing half.
Oh, I'm sorry. I thought I was full screen. How do you see it? Is it still small?
We still see slide view, Ziad.
Sorry about that. I'm actually on primary monitor.
Hit F5. Usually that works.
Yeah, I'm actually seeing. 1 second, guys. Sorry, I'm actually seeing the. I'm going to do a new share here.
Probably you can stop share and do it again.
To jump ahead, in the pre-PCI, we know we need to look at the morphology. which is largely an assessment of calcification. We need to determine accurately the length to make sure that we cover the lesion and also that we land in the most normal segments distally and proximally. And obviously the diameter of the stent indicates how much lumen area we're going to get and is probably the most important predictor of long-term PCI outcomes. Post-PCI, we want to look for medial dissection, and because we know that the presence of an edge dissection, particularly at the distal reference, is an independent predictor of target vessel failure. We're looking for apposition largely to prevent us from getting into complications if we need to re-intervene. That's gross areas of apposition, and we know the clinical utility of expansion on PCI outcomes. And so we termed this MLD max because it's something that's really germane to interventional cardiologists. We all want to try to get the maximum MLD, and this is an easy way to remember the steps of an imaging-guided PCI and apply them into practice. So for OCT-guided PCI specifically, I do want to spend just a couple seconds on how we set things up. You connect the syringe and flush the catheter with whatever medium you're going to be flushing the artery with. So if you're doing a saline-guided OCT, this should be saline. If it's contrast, it should be contrast. You purge the catheter with that material. That's simply you're following the steps here on the bottom right-hand corner of the screen. After that, you're going to go ahead and drape the dock. It's very important that you do not hold this black cable and hang the OCT. There's about $100,000 worth of fiber optics in there, and every time you bend this, you damage some of those fiber optics and your image will get worse. And then you simply connect the catheter, and then you follow the instructions on the screen. Once you've connected the catheter, we're going to be looking at positioning the catheter distal to the lesion. We're going to end up purging the catheter lumen, and then we're going to do a little puff to evaluate the clearance to make sure that the guide is engaged. And then we're going to go ahead and perform our pullback. So you can see all of this can be done really very, very rapidly. And in the span of less than 90 seconds, we've done our OCT connection and our OCT acquisition. Now, it's important for those of you who are less familiar to understand the user interface of OCT. And so what you have in the pre-PCI is your co-registered in actually 4D on the angiogram, in the cross-section, on the lumen profile, which I like to call the OCT angiogram, and then in the longitudinal profile. Obviously, one of the benefits of OCT is that it gives you the areas automatically, unlike IVUS where it requires automatic measurements. The OCT is able to detect all of these automatically if you get a good flush clearance. It provides you the L mode and the lumen profile, which is on the bottom, more on that in a moment. And there are important features of OCT which we should acknowledge, and that is the zoom out feature, because in the past when we had the M3 catheter, M5 catheter, it really was very difficult to image the left main. But in fact, now we can zoom out and do the left main, we can do the carotid, we can even do the superficial femoral artery. Now, so let's start with our case. It's 12:30. We're going to do an MLD max guided approach and start by looking for morphology. And so when we look at morphology, of course, it's important to understand the natural and normal layers of the OCT. You can see the innermost layer is the intima, that's bright orange. The inside layer of that is the internal and external elastic lamina bounding the media. Outside of that is the adventitia. And that's important because anytime we look at an OCT, we're going to be able to look, we want to look for some of those features. OCT is, image interpretation is dependent on the concept of signal attenuation. And to understand that, let's take this hypothetical situation where you flash a flashlight into a bowling ball. If the bowling ball is black, all of the light will become blocked. This is high attenuation. If you shine your flashlight into a crystal ball, of course, the light will hit the crystal ball and refract. So the light is bent, but you're still able to see behind the image. That's low attenuation. So anytime you see any OCT cross-section, we want to ask ourselves, can you see the EL and can you see the adventitia? If you can, the artery is normal or fibrous. And only in this situation, if there's a signal change, do we end up looking for pathology. And by using an algorithmic approach of looking in the rope and the adventitia and looking in the lumen or the wall and understanding high or low attenuation, we're very quickly able to determine what the lesion morphology is for all OCT cross-sections. Now, the most important one from a clinical standpoint is actually the low attenuation signal that you see in the wall, and that's in the in the wall, and that is calcium. So what you'll notice, if you know calcium is a crystal, so if you shine light through a crystal, the light will refract, and so you're able to see behind it. And the reason calcium is important is because it is the one parameter on morphology that is the most likely to get you into trouble. Because fibrotic and lipidic lesions yield after even direct stenting or compliant ballooning, and even if you end up a little bit relatively underexpanded, high pressure post-dilation can really rescue these areas. However, in the presence of moderate to severe calcification, that's completely different. And once the stent is placed, apart from maybe some preliminary data about IVL rescue, really you're in a difficult situation here. So when you see moderate to severe calcification, you need to think about advanced lesion preparation. We developed this calcium algorithm called the calcium imaging score, in which we created a simple strategy called the rule of fives, where if you have a vessel that's got calcium that's 0.5 millimeter thick, 5 millimeters long, and 50% or more of the vessel arc, you're more likely to be underexpanded, reminding you that advanced lesion preparation, whether it be NC or specialty balloon or atherectomy or IVL leading to calcium fracture, is critically important. And this is an example of calcium-dependent lesion preparation where the pre-PCI M for morphology is critically important. You see that there's dense calcification in the artery wall. We perform atherectomy to thin this calcium down. The calcium is fractured by an NC balloon, and then you can get excellent luminal gain. Now, when you do an OCT-guided morphology assessment, it really can be done very, very quickly, and all you're seeing is us scrolling through the artery here to look for segments of calcium that are more than 180 millimeters, more than 0.5 millimeter thick, and greater than 5 millimeters long. When we do the length portion, what we're really trying to do is manipulate the angiogram. So if we look at the OCT co-registration angiogram, what the OCT 3D luminogram or automated lumen profile is really a multiplanar reconstruction very similar to TAVR. You've essentially squashed all of the images and the three-dimensional nature of the artery into 2D, and that helps you to determine the optimal reference segments. So when we do that, what we're going to try to do is land our stent into the most normal segment distally, and we want to examine the cross-section and say, yes, this is a nice place for us to land. We want to do the same thing proximally. And when we do this proximally, we notice that there's a segment of disease here. However, this may be the most normal segment of this artery. Now, we don't have a 35.2 millimeter length, and to fit into the concept of precision PCI, we should manipulate the more normal of these two segments, and in this case, that's the distal, by basically pulling it in 2.2 millimeters, and now we end up with a commercially available drug-eluting stent size. And when we do this in real time, you can see that we're looking for a normal segment distally, and we're going to leave a bookmark there. We look for the most normal segment proximally. So we're going to scroll in and out until we see the most normal segment. You'll see we're at 35.2 millimeters, and then we adjust the distal segment inwards to become an exact stent size. Once we bookmark our distal and proximal segments, the next thing that we can do using the MLD Max approach is to determine the diameter. And stated simply, if you're able to see the external elastic lamina, we should use the EL and round down for our stent and balloon size. In situations where we're unable to see the external elastic lamina in about 20% of cases, we want to use the lumen and upsize. We do this for both the distal reference to pick our stent size and distal post-dilation balloon, and also in the proximal reference to pick our proximal optimization balloon. And so this is a very easy task to go ahead and recognize now the external elastic lamina and measure it quickly. We do this at the distal reference, where we can see the EL very clearly. Now, when we go to the proximal reference, you may remember that there's a significant burden of disease, so it depends on the operator's comfort level to be able to identify the external elastic lamina. Here I feel comfortable on being able to identify it. In situations when I cannot, you'll note that we have the mean lumen diameter and can upsize. So if we were to go ahead and analyze these distally, we're a 3.0 by 3.06. So we round down to the close EL that's a 3.0 device. Proximally, I found the EL that's 4.3. We round down to the closest device that's a 4.0. If we use lumen and upsize, we'd end up with a 3.5. So now, again, this has become quite like a TAVR. We know we need a 3.0 by 33 stent. We're going to direct stent based on our morphology, and then we'll use a 3.0 NC distally and a 4.0 NC proximally for optimization. So that took about 13 minutes. You remember we started at 12:30. We imaged, we analyzed, we placed the stent, we optimized in 13 minutes. And now what we're going to do is look at our post-PCI user interface on OCT. And the two most obvious features are that there is an apposition indicator, which is a white bar showing that the entire stent is apposed with less than 200 microns of malapposition, and the rendered stent, which is the stent placed into the artery. One of the main advantages of the rendered stent is that the OCT automatically identifies the edges of the stent, allowing rapid assessment for distal edge dissection. There are some advanced features in the OCT, which include 3D bifurcation mode to assess the placement of stents close to bifurcations. There's also the ability to look at the stent longitudinally in its appropriate branch pattern. And then finally, I think this is a nice feature to be able to show patients, and that's the 3D bifurcation or the 3D fly-through, which lets patients understand how the technology may impact their clinical outcome. For medial dissection, there are 3 types. When we see a dissection into the intima, we really tend to leave these alone. Lorenz Reber and Maria Radu showed that almost 98% of these heal after 9 months. But once we have a medial dissection that penetrates into the media, particularly at the distal edge, there is a risk of progressing into an intramural hematoma, and we strongly suggest stenting these when they're greater than 1 quadrant in arc from the center of the vessel and they penetrate the media. You can see that it's very easy and quick to assess the distal reference and the distal edge dissection because the OCT automatically identifies the proximal and distal edge. Here you do see that there is a distal or proximal edge dissection. However, we know that it's not greater than a quadrant and we can treat it medically. Apposition, of course, is important to understand the difference between the definition of apposition and expansion. Apposition is simply whether the stent is touching the wall. If the stent is touching the wall, it's apposed. If it's not, it's malapposed. In general, treating malapposition treats the physician more than the patient. We should be considering treatment of proximal malapposition that may interfere with rewiring or gross malapposition for long stents, i.e. a floating stent. Malapposition is identified automatically by the OCT. Here you can see on the OCT angiogram in red, on the cross section in red, in the lumen profile on the malapposition bar, and on the rendered stent. It can have bad consequences to have malapposition. This is an example of a lost wire where the operator rewired. You can see that the wire went through the side branch, and what they ended up doing was inadvertently crushing the proximal stent because of abluminal and luminal wiring. Finally, for expansion, it's important to understand that expansion and apposition are different. Expansion is the ability of the stent to hold the lesion close to or greater than the normal reference segment, then the stent is expanded. Here in this example, you see that the stent is fully opposed based on the white bar, but the stent is much smaller than the reference segment areas, showing a 48% underexpansion. We should be aiming for at least 80%, if not 90% expansion if possible. There are 2 modes of OCT assessment of expansion. One is the tapered view. The other is the dual lumen view. We're moving towards the tapered reference because it automatically accounts for side branches. And here you can see the region of interest is automatically detected on tapered. The expansion is automatically displayed. In the event that you do end up underexpanded, well, of course, you want to use your post-PCI OCT to help determine the stent size. And just like we mentioned, similarly, in this situation, the distal half of the stent is underexpanded. In the distal reference, the artery has now grown by 1/4 millimeter. And so we can use a larger post-dilation balloon to perform our optimization. And then you can see we've rescued that under expansion, which is now greater than 100%. In fact, you can even see the shape of the balloon optimizing the vessel wall. So we can perform MLD max guided PCI very quickly. This procedure was 25 minutes beginning to end with cabbage-like results, 100% expansion, absence of malapposition, and absence of an edge dissection. So thanks for listening to my talk on MLD max. And I invite you all to join us for our OPCI Live, which is an ongoing program for education for the interventional community, as well as the Heart of the Matter Journal Club. Thanks very much.
Thank you, Ziad. I think Dr. Kevin, you need to go because Indians, we are at night here. If you have to also go, you can finish your talk. Otherwise, you can wait. We have 2 more talks from Indian colleagues, Balbir and Dr. Roni. If you are okay, we can give after, or you can give your talk, and if you have to leave, you can go.
Thanks, Dr. Srinivas. I've got the latitude to wait and
okay,
be happy
please,
to have the other two
deliver.
presenters go.
Hope Balbir and Dr. Roni will not mind and cooperate. Over to you, Dr. Kevin.
Oh, okay. No, I can wait till my time slot. I'm fine. I have time. I'm happy to stay to my. I can wait. I'm happy to have the other 2 presenters go first.
Okay, then fine. Thanks for that. Then we can have Dr. Balbir Singh's talk next, which is there.
Sounds great. Thank you.
Yeah, thanks, Dr. Srinivas. I'm going to share my screen. Yeah. So we've been listening. I hope you can see my slides.
Yes, we can.
Okay, so we talking about calcium today evening, and if you look at meta-analysis of 7 trials, which was published in 2014 in Heart, we clearly see that the outcomes of calcified lesions who had severe calcium was worse or double MACE rates at 36 months after angioplasty. So 3 years MACE rates were almost double, including almost double deaths, double myocardial infarctions, and higher revascularizations. So this is 2014, and this should put many of us think that if we are doing the right strategy for our patients. But fortunately for us, Gary is here, and this is an ADAPT DS of his study, which said that increasing coronary calcium, they divide into 3 tiers: low, intermediate, and high. This is an IVUS sub-study. And they looked at the MACE results. And if the PCI is IVUS guided, there was no difference in the MACE. So increasing coronary calcium has been associated with complex procedures, higher difficulties with the procedure techniques, but it needs aggressive PCI techniques. And if you optimize your stent, you would get results equivalent to low calcium burden. So it makes life difficult for the operator at that particular point in time. But if you do a good job, have imaging to expand your stents, do an optimal job, you could get results which are similar to low calcium burden. So this refutes the previous trial or the meta-analysis, which suggested a double MACE rates. This is looking at calcium. This is a CT angio and can make things look really difficult. So we get very scared, but at least we know we are heading for some very complex case when you look at such images. Then looking at angiography, of course, should be the first starting point. Here you see a tram-like calcium, that you see this calcium on both sides. You see the calcium on one surface, the other surface, you see this calcium coming up in the circumflex. You clearly know this tram-like calcium is going to go into severe calcium when you do imaging for this patient. Again, another case of a complex left main, and you see some calcium, but not too much calcium here. But however, we know angiography is insensitive. For example, this lesion did not suggest any calcium, but on IVUS, you see a long arc of about more than 180 degrees of calcium. So this is again Gary's paper in 1995, which suggested that angiography correlates poorly with IVUS detected calcium. So IVUS is far sensitive in looking at calcium. So intravascular imaging really helps to look at calcium. So IVUS is sensitive, but due to reflection of the calcium by the caustic waves, it cannot go deep. For example, this is the calcium here. You can't go beyond that with this. OCT is not only sensitive, but also can measure the depth as well as the arc quite clearly. So this is a human coronary artery calcification as by OCT and histopathology. You can see this is the calcium and this is the calcium on OCT. Very good correlation. So the IVUS assessment is to look at the arc, the length, and whether it is superficial or deep. These are the 4 things that you want to know on IVUS. This is an IVUS image, and this is an OCT image of a different patient. So you see a full arc of calcium. After rotational atherectomy, you see the calcium reverberations do not help you to really assess whether you've done a good job or not. Then again, spotty calcium allows multiple vulnerable plaques form in between these spotty calcium, and they can present with unstable angina or ACS. Calcium nodule is another havoc for interventionists. This is what a calcium nodule looks on an angioscopy. It bulges into the lumen and creates a lot of problems. So if we compare the imaging techniques of coronary angiography, IVUS, and OCT, we realize OCT detection of calcium is very sensitive, localizes quite well in terms of the arc and the thickness and quantification. So it does a little better job in terms of quantification, thickness, and the length than even IVUS does. So calcium nodule we're just discussing. This is how an OCT image of a calcium nodule appears like. It bulges out and then has all the properties of calcium, which Ziad just described. This is how it looks on IVUS. Let's look at one case. This looks like a very simple case. And when this was done, I thought it will be out in half an hour. But when balloon was passed, we had some difficulty in balloon crossing. So we took a smaller balloon, crossed it, and looked at the calcium. This is the OCT image, 360-degree arc of calcium, very thick. And look at this lumen, very narrow. So this is how the balloon inflated when we had to switch to OCT to look at what happens. This is a 2.5 balloon. And look at it, it's not expanded at all. This is the first thing one should look very carefully, an under-expanded balloon to guide you. This was a Wolverine cutting balloon, 3 millimeter, to cut through this lesion. And having done that, we assessed whether we have done something with that balloon or not. Yes, we had done 2 long cuts there. And this is the stent expansion, the same patient where a balloon was difficult to expand. We got an area of 8.27 in the distal RCA. Just tells us that how MACE rates can be reduced by doing this. We know the bigger the better concept. More expansion, the better outcome is going to be. Restenosis is going to be lower. So the best thing to do is assess your lesion before you decide what strategy you have to do. The IV intravascular imaging using OCT helps you to decide the arc, the length, and the thickness of the calcium. And a dog boning, which I showed you, also is a very good marker to tell you that you need to change. Suppose the score you get is less than 2, you could end up using a compliant or an NC balloon. But if score is 3 or more, maybe calcium modification using cutting balloons, scoring balloon, IVL, rotablator, depending on what you are comfortable with or what choices you have, would be very useful. So one of the best choices, if a patient can afford and you have, is to straight away go to an IVL if you have these markers there. If the IVL doesn't cross, you have rotational atherectomy, and this could be followed by an IVL and could be followed by a stent. Let's look at another example. This is angiographically tram calcium. You can clearly see the calcium. And this was a small 2.5 balloon to make us have an OCT run in this patient. And this is the OCT image. We go from the normal area, like Ziad was just mentioning, look at the distal landing zone, look at the calcium. Now look at the thickness, the arc of this calcium. This case cannot be done that easily. Now look at the length. Wherever you put the OCTs, you have the calcium. And then you have the proximal landing zone. Fortunately for us, you have a beautiful landing zone. And this patient was treated with a 3.5 IVL balloons, got good cuts on this. The length was decided based on OCT, 2 stents. This is an IVL balloon opening up this lesion, following which 3.5 and 4 millimeter stents were deployed. And this is the final OCT run. Now, things do not happen. Even after IVL, after NC balloons, the expansion was 5.6 with 5.86 area. We weren't satisfied at all. We went further ahead with bigger balloons, 4 millimeter. did get an expansion of about 75. That was the best that we got in this patient. So it tells us that, despite working so hard with multiple dilatations, with NC balloons, with OPN, with IVL, you sometimes do not get that 90% or 80% stent expansion. But the MSA was 7.4, which is quite adequate for this patient. This patient has done very well on a more than a year follow-up. And in summary, I would say that we have multiple modalities to look at the imaging, but doing complex coronary calcium lesions can be very difficult, may result in MACE. So we should use CT angio, angiography, IVUS, and finally OCT to help us see the distribution of plaque and help us manage our patients better. Thank you very much for your help.
Yes, Srinivas left, so that was actually really, really great. And it. Oh, go ahead, Srinivas.
No, we can go to the next talk and have discussion after the talk, sir. After all the talks.
Please introduce the next speaker.
Okay. So next is eye optical trial and eye opener by Dr. Ronnie Matthew. Actually, he is pioneering work in OCT in India, similar to Light Lab work, what Kevin and others did there. Similar studies done in India, highlighting some of the important aspects, how the OCT changes its decisions. And let us hear more about it from Dr. Ronnie Matthew. Thank you, Ronnie, for again sparing your time and participating in this. Over to you.
Thank you, Dr. Srinivas. I hope you can see my slides and hear me too.
Yes.
Great. It's a pleasure to be here at TCT, especially in the company of greats, Dr. Gary Mintz, Dr. Ziad, Dr. Ashok Seth, and Dr. Kevin Kroc. Hi, Dr. Kevin. So I'm going to present to you the IOPTICO study, and the study was done in the Indian subcontinent. And I don't have a disclosure, though it's an investigator-initiated study. It was supported by Abbott Vascular. So the study objective of IOPTICO was to assess the impact of real-time OCT and angio-co-registration on physician decision-making for PCI optimization in South Asia. And we had 9 sites from all over the country. We had Dr. Tejas Patel from Ahmedabad, Dr. Hiramat from Pune, Dr. Samuel Matthew from Mumbai, Dr. Balbir Singh from Delhi, Dr. Shengetwelu from Chennai, Dr. Vivek Kumar from Delhi, Professor Fazila from Dhaka, and Dr. Shivakumar from Madurai. Our co-lab was at Chennai at the Madras Medical Mission, and Dr. Vijay Kumar did a wonderful job. So as I said, the primary objective of this study was to assess whether OCT imaging after angiography altered our PCI procedure when performed pre or post PCI. Pre-PCI strategy, the points noted were whether there was a further need for lesion preparation, whether there was a change in the intended stent length and diameter, and whether there was a change in the stenting strategy. Post-PCI OCT optimization involved identification of stent malopposition, dissections, under expansion, plaque prolapse, or an incomplete lesion coverage. The secondary objectives were the angiographic procedural success, the MACE at 6 years and 1 year, and the cath lab metrics. What I'm going to present today is the interim data that was presented last year at the TCT. Now, I'm very happy to tell you that we have completed the 6 months and the 1 year follow-up. The MACE and this data is at least been submitted to the TCT this year, but that will not be part of this presentation today. Now, we have a very unique study flow, and it was real time. Now, each investigator had an assistant who would enter data real time as the procedure progressed. So prior to the procedure, based on the angiogram, the operator was asked to define the procedural strategy based on the variables I just discussed with you. Whether there was a need for further lesion preparation, what was the intended stent length, diameter, and the landing zones were marked on the angio and the stenting strategy determined. Now, subsequently, they performed the OCT. And based on this additional information provided by the OCT, the changes in strategy were documented real time by the investigator. At this point, the angio co-registration was applied, and any further changes in landing zones or any other study variable that I discussed was further documented. Now, based on all this information that the investigator got, he performed the PCI. And post PCI, the OCT was done to determine whether further optimization was required as far as malapposition, expansion, under expansion, etc. And then again, the ACR was applied and it was documented whether a strategy change was required. Now, everything was analyzed at the collab. Now, we enrolled 500 patients between November 2018 and March 2020 from 9 sites across India and Bangladesh. We had to exclude 28 patients from the primary endpoint analysis due to inadequate imaging. So 472 patients were included in the analysis. 2 patients died after 3.5 months of the procedure. So at follow-up, we had actually, this is what was presented last year, but right now we have the entire 472 patients who have been followed up at 6 months and 1 year. Now, if you look at the baseline characteristics, it's more or less what we see in some of these busy labs in our country. Diabetes in about 50%, hypertension in about 57%, and if you look at the indications for PCI, about 80% were ACS. And the lesion characteristics, not surprisingly, some form of calcification was seen in about half the patients, and type B and C was in the majority. And that's again a snapshot of the type of patients we see in our labs in this part of the subcontinent. Now, coming to the results, if you look at the left panel, there was a change in the PCI procedural strategy once OCT was performed after angiography in about 76% patients. And this included a further need of lesion prep in 25%, change in stent length in 53%, change in stent diameter in 36%, stenting strategy in 4%, and change in the landing zones in 61%. Now, once OCT was performed, adding angio co-registration further changed our PCI decision strategy in 22%. And that was predominantly due to change in the landing zone, due to which we had a change, a further lesion preparation in 15%, change in stent length in 10%, and a change in the stent diameter in 5% of patients. Post PCI, OCT identified a problem that required additional intervention in nearly 30%. And this included under expansion in 15%, malapposition in 15%, edge dissection in 3%, and a tissue prolapse in 7% of patients. Not surprisingly, adding ACR at this point did not have any additional strategy change post PCI. The secondary endpoints, running through this, the average time required for conducting the OCT pre-procedure was around 6.6 minutes and post-procedure 10.7 minutes. The contrast used was 205 ml. Additional contrast for OCT was 40 ml. Now, so if you look at the overall impact of the iOptico, what it showed was the overall impact of OCT and ACR during PCI. Pre-procedural OCT changed decision making in 86% of patients, and overall post-procedure in 30%. And if you look at OCT plus ACR, it changed angiographic-based decision in nearly 90% of our lesions in this part of the subcontinent. So to conclude, this was the first South Asian study reporting the outcomes of OCT and ACR-guided PCI in this part of the world. And OCT and ACR changed our angiographic-based decision in 90% of lesions. Pre-procedure OCT changed strategy in 76%. ACR additionally changed strategy in 22% lesions. And post-procedure, the OCT showed a further need for optimization in 30% of lesions. I would present the 1-year clinical follow-up data at a later date. So before I say thank you to you all, I never knew about Dr. Kevin Kroc and the Light Lab study, but once I got to know that these were two studies that were done in two different parts of the world with two sets of investigators who never had a contact. Of course, I know him now, but I didn't know him at that point of time. And if you look at both these studies, more or less showed that imaging helps you to change decision making, and importantly, the majority of the change in decision making is in a pre-PCI OCT and not a post-PCI OCT. Thank you all for your kind attention, and I thank my co-investigators for helping us out. Thank you.
Thank you, Dr. Roni. Actually, that is the power of truth. If you are truthful and do what is right, it will come the same wherever, whichever part of the world you do it. Thanks, sir. Thanks for it. I think we will go to Dr. Kevin's talk. We heard it before, sir. Now we are eager to hear to you. Now you see it, now you treat it. Integration of imaging for routine PCI learnings from Light Lab. Something similar to the previous, but from the Western side of it. Over to you, sir.
Thanks, and I'll try to be brief to help catch up on time. I really appreciate the opportunity to be invited to this excellent conference. Can everyone see my slides okay?
Yeah.
Great, awesome. So I'm Kevin Kroc. I work in Boston, Massachusetts. I think, it's not lost in this conference that there's two randomized trials that show that intravascular imaging guidance cuts MACE down by half in patients undergoing PCI. And I think there's been this is one of many meta-analyses which demonstrate that intravascular imaging lessens the occurrence of an outcome we really care about, which is cardiovascular death. And Gary's put together a slide I don't have on this deck, which just shows the mountain of trials that support intravascular imaging for PCI. And I think it's really, state of the art to how to do a PCI is to guide it with imaging. Additional to that, and Ziad talked a little bit about this in his presentation, in terms of our striving to be as good as CABG or maybe someday better, the Syntax study, unfortunately, was single-arm, but it looked at things like modern image guidance, new stents, physiologic assessment, and dedicated CTO sensors. And if you take Syntax 2 and look retrospectively at a very similar patient cohort to what was treated in Syntax 1, you see that the patient outcomes are excellent with PCI when it's done in a modern image-guided way, such that the PCI patients start to look very much like the CABG patients. And so some part of doing a good job and competing with bypass surgery to get good outcomes for patients, especially complex patients, is to use intravascular imaging as part of our armamentarium of how to optimize PCI results. So with that in mind, this is last year's data on the use of intravascular imaging globally, with the United States being about 20%, Japan being very high, but a lot of variability across continents. And we got to thinking, what are the barriers to adoption? If you look at the data, it's clear that there's benefit, but why aren't people using it more? Complaints are there's not enough people trained to do it well, it takes too long, and potentially there's too much cost involved. And I would challenge each of these. But Light Lab, MLD Max, and our opportunity to make a consistent and prescriptive imaging pathway to do PCI was really meant to address the gaps in training. We wanted to make OCT very easy for patients. And so many of us got together about a year and a half ago, and with Ziad and some other colleagues, we came up with MLD Max at a conference room in Boston. And this is a slide which I borrow from Ziad quite often, but it shows our U.S. interventional fellows and their self-reported competency for things you need to do modern, high-quality precision PCI. They don't feel confident very much in physiology, certainly not in IVUS, and definitely not in OCT. So with that in mind, we really wanted to move forward to try to make this simple and teachable. And MLD Max, which was presented a couple talks ago, was really the product of trying to come up with a prescriptive and very regimented way to approach PCI with OCT. And once this was built, we set out to test this in a study called Light Lab. And so what OCT-guided PCI is meant to do is it's meant to lessen the occurrence of things that we know drive MACE in patients, which the highest MACE hazard is having a stent which is poorly expanded. Also, things like distal edge dissections are quite noxious from causing MACE in patients, and having bad inlet and outlet disease is a problem. And as Ziad went through how to do MLD Max, one of the ways we coach people to deal with distal and proximal reference narrowing is, when possible, to stent normal to normal if the artery is amenable to that. So this is the application of MLD Max to try to lessen the incidence of things that we know drive poor outcomes in PCI patients. So MLD Max and Light Lab was a study which was done in 14 hospitals with over 40 investigators. It was meant to look at the prescriptive use of OCT in an NLD max guided way. And this is a real world population, much like iOptico, with upwards of 55% of the patients having type C lesions. And this is a multi-phase study looking at decision making, later efficiency, and later application to the complex PCI, which I'll talk about later because that data is currently being amassed. But effectively, even in the initial phase of Light Lab, this is real world, and the large number of patients had type C lesions, and long lesions in complex PCI were very much a part of the patients being treated in these centers. And so much like iOptico, if you look at the difference between angiogram guidance, where we had to call out and define our plan based on the angiogram, versus using the OCT data to assess how the OCT changed our decision, we see that the majority of impact was in the pre-PCI OCT, where it changed decision-making and diagnosis of things like lesion type, what we do for vessel prep, how we're going to treat, and number of stents. And this is the difference between planning a case by imaging or just endorsing it. If you plan the case because you paid for the catheter anyway, and knowing exactly what you need to do to optimally treat the artery, on the back end, there's a lot less impact of the OCT because you've gotten it right up front. And the cumulative impact across the pre and post part of the case is 88%, with the majority coming early. And so it's a difference between an image-guided versus an image-endorsed PCI. And I'll show you a little bit of data on the difference between those in a few slides. So with that in mind, morphology really is what changes our decision-making. As you look at morphology, it had the greatest impact on both the pre-PCI planning and on the post-PCI, impacting things like what we're going to do for vessel prep and how we're going to address an important indicator of MACE such as underexpansion. Additional to that, our assessment of lesions changed 22% of the time, where it got upregulated and we increased in severity. So to the point made earlier in one of the wonderful talks that was given a few minutes ago, an angiogram is a terrible way to determine the calcium burden. And that point has been shown in live cases over the course of today and in the presentation, which was beautifully outlined by one of my colleagues a few minutes ago. So with that in mind, when the OCT detected calcium and the angiogram didn't, it led to a 47% change in the vessel preparation strategy, with escalation to more aggressive predilation, or in many cases to atherectomy or laser. This is where the case is either won or lost from an ease of stent expansion standpoint. And if you think about the change in terms of diameter, people are as likely to oversize based on the angiogram as they are to undersize. And so we saw really a bell curve in terms of how the OCT informed the choice of stent size. Additional to that, if you use MLD max, about 80% stent expansion is achieved on average after the stent is placed, post-dilated, and the post-PC optimization is done. In cases where the OCT showed there was underexpansion, in a large number of cases, the investigators went on to do additional post-PC optimization. The goal is getting the stent to at least 80% expanded, as Ziad outlined, but preferably to 90% expanded relative to the reference segment on either end of the stent. And so if you think about the effect of PCI planning with OCT on de novo lesions, there is several hundred OCT cases with in-stent restenosis in Light Lab. And this is something which I'm very passionate about because we have a pretty busy stent failure referral practice. If you look at the impact across pre and post-PCI OCT planning for de novo lesions, it has an even larger impact when you go ahead and look at in-stent restenosis cases. Now, I'll be interested to see, Ronnie, if you can show very similar overlap in your curves if you get a chance to look at this with your core lab. Some of the nice congruency and agreement between our two studies, which are done independent by people that didn't know each other, has been one of the more fun things of my involvement in this project. So I congratulate you and your co-investigators. It's nice to see that we agree quite easily, despite the fact that we're several thousand miles away from one another. If you look at the later phases of OCT, as people went from the baseline phase of early assessment and then into a little bit more practice with about 20 or 40 cases in each phase, we see that the application of OCT to type C lesions grows with a little bit of experience. And so this I take as an underscored exclamation point that once you get a little bit of experience under your belt, this technology is more than ready for real world practice, as we showed even in the early phases of Light Lab, where it was being done at 12 centers with 40 different operators. Additional to that, with a little bit of practice, the percentage of times when you can't get usable information from the OCT goes down substantially. But even for people that are early on in their learning experience, most of the time, with a little bit of coaching and a little bit of attention to the OCT run, you can get high quality and usable OCT images the vast majority of the time. And the chances that you can't use the information goes down to less than 3% after you've had a little bit of practice. Additional to that, with time and experience, after about 20 to 40 cases, the time spent in Light Lab actually doing the OCT decreases. And this goes back to what Ziad showed earlier with the LED OCT guided PCI that he showed in that test example, is it only adds about 10 minutes total to the case to come out with a precision PCI guided result where you know that you've done everything possible to keep your patient from having a stent failure and coming back with a stent that's no longer open. Additional to that, and this is one of the more cool things which has come out of our recent analysis, in cases where just a post-PCI OCT was done, MLD max was not used, the case was not planned based on the OCT. They just checked their work when they were done. Versus actually using the entire pre-PCI planning OCT workflow and then the post-PCI optimization, you actually use less contrast when you get it right up front by planning the case with OCT, as was demonstrated by the MLD max strategy that Ziad outlined. And so it's a really nice way to show the value of knowing what you're getting into and actually rationally planning the case as opposed to just checking on the back end, where you've often gotten it wrong and end up using more time, more dye, and it's more work to fix it on the back end. So with that in mind, the key takeaways are that when the full range of pre-PCI planning and post-PCI planning imaging is used, we have a major impact on the strategy with less impact on the optimization, because you've gotten it right up front in terms of having a well-placed stent, a lesion that's modified appropriately to accept that stent and have it expand well, and then landing normal to normal and working on apposition expansion and sizing. So with that in mind, by way of summary, intravascular imaging improves PC outcomes and likely saves lives. Intravascular imaging is currently underutilized, and MLD Max was built in response to that to bring consistency, ease of use, and a very simple and algorithmic approach to doing this. An algorithmic application of OCT imaging improves procedural decision-making, facilitates optimal stent deployment, and you can do it on 2 different continents and get the same results. I really appreciate the invite today. Thanks for having me here.
Thank you, Dr. Kevin. Very excellent talk. Many people will have many doubts. They are eager to ask many questions, but in the interest of time, already is getting delayed. We'll move on to the next topic by Dr. Selvamani, imaging role in bifurcation PCI.
Sound.
Sorry.
Yeah, we can see
good evening,
your slides.
Good evening, everybody. It's really a pleasure being here, and I thank Dr. Srinivas Kumar and the organizers for calling me here. And I'll just go to the topic directly. And coming to the issue here today, OCT in bifurcation. How do I do this? See, basically, apart from routine things like plaque burden, stent size, stent landing, and calcium, lipid-rich thin cap, we generally use OCT in bifurcation to decide whether to do a crossover or just a simple ostial landing. That is one point. Whether it's a single or a double stent strategy, and to predict the side branch closure, and size the crushing balloon balloon sizing, and to look at the metal deformed carina, optimal side branch cell crossing, and of course final kissing balloon, and whether to kiss in provisional stent strategy, and of course for complications. So these are my general approach. When you look at this case here, this patient actually had a proximal LAD lesion and some disease in the LAD here, and a very tight diagonal disease here. So what our strategy was to decide whether to treat the LAD and what, but the FFR was negative in the LAD, RFR as well as FFR. And although OCT in the LAD showed a very critical lumen area somewhere around 1.8 and 1.9, but the FFR is negative, but we just thought of treating only the diagonal disease here. So when I did a OCT in the diagonal, you see here, what we can see is we can make out what is the area at the landing zone and what is the diameter of the main vessel as well as the side branch. And you can decide whether to do a crossover or just land on the ostium so that it is just an ostial landing. What I do is you just co-register and you mark the ostium of the vessel on the angio co-registration, and then you place the stent exactly on that. See, this is how I have placed the stent. If you go by angiogram, generally what we do is we tend to pull the stent till further. Probably you might overhang, but thinking that we'll miss the ostium. But when you use a co-registration, it is exact landing usually you get. See, this is what I have stented using this angio co-registration. And post-stenting, you see here, it is an exact ostial landing. The stent is not extending into the LAD there, just landed in the ostium of the diagonal with a very good result here. So this technique, what we call it as a boom technique, is very, very new, and probably you can use it. It was actually presented in TCT 2018. It is bifurcation and ostial OCT mapping. What you do is you just select this ostium and then place it on angio co-registration. This is the precision. Usually it is around 70% within 1 millimeter precision, and around a 90% in 2 millimeter, and almost 100% or 98% within 3 millimeter precision regarding the stent placement precision decision making. So it's a very useful technique, especially in bifurcation for ostial, as well as bifurcation overlap, where you can minimize the overlap. Still, you can avoid crossover. Look at this case here. We always had a discussion whether to have an ostial landing here or to do a crossover. So in such case, what generally I do is, after doing a balloon dilatation, you do a OCT. In this case, what has happened is, you see here, the lesion is actually from the ostial LAD is extending into the left main. So in such cases, it is usually better to do a crossover when there is a disease extension from the branch into the main vessel. Apart from that, he had a dissection there in the ostium extending into the left main. So in such cases, there is no option. Probably you'll have to do a crossover and just treat it over. Coming to side branches here, see this, the patient had both the vessel's FFR was positive, and you do an OCT there, then you look at certain characteristics here. So when you look at the longitudinal view here, this is the carinal angle, which is very important. If it is more than 30, it is better. If it is less than 30 or somewhere around 15, 20, the chances of side branch occlusion is very high. You look in for the block characteristics just opposite to the takeoff of the vessel. If there are calcium, chances of occlusion is very high. And then you look for carinal angle to branching point distance. If it is more than 1.7, chances are very less. And more than that, if there are huge lipid burden at the carina, chances of side branch occlusion is very high. And more important is size of the distal main vessel. If you oversize your NC for this, probably you will close the side branch. So look at this example here. There was a tight lesion in the diagonal as well. And this is the OCT here. So here, there are two vessels taking off. Actually, it was mistaken. You see here, there's a very small diagonal and a big diagonal here. We thought probably this is the main vessel, and then the distance was miscalculated. Actually, there is a pointing carina here, and then the distance between the branching point and the carinal angle is very less here. And there was calcium opposite to that. So when we stented, the vessel got occluded here. So this is what happens. The vessel is occluded now. And it's a very clear description. Any pointing eyebrow sign or a pointing carina, calcium opposite to that. And if this distance, actually branching point to this distance, if it is very less, the chances of side branch occlusion is very high. Coming to crushing balloon size, it is, see here, this, I was doing a DK crush. So I have crushed with a 4 NC there in the side branch. And after this crushing, when you do a OCT in stent rendering, if it picks up something like that, that means it is not an adequate crushing at all. Generally in stent rendering after a crush, OCT does not pick up this metal here. If you see something like this, probably it's not an adequate crush. So I have taken a bigger NC balloon there and then crushed it. And after crushing, you see here there is nothing, and then you see a very thin crushed part of the stent here. And sometimes you see still lesser amount of stent in a well crushed stent there. Coming to kissing balloon sizing, it is very, very easy. You can forget all the fillet law or Millet's law. What you should do is you size your side branches, you balloon according to the distant reference. So you take your balloon sizes according to the distant balloon and then you dilate it. It is so simple. The main vessel will definitely tolerate. And of course, for pot, you can measure the main vessel and go with that size. So sizing of kissing balloon is also very, very easy. You need not calculate or look into the fillets law and all. Coming to ideal cell cross, it's very, very important. Whenever you stent here, usually restenosis occurs at the ostium of the circumflex, that too at the carina. But generally, otherwise, in a non-stented area, the plaque burden is in a non-carinal area. Why does it occur is when you stent it, there is a strut accumulation and there are a lot of reactions occurring and flow dynamics are altered. We have a lot of papers saying that optimal wire crossing in the side branch and bifurcation stents, and they have been followed up also. Whenever you get a side branch opening like this, when there is a link across it, probably long term, your ostial opening of the side branch will be reduced. We'll see how it happens. When there is no link, probably it is better. There is a paper by Akumara who, what they did is, they studied the presence of link-free type as well as link connecting type carina. After you see a kissing balloon, if it was like this, they selected such cases. Around 54 cases were studied and suboptimal 51 cases were studied. And they found out the reason for that struts across were guide wire not crossing distally, that is one, and angle between the side branch and the distal main vessel, and proximal main vessel reference. These were the important factors. When you do a distal crossing, what happens? You see here, even in a provisional stenting, which is very, very the common, probably around 80 to 90% of bifurcation today, we treat with the single stent strategy. So in there, if you cross distally and you dilate this, what happens is there is a good coverage of the ostium and the stent expands like this. If there is a proximal crossing, what happens is there is a distortion of the main vessel stent there causing a problem. So that is the reason why you emphasize you go with a distal crossing here. And OCT clearly shows that. See here, it is a very distal cross there, can clearly make out. And once you see here, you can document very clearly in the longitudinal view also that what cross it is. It is a very clear distal cross here. And you can reconstruct in the 3D mode also. Even in the distal cross, you can make out in which cell it has crossed. So here it has crossed a very remote cell. Probably this may not be a very ideal cell, even if it's a distal cross. Probably if you want, you can change the cell and then go with a better cell there. And during provisional stenting, should we do a final kiss? That is a matter of question always. In this case, you see here, after this provisional stenting, if there are metal like this across the side branch, and there is a lot of connectors across the side branch like this, it is definitely not ideal. So you do a distal crossing. But in an anatomy like this, angiographic crossing of distal cell may not be very, very easy. But otherwise, in many cases, angiographically itself, you can get a distal cross. But in an anatomy like this, it's very difficult. But the OCT clearly shows it's a distal cross here. You look at the OCT here, and it shows it's a distal cross, and you can confidently go and kiss there. And you can reconstruct on the bifurcation mode also, and you can look into that what cell it has crossed. And even in the run-through mode, you can clearly make out the cell where you are crossing. And this is after the final kiss. You can make out there are no cells there. And the bifurcation spot is exact with good apposition there. So even after pot, side pot, see, this is before the pot, side pot, and this is after. You can clearly make out that
Dr.
there
Selvamani,
is,
you can
yes.
conclude. Already we are
Sure,
running
sir.
late.
Last
Half an hour.
2 minutes. And this is a follow-up case here when there is there are cells where we did not do any kissing there. And once we did that, 1 year follow-up you see here, there is a very clear growth of the cell, causing some doubt there. Probably this is how it goes in a long run when you follow up these cases. And of course, since it is getting time there, and I think probably this is double stent strategy what we do here. I have done a decay crush with the crushing there. And after the crush, this is the proximal first cross which we do. And this is the first kiss what we do. And this is the stenting. And after the stenting and pot, you go for probably a mid or a distal cross in this. And then you can clearly document on an OCT. And this is the final kiss with a very good result. In a two-stent strategy, this is what you should aim. It should be a clear figure of 8 with good apposition without any metal bridging there. So, and I think I will just come back to the first slide. So these are the important points we should look into bifurcation. These are the points what we use using OCT in bifurcation. Thank you very much.
Thank you, Dr. Selva, for excellent coverage of that topic even at this late. And one more interesting thing which is waiting for us is we had Shivamani's musical program kept just for encouragement and enjoyment after this tired evening. Dr. Kevin, we would assure you that you would enjoy if you can listen first 5-10 minutes and then leave. You will not like to leave once you see. And Harshita, can you make him join? Mr. Nagaraj sir is a good friend of me. He is with flute and he's made this possible actually. Shivamani sir is a famous drummer in our place, and we thought at the end of a tired day we could have some music and enjoy yourself. And thank you for excellent sessions, and thank Dr. Kevin and Dr. Roni and all others for staying so long. Hope all of you had good interaction. And tomorrow will be the last day, day 3. It will start again at 3 p.m. We are interesting. Tomorrow also we have some sessions in congenital heart disease and some other live cases coming up. Request all of you to join by 2:55 tomorrow. And today's session, academics will end now. We'll have some enjoyment and with a few words of welcoming to Shivamani Garu. Can you make him onto the big screen, onto the podium, Harshita? Can we see him in Zoom?
Sir, he's joining, just getting in, sir.
Okay. He was waiting in the meeting room. That is the other one who's seen in yellow t-shirt is my good friend Nagaraj sir. Welcome, sir. And thanks for making this possible, and thanks for keeping you a little waited. That's how the doctors work. That's how the academics also go for us. And thanks for waiting patiently for half an hour or so. And before Shivamani joins, you would like to say a few words, Nagaraj sir, then as he's joining. He joined before, he left again to come back, Shivamani, because he doesn't understand cardiology. So, but he promised again he's joining back. Please, before he joins, I think, sir, Nagaraj sir, you can speak few words.
Dr. Srinivas, we would have allowed some refreshments too.
They are getting, if you go to PVR, you would have got it. we are because faculty were stuck in Zoom programs, we don't have anything, unfortunately. Can you unmute Nagaraj sir? Actually, he went to the PVR theatre to enjoy the music along with me. So I am stuck in the office. I'll go and join him after this introduction is over.
Sir, and, I think he's facing some internet issues. So
okay, I think no problem. If at least Shivamani can join and talk. Did you call him again? Yeah, as he's joining, sir, if you want to say any final words of conclusion, Dr. Kevin Roni.
Oh no, thank you, Dr. Srinivas, for this wonderful time. And I think there was a little bit discussion that was happening on the chat box, and Mahesh asked that question to us, whether after doing imaging for some time, whether you really develop a sort of insight into the stent sizing and length, and whether you really require imaging in all cases. So I did reply back to him saying that I do not agree with the so-called OCT eyes. At least I haven't got it in spite of 6 years of OCT and 20 years of IVIS. So I did ask Dr. Kevin for his comments too, and I think it's very revealing what Kevin said. He said, also I have shown on OCT. See, I had the same thought. I've been imaging for a while. I've retrained my eye. I'm better at sizing than I used to be. Then I saw my own personal light lab data. What I learned is angio is a blunt tool. 70% change in size or length by either a 0.25 size or a 5 mm length. That's really a good data, Dr. Kevin. What do you say?
Yeah, the other thing about it is, we're going to look at this in light lab because there's a smattering of older people like me that have been doing OCT since it was approved in the US, and then brand new users. And so we hope to look across that to see if there's differences in operator experience in terms of how it changes decision making. That's one of the ongoing analyses. But I'm probably, other than Haram Becerra, I think within Light Lab, I probably had the second or third most OCT experience of all the investigators. So one of two things are the conclusion. Either I never learned how to read an angiogram in fellowship, or an angiogram is a really bad way to size the vessel. And that's why I let that other anecdote in the chat. We run a very well-attended complex PCI course with 50 interventionalists every time we run it quarterly. And I have one OCT training of a proximal LED where I poll the audience and have them choose their stent size, diameter, and length. And only one person to date of 250 has chosen the right stent size and the right post dilation. And we've seen this. As the arteries get bigger, it's harder to size them based on the angio. I think most people can figure a 225 artery within reason if you're just going to do the angiographically. And the hazard there is less. As we start talking about the proximal LED where it really matters, I don't guess anymore. I know with certainty and do the best thing for my patient, which is to use imaging to guide what I'm going to do.
Thank you, Kevin, for your comments. Welcome, Shivamani Garu. We had waited.
Hello.
So in the time we again had some discussion. Sorry for that. Welcome and namaste, sir. And
I say hello to everyone, all the doctors, all the angels, and it was awesome, and I hope you enjoyed our show. And I wish everyone and do the best work for everyone. And nice meeting you all.
Thank you, sir. Thanks for joining.
Thank you, sir. Thank you very much
for joining, for
yes,
playing.
Thank you
for
everyone.
Srinivas Kumarji for this wonderful opportunity. And Shivamani Anna is a very big legend in drums playing. He's a world famous drummer, and we are very happy to be associated with him, and we are very happy to be a part of this conference. Thank you so much, Shivamani Anna and Srinivas.
Thank you very
Kumarji.
much.
Thank you.
Thank you.
Kevin,
Be safe.
Dr. Kevin, sir, we will invite Shivamani sir to US also.
I love that. I'm excited.
Yeah? Okay. Hope this COVID goes and we could invite Shivamani to US.
We will.
Okay.
We will.
Thank you.
We and
sir.
Nagaraj Garu will come and play. Thank you very much.
Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
All the best.
Thank you, Anna. Thank you.
Yeah, please.
Thank you, Srinivas.
Right, thank you. So now you start the program.
A very, very good evening and namaskar to all the cardiologists attending this TCT India South Asia 2021 conference. A special thanks to Dr. A. Srinivas Kumar, founder, director, FACTS Foundation, and organizer of this conference. Tonight we have a very, very, very unique band performing for you, led by none other than the legendary Shivamani on drums. This name definitely doesn't need any introduction for you. A phenomenal drums player who is a household name throughout the world, not only in India, across the globe. We have Shivamani on drums. And moving on, I would like to call upon a prodigy flute player and an award-winning composer, Nagaraju Thaluri from Hyderabad. His audiences include the elite gatherings like Prince Charles of England, APJ Abdul Kalam sir, and Vajpayee sir. Please put your hands together and invite Nagaraju Thaluri on float. Thank you. We have one more prodigy on case. He is Karthik Devraj, a very, very bright star, not only in India, across the globe, making his own mark nowadays. This young talent has performed at United Nations Organization along with ARR and also at the Sydney Opera House along with the ARR. Please put your hands together, invite Karthik Devraj on case. Thank you. Hope you all enjoy this evening. Thank you so much. This is yours truly, Mani Nagaraj Thaluri will be joining a few pieces on vocals. Thank you.
வாழ்க வையகம் வாழ்க வளமுடன் வணக்கம் நமஸ்தே நமஸ்கார சஸ்ரீகால் அஸ்ஸலாமு அலைக்கும் praise the Lord. TCT India South Asia 2021 conference. I wish everyone all the best. Enjoy the concert. I have to thank Nagaraj Garu to bringing us this band together. Enjoy it. Your drums, Shivamani.
da dum, da dig da da do, da di da dum, da dig da dum, da dig da go, 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 da.